We will now begin session 1. Session 1 will be chaired by Dr. George Moti Justin, HOD Pulmonary Medicine, Medical Trust Hospital, Kochi, and Dr. Aziz KS, Consultant Pulmonary Medicine, Apollo Adlux Hospital, Angamali. Apparently, Dr. Shahjahan was not able to join the session due to some personal reasons. I invite the chairpersons onto the dais.
Good morning, dear friends. It's a great pleasure to be here. Thank you. I'd like to first express my gratitude to Dr. Hari, Dr. Mujeeb, and the team from Lakeshore who have organized this particular CME. And we all know, as Dr. Mohan Mathew has said, that sleep is a very important aspect of our human existence, and there are a lot of questions that are coming up regarding sleep, and it's still in an evolutionary phase that we're going through, that we are still maybe at the very preliminary junctures of advancement in sleep medicine. Today, the first topic that we're going to discuss would be the advantages and disadvantages of home-based sleep study versus the conventional sleep study in a proper sleep lab. To elaborate on this session, I would request Dr. Hari Lakshman. Over to you, Dr. Hari.
Thank you, chairpersons, Dr. George Moti, Dr. Aziz, who are my good friends also, for for the kind words of introduction. It's a very often debated and much argued topic, and you often hear this in most of the conferences, but still the arguments and debates persist as to whether you have to go for an in-lab polysomnography or a home sleep study. Both have their own advantages and disadvantages. For some group of patients, one set of study may be helpful. For other set of patients, the other type of study will be helpful. So in the coming 10 or 15 minutes, we will be just going through the different types of sleep studies, and we will try to see in which group of patients which study will be suited. So there are different terminologies when you read the literature that you come across, like portable sleep monitoring, home sleep apnea testing or HSAT, home sleep study. So these are often used interchangeably. There are slight differences between these. The home sleep apnea testing and home sleep study almost are the same, whereas portable sleep monitoring is different, slightly different from HSAT. That means all portable sleep monitoring need not be home sleep studies. You can do portable sleep monitoring in hospital also. So we will just see a few scenarios which you often come across in your clinical practice. A 36-year-old female with a obese, with a BMI of 38, who is having excessive daytime sleepiness, but snoring is only mild, and other typical symptoms of sleep apnea not much, like witnessed apneas, nocturnal choking. So what would be the ideal type of sleep study for her? Then we'll be discussing this in later. We will first see the scenarios. The second scenario is that of a 48-year-old male diabetic from UAE. He's on a short visit to Kerala, and he has typical OSA symptoms, and he's only having a short time here in Kerala, and he wants to get his symptoms evaluated. So what would be the type of sleep study that would be ideal for him? Another scenario is a 76-year-old male with multiple comorbidities like CAD, LV dysfunction, stroke, diabetic, and he was referred by cardiologist for sleep study. Again, what would be the ideal one for him? And another scenario, a 38-year-old lady, obese. He is posted for a bariatric surgery the next day. So he was asked for a pulmonology fitness. She also has typical OSA symptoms. So these are all scenarios which I'm sure you will be coming across in your routine practice. So before going to the answers, we will just discuss about the different types of sleep studies. As you all know, the gold standard is polysomnography, where all the sleep as well as respiratory channels are being recorded, which include EEG, EOG, and EMG for recording the sleep stages. And the respiratory parameters are measured using the nasal airflow saturation. Then the cardiac activity is monitored by ECG, and the body position as well as chest and abdomen excursion are monitored by piezoelectric belts. Now, the ASM has divided the polysomnography into different types or different levels. Basically, there are 4 levels. The type 1 is full attended polysomnography with all the channels described earlier, and that is done in a laboratory setting, and it is monitored by a sleep technician. So that is the gold standard. Type 2 is full unattended polysomnography. That is, it has all the channels, but it is not attended. So a sleep technician will connect all the leads, but he will not be sitting with the patient throughout the night. Type 3 is limited channels. There is 4 to 7 channels. The sleep channels will not be there. Only the respiratory channels and may plus or minus the effort channels will be there. And type 4 is the least one of all. Only a very limited channel. 1 or 2 channels will be there, usually oximetry and one of the other parameters. So this is in decreasing order of accuracy. The type 1 will be the most accurate, as well whereas type 4 will be the least accurate. So this is a type 1 where you can see you have all the EEG channels attached to his forehead and the EMG channels over his chin. Then you have the respiratory channels over his nose. Then you have the abdominal excursion and the body position sensor attached to his chest and abdomen, and you have the oximetry probe over his finger. So this is the type 1. The channels are same in type 2 also. In type 3, as you can see, the EEG channels are not there. Only the respiratory channels as well as the abdominal channels are there. So next comes the question is home sleep study the same as type 3? Because many feel that if you say it is home sleep study, then it will be a type 3 or type 4. There won't be any EEG. So for that, we will just look into what are the portable sleep monitoring systems that are available in the market. These are the different portable monitoring systems that are at present available in India. One is from the ResMed by the term Apnea Link. They are mostly type 3. Then you have the Philips Respironics. They also are type 3. Then you have a newer form of portable monitoring system, which is the peripheral arterial tonometry. This is the peripheral arterial tonometry, where this measures the sympathetic arterial tone of blood vessels, peripheral blood vessels. So this we will come to it later. Now there is a categorization known as Cooper categorization for easy understanding of the different channels available in different sleep studies. This Cooper stands for S for sleep, C for it's a mnemonic. You can easily remember the channels with this. S for sleep, C for cardiovascular, O for oximetry, P for position, E for effort, and R for respiratory. So accordingly, the different channels are being categorized from different numbers. Number one represents the highest accuracy. For example, if you take the sleep, S1 is by sleep by EEG channels with EOG and chin EMG channels. That is a full, all the full leads will be there. C1 means more than one ECG leads, and it can derive events also like arrhythmias. O1 means oximetry with finger or ear with recommended sampling. The standard sampling technique will be applied. And P1, the position is by video or visual position measurement. Effort will be with using 2 respiratory induction plethysmography belts, and respiratory by nasal pressure and thermal device both. So the first S1, C1, O1, P1, all the first one, number 1 denotes all the highest accuracy measurements. Then if you go down, S1, S2, S3, S4, the accuracy, the channels become lesser and lesser. For example, S2, sleep is by less than 3 EEG channels, and EOG and EMG are optional. S3, it's just a sleep surrogate, maybe like actigraphy, and S4, some other alternate sleep measuring parameters will be there. Similarly, for cardiovascular, oximetry, and all are there. So these are the different devices available in India as well as abroad, and their categorization by Scopper category, of which what we have here is the apnea link by the ResMed and Embletta. And if you see the Scopper system, in apnea link you don't have the sleep channel, sleep is 0, and cardiac is 4, you have only 1 ECG channel. Oximetry is 1x, 1x means this is 1x for oximetry, that is finger or ear probe without the recommended sampling. So you have the probe, but the sampling technique is not as per the recommendation. Then this was in 2009, but the latest versions have the position. So position, we can keep it as 1 for the present, sorry, not position, the effort. They don't have the position sensors. Position is still 0. The effort is 1 in the present versions of apnea link, and respiratory is 2. Similarly, for Embletta, the sleep is 0, cardiac is 4, again not very accurate, but at least some cardiac channels are there. Oximetry again 1x, position is 2, and effort is 1, and respiratory also is there. So as you can see, there are some other type of devices where you have even the sleep channels also there. So when you get a device, you can try to categorize into which of these categories it come. Accordingly, you can predict the accuracy of the device. So as you can see, the home sleep study is not always type 3. It can be type 2 also, because we have now devices available which have EEG channels, which are portable and which can be applied at home. But it can never be type 1, because in home nobody can sit throughout the night with a patient unless your bed partner is a sleep technician. However, for the ease or for the comfort, for the ease of purpose, or for comfort, for the purpose of comfort, most of the home sleep studies are done by type 3 monitors. Type 2 are relatively not widely available. And as said earlier, type 1 is always the gold standard for OSA diagnosis. So why we should go for a home sleep apnea testing? So the main problem with in-lab polysomnography is, of course, the cost, because it will incur higher cost, including the hospital room bills. Then since it has all the full channels, the sleep technician will be there, so the cost naturally will be higher. Another important aspect is limited access to in-lab testing, because not all hospitals, especially in periphery, you don't have the full-fledged sleep lab. And as you have more number of OSA cases, all may not be able to come to the hospital, or the sleep lab will be full and the booking will be already full. So if you have only a very short period of time, it will be difficult for you to get an appointment in lab polysomnography, and naturally the long waiting period. So the merits of home sleep apnea testing is it is more acceptable to patient, because many a times you might have heard the feedback from patients that all the EEG channels, it's very cumbersome and it affects my sleep. Then more comfort, of course, because of the limited channels. And you can get the test done early, because it can be done at your home or even in any room. It can be done, and the devices are also freely available. So even if you order a sleep study, it can be done either the same day or the next day. And naturally the cost is also less. But having said that, the home sleep apnea testing is not without limitations. The first and foremost limitation will be that you cannot determine the sleep status, especially if it is a type 3 or a lower device. Hence, if a patient has not slept well, there is no means to assess whether that the patient has entered into the deeper sleep stages or not in the portable monitoring system type 3 or lower. So that is one aspect. So if the sleep study with a portable monitoring system turns out to be negative, you can't be sure that you can't exclude obstructive sleep apnea, because if it were due to lack of sleep, there is no way to assess that. Then you can get the measurement error, because it cannot differentiate a sleep time. That is, the ideal recording time should be the sleep time, but the technician would have connected the leads much earlier, and the patient would have gone for sleep maybe 3 or 4 hours later only, but the recording will start even before that. So that can dilute the data. Then there is another entity known as a REM-induced OSA, where the sleep apnea occurs only during the REM. So if you do the sleep study, that may be the AHI may not be that high, but most of the AHIs will be concentrated during the rapid eye movement of the sleep. So that will be missed in the type 3 or lower, the portable systems. And there are more chance for technical errors. Example, if the nasal airflow lead or any of the other leads get dislodged, there is no means to verify that, because the technician is not there, so it is unmonitored. And another disadvantage is simultaneous PAP therapy cannot be applied because it is not validated for PAP titration. So these are the various limitations for home sleep apnea testing. So what are the criteria for portable monitoring? At a minimum, it should record sorry, airflow, respiratory effort, and oxygenation. These are the minimum parameters that should be recorded. PM device must allow for the display of raw data, and if the technician wants to cross-check the data, it should have the provision for rechecking. And always before subjecting a person for a portable sleep study, we need to apprise them that if this study is negative and the patient has symptoms, then probably they may have to undergo for an level 1 in-lab polysomnography. So portable monitoring, as per the American Association of Sleep Medicine position statement, the portable monitoring can be used as an alternative to polysomnography in selected situations. So these are the situations. One is for the diagnosis of OSA in high pretest probability of moderate to severe OSA. So if the symptoms are not very great, then it's always better to go for an in-lab polysomnography. For the diagnosis of OSA in patients for whom in-lab polysomnography is not possible due to various reasons, like immobility, or because of safety if the patient is too sick, or because of critical illness which preclude them from doing the study in lab. For example, the patient may be in ICU due to some other medical illnesses. Then monitoring the response to non-CPAP treatments like dental appliances, for there also this can be used. It is not appropriate for, these are some of the conditions like significant comorbid medical conditions. Then most important is if the patient is suspected of having another sleep disorder, a non-OSA sleep disorder, then of course you need to go for an in-lab polysomnography. For general screening of asymptomatic population, again it is not recommended because the pretest probability becomes very low. So the negativity cannot be taken as true negatives. And for split night studies also, always in-lab polysomnography is recommended. So if you are planning for a split night polysomnography, go for a level 1 itself. So when you apply for when you order for a portable sleep study, you can keep a checklist like this: whether the patient comes under a high pretest probability, no other sleep disorders are suspected, no possibility of complex sleep apneas, no other confounding comorbidities like LV dysfunction, neurological diseases, and you are not planning split night studies. And always the need for a follow-up type 1 study to be informed to the patients prior if portable study becomes inconclusive. So that also has to be apprised. So this was the peripheral arterial tonometry which was mentioned before. So this determines the peripheral arterial vascular tone using a plethysmographic method, and it is modulated by a sympathetic activity, peripheral blood pressure, and the peripheral resistance of the vessels. So what it basically does is, when you have an upper airway obstruction, there is a rapid change in sympathetic tone and activity. So that can result in two things. One is arousal and the other in change in vascular tone. So the change in vascular tone is being detected by the peripheral arterial tonometry, and that is correlated with pulse oximetry, whether the change in vascular tone coincides with the desaturation events, and it applies an automated algorithm to calculate the AHIs. And this was one meta-analysis which looked into the accuracy of peripheral arterial tonometry published in JAMA, and they concluded that the respiratory indexes calculated using pad-based devices positively correlated with those calculated from the scoring of PSG. We had a demonstration previously when I was in Amrita, so that also was reasonably performed well. So now coming to the scenario, the first scenario, a 36-year-old obese female with excessive daytime sleepiness, but the pretest probability of OSA is not very great. So probably there can be other causes of excessive daytime sleepiness like obesity, hypoventilation, or maybe some other reasons. So ideally type 1 sleep, since the pretest probability is less, type 1 sleep study would be ideal for her. And the next scenario, again, the patient has all the typical symptoms of OSA. His ESS score is 11, and he has nocturnal choking, and he only has a short waiting period because he wants to go back to abroad shortly. So for him, a type 3 would be, or a type 3 or portable, whichever is the ideal one. And the scenario 3, of course, multiple comorbidities, CAD, LV dysfunction. So there is a probability that he can have a central sleep apnea also. So for him, type 1 sleep study always is the choice. And the last scenario, posted for bariatric surgery. You don't have much time. All the typical symptoms are there. So the pretest probability is high. So you can go for a portable monitoring. So the take-home message is, portable sleep study, if it is positive, you can roll in OSA. But if it is negative, and if the patient have all the symptoms, better to go for a, not better, you have to go for a type 1 or level 1 sleep study. Always, in-lab polysomnography is the gold standard for OSA diagnosis. However, due to certain limitations, the certain patient subgroups can be subjected for portable sleep study, which are, for example, if the waiting period is less expensive, less technical expertise, more comfortable for, because of these various reasons, for certain subgroups with high pretest probability of OSA, you can apply portable monitoring. Thanks.
Dr. Hari Lakshman has gone through all the aspects of this sleep studies, that whether it is portable done at home or the in-hospital detailed sleep study, that is level 1 study. And he has gone to through the merits and demerits of the different types of or different levels of sleep study. And he has also gone through the newer aspects of sleep study which is available now. I think the question answers we will discuss later after all 4 sessions. So we have a question answer session. That time we will discuss the questions. We'll go to the next session. This PSG interpretation, this is a systematic approach. So that will be dealt with Dr. Sourin Bhuniya, who is as additional professor pulmonary medicine and critical care at AIIMS Bhubaneswar. He has done his MBBS from Utkal University in 1998, and he has done an MD pulmonary medicine from again Utkal University. He has also MAMS, FCCP and FAPSR. And he is also assistant editor, the Journal of Association of Chest Physicians. So I welcome Dr. Sourin Bhuniya for the next talk.
Am I audible? And let me know if the screen is visible and if I'm audible. Then only I can.
Yeah, screen is visible and you are audible. Can you make the screen the full screen?
Yeah, sure.
Yes, sir. You can start now.
Thank you very much, sir. Thank you for that kind introduction. A very good morning to all of you. At the outset, I would like to thank Dr. Mujeeb and his entire team for inviting me to this wonderful CME. I must congratulate Dr. Mujeeb and his team for conducting this such a comprehensive CME on sleep medicine, and wish him all the best. So my job is to discuss regarding the interpretation of a PSG or a sleep study report, how to approach it systematically. I feel this is a very, very important topic because a lot of efforts go into the sleep studies. We spend sleepless nights, and the technician takes so much of efforts, and we take such a lot of time in preparing the report, and the patient spends such a huge amount of money for the sleep study. So until and unless we approach the report in a systematic way and interpret in the right perspective, then we are not doing justice to ourselves as well as to the patient. So the outline of my talk would be to discuss regarding the need for the systematic approach to interpret a PSG report. What is the need? Why do we need to approach systematically? As I had already said in my initial lines, that in order to do a proper justice to the patient, in order to make a proper treatment plan, the right treatment approach which is required for the patient. Also, we'll discuss the components of the sleep study report. What are the different components that constitutes a sleep study report one by one, and we will also discuss regarding certain variables that constitute a PSG report, the definitions of all the indexes that constitutes a PSG report, and finally how to analyze all the components to have a clear understanding of the PSG report. So the need is if we are not systematic in our approach, then probably we will be missing the real problem for which the patient has come to us. Frequently, we have seen patients coming with PSG reports. Nowadays, they are being done at home, and as we had seen in our previous talk, and the company people, they just for their own vested interest, they just pursue them to take a CPAP machine, and then the patient again comes back to us telling that there is persistence of symptoms, they are not getting relief of the symptoms. So these are the different reasons for which we need to look into the report more carefully, and we need to look at all the aspects in order to prevent a misdiagnosis, and so that we can approach the patient with the right kind of therapy. Also, the cost effectiveness, as I had said, it's a costly affair, especially in the corporate world. The patient has to give a fee for that. Then we should do justice for the patient. So there are some prerequisites for sleep study interpretation. The first and foremost is a thorough history and clinical examination. It's a must before interpretation of any PSG report. Until unless we examine the patient carefully, we see the Mallampati scoring, we examine the oral cavity, everything has to be done, and of course the proper drug history as well. Then we have to check the level of study as whether it's a level 1 study, it has been done in any sleep lab or a home study, because often, as we had just heard, the home sleep studies, they lack the respiratory. I mean, they lack the EEG channels, and so we have to interpret in that perspective. So whether it is an auto-generated report or a manually scored report, that also has got some implications. Then whether the patient has got any previous sleep reports or not, if they're available with the patient, they should be checked to see either the response to therapy or the progression of the disease, or how the patient is doing, whether the patient is regular with the therapy or not. Also, it should be an acceptable PSG. Minimum 4 hours of adequate flow and oximetric pressure should be there in order to interpret a particular PSG. It's very important that we seek the remarks from the sleep technician who was there with the patient throughout the night before interpreting any PSG, because the sleep technician often gives very important inputs, so that should be taken into consideration. It's very important that we take a proper drug history. What are the drugs the patient has been taking, especially whether the patient is on sleeping pills or not, benzodiazepines particularly. Is there any history of intake of caffeine, nicotine, or alcohol within 6 hours? That should be inquired. So if the patient has been on sleeping pill for a long time, rather dependent on benzodiazepines, then he or she should be allowed to consume the same on the night of the sleep study. Because if you deny the patient of the sleeping pill, then you may land up recording a sleep study where there is a very less amount of sleep, and the entire effort will be futile. So again, the assessment of comorbid illness, that is very important. Whether the patient has any associated COPD or any other cardiovascular illness, that has to be taken into account before going for the study interpretation. So now, what are the different components of a sleep study report? So this is how a typical just a second. So this is how a typical sleep report looks like usually. So first, we have got this patient information where everything is recorded about all the particulars of the patients are recorded, right from the age, height, weight. We calculate the BMI. Then the study indication, which is left blank here, that should not be. Then from there, unless we know what was the indication of the study, we cannot interpret in the right perspective. Then there is a column for the technical aspects, the technical details. We have an idea how many channels were used to do the sleep study, whether the EEG channels were there, EMG channels were there, which level of study it was. We can have an idea from the technical details in that column. We should see that. Then of course we have the column for the sleep architecture, the how much time the patient had spent in the bed, how much time the patient slept, then how much time the patient has spent in the different stages of sleep. Everything should be taken into account. Then there are the respiratory event summary, where which gives an idea about the AHI score, the apneas, number of apneas, hypopneas, whether the apneas were obstructive or they were central in character. Everything is given in the respiratory event summary, and also the respiratory events in relation to the position of the patient and different stages of the sleep. Then we have got the heart rate summary, whether the patient is having, we have to see whether the patient is having any arrhythmias or any bradyarrhythmias or tachyarrhythmias, that we have to see. Then the oximetry data, now oxygen desaturation, we have an idea from the oximetry data how much the patient is desaturating, and then of course the hypnogram, which is a graphical representation of the entire event, of all the events that spent in the sleep lab. Sorry. So coming to some variables in sleep summary, the first one is light of time. These are the terminologies we come across in a sleep report. So what is the light of time? So it's the time at the start of recording, it's an indicator of the beginning of the sleep data. So it is the time when the technician is ready with the equipment and all the leads are in proper place, and the recording is ready to be started, and then the lights are put off and patient is allowed to sleep. So that is the light of time. Light on time is the time at the end of the recording in the morning when patient has woken up and you want to end the study, that we have to mark as the light on time. Then there is a terminology called total recording time. The total duration in minutes from the light off to light on. That is the total data we have acquired during the period. That is the total recording time. Then there is the total sleep time. The total time spent in minutes in all the different stages of sleep. That is from sleep onset to sleep offset. That means how much time has the patient spent in the actual sleep time. Then there is a very important parameter called the sleep efficiency. The actual time sleep time out of the total time one spends in the bed. We divide the total sleep time by the total recording time, and then into 100, it's a percentage. Normally, it's 80 to 89%. That is taken as an acceptable cutoff time as a marker of good sleep efficiency. Now, one thing is very important here, that we should keep in mind that the light of time should be as far as possible near to the usual time of the patient's habit of going to bed. If the light of time, suppose we start the recording very early, suppose the patient has a habit of going to bed at 11 p.m. and we start the recording at 9 p.m. The patient might not be sleepy at that time, and the sleep latency will be very high, and the sleep efficiency will be spuriously very low. And similarly, if the light of time, we delay the light of time, suppose the patient has a habit of going to bed at 10 p.m. but we start at 11 p.m. then the patient will be already sleepy. So immediately patient will be falling asleep, and the sleep latency will decrease in that case. So sleep latency, as I was telling, the time lag from the light off until the patient enters into sleep, as confirmed by EEG in the first epoch scored as sleep. So sleep latency of more than 30 minutes is usually considered abnormal. That means the patient should fall asleep within the first 30 minutes. Then the other very important parameter is the REM latency, which should be taken into account always while interpreting the PSG reports. It is the time from sleep onset to the first epoch of REM sleep. It is usually 90 to 120 minutes, and it gradually, the REM sleep increases towards the morning, we all know. Then there is another terminology called wake after sleep onset, or WASO. So this is the wakefulness after sleep onset till the end of the recording. So it reflects the amount of time the patient is awake after he or she has fallen asleep, and it indirectly reflects the degree of sleep fragmentation. How many times, how much the sleep has been interrupted with different events that is leading to wakefulness in the middle of the sleep. Wake after sleep offset. This is the duration of wakefulness after a defined termination of sleep. Typically, it is seen in the elderly population, and it's possible indicator of depression. Usually, what happens in depression in elderly population, they go to fall asleep, and then they wake up after 2 to 3 hours of sleep, and they find it difficult again falling asleep. So that is wake after sleep onset. There are some indices in sleep summary. We all know AHI, the apnea hypopnea index. Then there is the respiratory disturbance index. The difference is that in the RDI, we take into account the RERAs. RERAs are nothing but the respiratory events which that doesn't exactly fit into the definition or criteria of apneas and hypopneas. They're considered as the RERAs. And then we have got the oxygen desaturation index, the average number of desaturation episodes. 4 or more percentage decrease from the average desaturation in the preceding 120 seconds and lasting for more than 10 seconds. So it is the number of episodes of desaturation per hour of sleep that gives us an idea how much degree of desaturation the patient is having. And of course, we have this arousal index, the number of arousals per hour of sleep. So these are the different important indices which should be taken into account while interpreting a sleep report. Now coming to the sleep architecture. So usually the normal time spent in the first stage of sleep is around 5%, and then in the second stage is around 50%. The most maximum time is spent in N2 stage of sleep. In N3, the deep sleep, we spend around 20% of time, and REM sleep is around 25% of time. So this is the normal architecture of sleep, and of course all these parameters we just discussed. So what are the deviations now? When we are interpreting a sleep report, if we find that the percentage of N1 sleep, the first sleep is increased, unduly increased, or it is depressed, then we have to interpret it in the right perspective. The percentage of N1 sleep is an estimate of the degree of sleep fragmentation. The more there is this disturbance, there is awakenings or arousals, the more the time the patient will be entering into N1 stage of sleep. So high percentage of N1 sleep results from frequent arousals caused by sleep disorders like sleep apnea, periodic limb movements, or snoring. Also, the environmental disturbances may also increase N1 sleep. Like if the atmosphere is not conducive for sleeping, that may also disturb. There can be noises around, so that can disturb and may increase the N1 sleep. Coming to the N2 sleep, a low percentage of N2 sleep may be due to sleep fragmentation, increased REM sleep, or a result of OSA related arousals. Increased N2 sleep may be noted in age-related changes in sleeping pattern, or may be a result of medication effect like benzodiazepines. So benzodiazepines are known to have increased the N2 sleep and decreased the N3 sleep. N3 or deep sleep, or in other words, the slow wave sleep that occurs more frequently in the first third of the night and begins to reduce during the second half of the night. The second half of the night, the REM sleep usually takes over. So high amount of N3 sleep is noted during rebound sleep, that is recovery sleep after sleep deprivation, initiations of nocturnal CPAP treatment, or treatment of periodic limb movement syndrome. Suppose a patient is deprived of sleep, has been traveling in the night, or maybe doing some night duties, is deprived of sleep, and suddenly then gets 1 or 2 days off, then the rebound sleep is bound to occur, and then the N3 amount increases in such cases. Or patients who are initiated on nocturnal CPAP treatment, suddenly they find that usually the patients typically describe it as they're sleeping, they're having that sleep of their life. They haven't slept soundly so well before. So in such cases also N3 sleep increases. Less N3 sleep is noted as a side effect of certain medications, including benzodiazepines, as I had told, tricyclic antidepressants and barbiturates, in addition to OSA-related arousals. Now coming to REM sleep. REM sleep is associated with more severe and prolonged apneas, hypopneas, and severe hypoxemia. That's why we pulmonologists are always concerned with this REM sleep. Certain sleep disorders, including sleep apneas, REM behavior, sleep disorder, and nightmares, they occur in REM sleep. We all know this. So there are certain medications. That's why this medication history is so important while assessing a case of sleep disorder breathing. Certain medications like amphetamines, barbiturates, tricyclic antidepressants, MAO inhibitors, anticholinergics, and even alcohol, they are known to suppress REM sleep. So higher amount of REM sleep is noticed during recovery sleep, following selective REM deprivation, discontinuation of REM suppression medication, and initiation of CPAP therapy. So we all know that alcohol induces sleep. The sleep latency decreases. The person falls asleep earlier, but has a very disturbed sleep throughout. There are many awakenings. It's not a deep sleep. Suppose a patient has got REM deprivation, habit of seen in young students, when before the exam they give the alarm and they wake up early in the morning to cover up their syllabus. But in the morning the REM deprivation is there, and after the exam when they get a chance to sleep, they have this higher amount of REM sleep during that period, or as discontinuation of REM suppressant medicine and initiation of CPAP therapy. So this is how the respiratory event summary page looks like in a sleep report. So we have to be very careful. It's not just that we look at the AHI level and just prescribe the CPAP machine. So we have to be very careful and see, as we can see here, the AHI is very high. This is the severe case of obstructive sleep apnea, definitely. But if we look carefully, we can see that there are some obstructive events as well as there are central apneas as well. So, and some mixed apneas are there as well. So we have to look for any causes. We have to analyze and we have to look for the causes for central apnea. So that will decide the treatment plan. We have to look for any cardiovascular morbidity, any heart failure. So that is the importance of looking at all the aspects. Now coming to the respiratory summary by body position, if we look here, in the supine position, most of the events are happening in the supine position, and also the AHI is high in the supine position. So it's in the supine position that the airways are compromised most, So we may have to plan for a positional therapy in such kind of patients. So the AHI is calculated in REM phase. So if we find that AHI calculated in REM phase is significant, if it is more than the total AHI, the severity of OSA should be escalated up. For example, if the total AHI is in the range of 12, and we find that in the REM phase the AHI is around 20. So then that means that the significant obstructions are taking place in the REM phase of the sleep, and so we should stamp it as a case of moderate OSA, not mild OSA. Similarly, if the PSG shows an AHI of less than 5, we should not just rule it out as a normal PSG, but we have to look at the REM AHI as well. If the REM AHI is more than 5, then the sleep study should be considered as positive for OSA. Usually supine position compromises airway more than the lateral liquids position and should be noted down for positional therapy or PAP titration. Now coming to the cardiac events and the leg movements, we have to look for tachy or bradyarrhythmias during the sleep. As I had told, if the patient complains of chest pain or there is profuse sweating is noted during the sleep study, we have to look for the ECG changes to detect nocturnal angina. And the periodic leg movements, if they're more than 15 per hour, it's significant. And if the periodic leg movements are associated with arousals, it becomes even more significant. But one thing you have to keep in mind, the EMG should come from both the limbs, not only one limb. So that is very important. Now coming to the oximetry data, the usually significant oxygen desaturation is decrease in the oxygen saturation by 3 to 4% or more from the baseline value. Lowest SpO2 should be seen to understand the extent of compromise caused by OSA. And also the duration of hypoxemia is equally important as the extent of desaturations. So this is how the oximetry data looks like in the PSG report usually. So here we can see the average oxygen during non-REM and REM, more or less same. But the minimum oxygen value is 61%. That means the saturation is dropping to 16. That's the minimum recorded saturation level. And the oxygen desaturation index per hour is 57. There is significant desaturations per hour. So we have to see how much desaturation. That gives an idea of the severity of the obstruction that is taking place during the night while during sleep. Now coming to the hypnogram, indeed a picture is indeed worth 1,000 words. The picture, the hypnogram is gives an information of the entire sleep study, allows the interpreter to get an overview of the entire night. It shows the relationship between the sleep stages, the body position, abnormal events that takes place during the stages, limb movements, arousals, and treatment levels. So this hypnogram is also a very excellent tool for sharing information with the patients, helping them to understand the pathology and the results of the therapy. When we counsel the patient regarding the therapy or the treatment plan that is designed for the particular patient, it becomes very important to explain to them what is happening with the patient. So if we just show them the hypnogram, then it becomes easier for them to understand the pathology, and so they can understand better, and there is a high chance of acceptance of the treatment that we are prescribing. So this is how a hypnogram looks like. It's very informative. We have got all the informations in one single graphical picture. So here we have got all the stages of sleep. We can see how much time the patient has spent in each stage. This is N1, N2. This is REM. We can hardly see any REM sleep here. And then the heart rate. We can see when the heart rate shoots up. The oxygen desaturations. We can see how much, how frequently there are oxygen desaturations here. Then these are the central apneic episodes. These are the obstructive apneic episodes. These are the mixed apneic episodes, and these are the hypopneas. There are so many hypopneas there we can see, and we can even correlate with the events with the stage of the sleep from this. And also we can see the body positions, whether the patient was in supine position, left lateral position. As per the body positions, we can correlate with the different respiratory events. This is another example of a hypnogram. If we look carefully, this is a hypnogram of a split night study. So,
Excuse me, sir.
yes.
We are exceeding time. Can you please wind up in 5 minutes or so?
Yes. Okay. Okay.
Thank you, sir.
Okay. Just give me 1 or 2 minutes. I will just wind it up. So here we can see a split night study. The second half, we can see there are the less number of events because of CPAP therapy, and we can see more REM sleep during the second half of the study. So I'll just clip this in the interest of time. So there is one important thing we should consider, that is called the first night effect. When the patient cannot sleep well in the sleep lab and has a different sleeping pattern than usual, can increase both advanced sleep and REM latency. So we should also take this into consideration when we are interpreting a sleep. And it is very important, as I told, to take the comments of the technologist, because the technologist can give in important inputs regarding some important observations during the sleep study. So to summarize what we have discussed so far, interpretation of the results of PhD should always be done in the background of a comprehensive sleep and drug history and physical examination. And in-lab PhD is the gold standard, as we have already heard in the previous lecture, and provides greater details regarding EEG, EMG to give more complete evaluation of the sleep disorders. AHI is often underestimated in the home sleep studies. In a patient with high pretest probability of sleep disorder breathing, a negative test may not rule out the disease. We have to be very careful in looking at all the aspects. Extent of desaturation, duration of apneas, REM sleep, and amount of sleep in supine position should all be given due importance. And comments from the sleep technologists and their assessment notes should be taken into consideration while interpreting the sleep studies. And last but not least, systemic approach to interpreting sleep studies, taking into account all its components, is the key to clear understanding of the PhD report. And this in turn facilitates a better treatment plan for the patient. Thank you for your patient.
Thank you, Dr. Sourin, for extensively elaborating on this particular very important aspect of sleep. In spite of the limited time, you've done real justice to it. Questions will be encouraged at the end of this particular session. Over to the next topic. And this particular topic we often come across because we have a lot of patients with obesity hypoventilation syndrome, and we often are in confusion as to what kind of therapy is best for the patient. And so the role of CPAP versus the role of NIV will be discussed by Dr. Mujeeb Rahman, who is a consultant in sleep medicine in Lakeshore Hospital. Dr. Mujeeb has done his MBBS from Thrissur Medical College and MD Respiratory Medicine from BHU, Banaras Hindu University, and later on has done his DM from AIIMS Bhubaneswar. Over to Dr. Mujeeb.
Thank you, sir. Welcome. So I'm just going straight to the topic. So I'm discussing about important and very common entity, obesity hypoventilation syndrome, and the role of CPAP versus the NIV, or BiPAP versus AVAPs. So all of you know that the definition of obesity hyperventilation has 4 criteria: the presence of obesity, which is having a BMI criteria more than 30, sleep disordered breathing, that is AHI more than 5, daytime hypercapnia, that is awake resting PCO2 of more than 45, and rule out other causes of hypoventilation like hypothyroidism, neurological causes, or other. So approximately 90% of patients with obesity hyperventilation syndrome will have an associated OSA if you take the AHA criteria of more than 5. But nearly 50% of the OHS patient will also have severe OSA, that is an AHA of more than 30. So that is actually the majority of patients will have a concomitant severe OSA. So if you look at the criteria, that is the nocturnal hyperventilation is defined by AISM with 2 criteria, that is the PCO2 criteria, more than 55 for more than 10 minutes in the sleep time, or an increase in PCO2 of more than 10 compared to an awake supine value to a greater than 50 for a more than 10 minutes during sleep. So if you look at the multiple studies and the literature, the prevalence of OHS is around 8 to 20% in patients who are referred for sleep studies, that is the data from sleep lab. And if you also look at the obesity index or the BMI index, the prevalence also changes. There is a 5% prevalence between BMI of 30 to 35, 10% between 35 to 40, and 20% if you consider BMI of more than 40. The prevalence is almost similar between males and women, and now we have a lot of obesity epidemic, and even after the COVID, the obesity all over the world is increasing, and the incidence or the prevalence of OHS will also likely to increase. So the clinical presentation, as I already discussed, majority of the patient will present exactly having a similar sleep disorder symptom like excessive sleepiness, loud snoring, choking sensation, apneic episodes, all the similar to, but the difference is patients can also present as a acute on chronic hypercapnic respiratory failure. So one study which is done in US is found 8% of all the medical ICUs were OHS patient is presented with acute hypercapnic, means an acute or a chronic hypercapnic respiratory failure. And the interesting point is that around 75% of these patients are actually misdiagnosed and treated as other causes of type 2 respiratory failure like COPD. The patients of OHS are more likely to report more amount of dyspnea and more amount of features of cor pulmonale because of the hypoxia and hypercapnia and the influence on the pulmonary circulations. So that is an important difference. So we all know that the Pickwickian paper, which is the Alden describe, and the one character is having exactly similar symptoms and signs of OHS, and that's why this syndrome is also called Pickwick syndrome. So if you look at the largest literature review of 15 studies, an aggregate of 757 patients, the profile of OHS patients will look like almost equal incidence in male and female, and a high BMI and a high neck circumference, pH between 7.34 to 7.4, and high PCO2 in the ABG, high amount of serum bicarbonate, because as a compensation to renal compensation to the elevated CO2, there will be elevated bicarbonate. And AHI is also around between the 20 to 100, an average of 66. So serum bicarbonate is an important element. If you look at the serum bicarbonate, less than 27 value is having a high negative predictive value. That is more than 97 is the negative predictive value. That means if there is less than 27, you can exclude if the clinical probability is low for the OHS. But if it is more than 27, we have to also consider other causes of elevated bicarbonate like renal, cardio, and other drug history also has to be evaluated. So there are a lot of pathophysiological changes. We have to understand this, for that the next important element of treatment will also depends on this. So there are a lot of obesity changes. The first one I would So because of extensive or morbid obesity, we have a reduction in functional residual capacity, FRC, and also basal lactases. And there is a high amount of fat deposition in the central area. This will actually move the diaphragm upwards, and that will affect the diaphragm mobility during sleep. There is a more amount of premature airway closure due to intrinsic PEEP that will cause gas trapping due to premature premature airway closure. All these together called altered VQ mismatch and increased work of breathing. So there is increased work of breathing, not only because of the obesity and the abdominal fat and also the upper airway resistance. There is a diaphragmatic compliance is also less. So not all can maintain adequate ventilation, because the ventilation center, the respiratory centers are also affected because of extensive obesity. We have leptin resistance. Leptin is also an important stimulant for respiration, where leptin resistance causes a delayed or a less response from the CNS, so that will also cause a hypoventilation. So that's why not all patients of OHS is having a hypercapnia. Some of the patients will able to manage this, but not all patients of obstructive sleep apnea will land in hypercapnia. Some of them will able to manage this minute ventilation. And excessive fat deposition in the upper airway will also have a cause premature or early frequent upper airway closures, significant narrowing. This will cause long-standing apneas and hypopneas also. So this is an just explanation again. So if you look at the pulmonary function and other lab parameters, this is I explained there is two phenotypes. This is what I want to explain in the next couple of minutes. There is patient with have increased respiratory effort, there is increased work of breathing, there is disturbed sleep, there is reduced muscle endurance, and there is increased leptin resistance. So this can cause a normal response to the ventilation, that patients can have a eucapnia in this during sleep, but it can also create a low respiratory muscle endurance, a low response from the center, a low respiratory drive that can also cause a low ventilation, which can lead to hypercapnia also. So this is the diagnostic criteria, and there is one literature showing a severity criteria also, and where the severe one, the type or the stage 4 is sustained hypercapnia during a week with an elevated bicarbonate and with cardiovascular complications are present. And the type stage 3 means sustained hypercapnia and more than 27 bicarbonate, but complications like cardiovascular and stroke and other histories are absent. And the mild form is intermittent hypercapnia, which is fully recovered during sleep, and the bicarbonate is less than 27, and cardiometabolic complications are absent. And the other one is intermittent hypercapnia without full recovery, that is the type 2 or stage 2, where bicarbonate is more than 27 and cardiometabolic complications are absent. So these are the treatment options. All the patients should undergo weight loss regimen with the diet, exercise, and the rehab programs, and the treatment options of the PAP, the CPAP, and NIV that we will be discussed in detail. So I already said around 90 or 80 to 90% of the patient will have a sleep apnea associated with OHS, but 70 or more than 70% will have a severe OSA. So only nearly 10% of the OHS patient will have an OSA which is having a non-obstructive sleep hypoventilation. That means less amount of sleep apnea per se. So sleep PAP is also a modality where it can improve the gas exchange by improving the FRC, and the basal ventilation is also improved, and improvement is also related to the CPAP compliance. So the patients with on CPAP can also clear CO2, but the relation is also related to the CPAP compliance. And leptin resistance is one of the important pathophysiological thing in OHS, and leptin resistance used to reduce once patients use CPAP, and it may improve the or augment the ventilation also. So coming into the first literature, comparison of CPAP with BiPAP in patients with OHS without a severe nocturnal desaturation. The aim of the study was to determine one form of the PAP therapy is better than the other or not. It's a prospective randomized study, was performed in patients with obesity hypoventilation referred for respiratory failure. The primary outcome was change in daytime CO2 level, and the secondary measures were daytime sleepiness, quality of life, their compliance and treatment, and psychomotor vigilance. There was 36 patients in this, and equal division to CPAP and BiPAP. So we can see the primary outcome was CO2, secondary outcome was sleepiness, quality of life, compliance to the treatment, and other thing. Their baseline characters are more or less same, and the improvement, if you look at the improvement in the CO2, improvement in the SpO2, bicarbonate, there is no statistical significant difference, even though the BiPAP reduces PCO2 little bit more than the CPAP. But the statistical overall significance is not achieved for this. So overall take-home message from this study is that both CPAP and BiPAP can equally improve the oxygenation, CO2, and also equally improve the sleepiness and the daytime symptoms. But this study has limitation that it has excluded patients with severe hypoxia or patients with which are prone to have hypercapnia during sleep. So the next important landmark study is the Pickwick study, which is a multi-center randomized control trial where people with OHS have divided the patients into 3 groups. That is, one is an NIV group, one is a CPAP group, another one is a lifestyle modification, the control group. And a polysomnography was done at the baseline and also in the 2-month follow-up. So this was the interventions. One is the control group with the dietary and lifestyle modification, the CPAP group where lifestyle plus a fixed CPAP was given, and the NIV was also given. The NIV BiPAP ST mode with the EPAP between 4 and 8 and IPAP between 18 to 22, respiratory rate between 12 to 15, and a targeted tidal volume of 5 to 6 ml per actual body weight is set. So you can see around NIV was 71 patients, CPAP around 80 patients, the control was 70 patients, the baseline characters were more or less same. And if you look at the improvement, the baseline values of PCO2, bicarb and pH and the NIV improvement, there is definitely slightly better PCO2 clearance with NIV when compared to the control and the CPAP. But we will look at the statistical significance in the next slide, and the bicarbonate is also better cleared in the NIV. That is the only difference. But if you look at the adjusted significance after adjusting the CPAP compliance and after adjusting the weight and other parameter, when looking at the CPAP versus control, the statistical there is significant change in PCO2 and bicarb when you compare the patients with CPAP versus the control group where there is no modality. And also similarly, the adjusted importance is more when you look at the NIV versus control. The NIV versus control has the maximum statistically significant difference in clearance of PCO2. But if you look at the NIV versus CPAP, where there is no statistically different, significant difference in improvement of CO2, where there is a marginal improvement, but it is not statistically significant. And this improvement in PCO2 alone is, we may not able to extrapolate into the clinical benefit of that also. So that's why this study is also concluding that both NIV device or the CPAP and the BiPAP was done more or less equal job to reduce the PCO2 and bicarb. And the bicarb improved better in NIV and it is both NIV and CPAP improved the bicarb when compared to the control group. And the PCO2 and the sleep quality improve with NIV and CPAP treatment without a significant difference between the group. And the significant improvement was observed in most health-related quality index in both NIV and CPAP group. And FEV1 and 6-minute walk test is the only 2 parameter where NIV group was ahead of the CPAP group. So coming into the next trial where AVAPS or average volume assured ventilation was compared. So this is also an OHS group of patients where CPAP non-responders were admitted to the hospital, where they are initially prescribed BiPAP ST device and later they will be again re-evaluated at 6 weeks and they will be crossover to the AVAPS modality. So if you look at the improvement and from compared to the baseline variance, there is CPAP one group and there is one CPAP group here and one the BiPAP ST group here, one AVAPS group here. The entry N4 sleep is slightly more in the BiPAP ST group compared to the CPAP group, and the respiratory disturbance index, that is this one, is actually done better in BiPAP group compared to the AVAPS group because there is a frequent increase in peak pressures. So this increase in peak pressure may cause a disturbance to the patient, so there can be an increased arousals and the respiratory disturbance is slightly more in AVAPS group. But look at the PCO2 clearance. The better PCO2 clearance modality is the AVAPS group compared to the BiPAP and the CPAP group. But if you look at the peak inspiratory pressure which is happened during this study protocol, BiPAP ST group had a little bit lower peak pressures, and since AVAPS is a tidal volume targeted modality, it can have an increase in pressure during sleep. Considering the apnea and the obstruction, it may require an increase in pressures also. So there is an increased tidal volume when in patients is in AVAPS, and there is an increase in CO2 clearance, but actually the significance of this is almost similar when you look at the statistically. If you look, both are almost doing great job when in the real statistical comparison. And the performance of the patients with the SIRS summary or overall physical and psychological well-being is also more or less same between the ST and AVAPS group also. So coming into the summary, we have a large amount of literature, both the randomized control trial, the case series and other reports. Out of these, ATS and ERS summarizes that patients with OHS with severe apnea, that is AHI more than 30, first should be subjected for CPAP therapy, and we have to assess the improvement in CPAP in terms of their episode sleepiness, their improvement in blood gases, their symptoms, and if you look at the CPAP is maintaining a good job and they are good and doing well, we have to continue, and if there is no improvement, then we have to subject these patients for NIV. And also if the baseline itself, if the AHI is less than 30, the ATS ERS recommendation is to consider these patients for BiPAP as the first modality rather than subjecting CPAP. So CPAP is less effective if there is a great degree of initial respiratory failure, that is patient who is presenting initially itself as a acute hypercapnic or acute on a chronic hypercapnic respiratory failure, poor lung function, advanced age and less severe OSA. There is a clear-cut advantage of BiPAP over CPAP. So I already said around 8% of the patients can present with the acute and chronic respiratory failure. These patients, the first modality of treatment is again NIV, the BiPAP therapy. We have to adjust both EPAP and IPAP to attain and abolish the apneas and to retain a good amount of tidal volume, and oxygenation is the target, is between 88 to 92, can be attained with the adjustment of the FiO2. And we also has to look for the pneumonia, heart failure and other causes like PE and untreated OSA, the CPAP failure as other risk factors for the acute decompensation. So coming into the outcome, as a long-term outcome of acute hypercapnic respiratory failure of OHS, if you look at the largest literature of 1,162 patients, we have seen at the 3 month around mortality of 16% if the patient is not prescribed a PAP or discharged without a PAP, and if there is a PAP at the time of discharge, at 3 month mortality is only 2.3. So that indicates that PAP is having a very good mortality benefit at long-term follow-up basis in patients who present with acute hypercapnic or acute on chronic hypercapnic respiratory failure of OHS patient. So if you look at the similar profile, that most of the time it will be a misdiagnosed as acute respiratory failure due to COPD, but there is some clinical profile difference. The patients of type 2 COPD respiratory failure and combined to OHS, this is the largest study from the literature. They found that patients OHS were older, they were more females, and were less NIV failure in OHS patient. There was lower hospital mortality, that is a 6% versus 18%, and there is a higher 1 year survival in patients. So this is the graphs of this study. The initial graph showing probability of remaining free from hospital admissions is better in OHS compared to COPD, and also the survival of patients during follow-up at 1 year is also better in OHS compared to COPD. So if you look at the patients of obese COPD versus non-obese COPD, the obese COPD actually doing better because of their better BMI, better mass index and better respiratory muscle function. So that means there is considerable difference, even though the pathophysiology looks like acute type 2 respiratory failure on a background of chronic, but the long-term outcome of these two patients of COPD, which is OHS, is also different. So looking at the context of bariatric surgery, most of some patients may also require bariatric surgery, and their options of NIV, sometimes we can also wean off the NIV if the patients undergo sufficient weight loss. For a meaningful benefit, at least 25 to 30% of weight loss is recommended for OHS patient as per the literature. The majority of the patient will be going for laparoscopic sleeve gastrectomy or a Roux-en-Y gastric bypass or a biliopancreatic diversion with duodenal switch. The important two randomized control trial in this area where OHS patients were subjected into bariatric surgery, the 1 year follow-up, around 35% of the patients when compared to the non-intervention group where the laparoscopic gastric banding was done, 35 versus 13%. That means more number of patients when subjected to laparoscopic gastric banding had a PAP therapy can be discontinued at the time of 1 year. But of course we need to do follow-up. Of course we need to do follow-up PSG and to take decision, and also the cardiometabolic and the lab, the blood gases also has to be monitored. So this is the algorithm where patients when they are subjected to the bariatric surgery, we have initial role of screening, we have initial role of defining whether they have with a bicarbonate value and looking at the clinical profile. If the BMI is more than 30, of course most of the patient will have a high BMI, PCO2 of more than 45, and looking at the ABG, we will decide whether this patient fit into OHS. Then we have to do PSG and we have to give a PAP therapy before the surgery, and also after the surgery also most of the patients require PAP therapy until and unless they reaches a sufficient amount of weight loss. So they need a follow-up at 3 month and 6 month interval initially to assess the requirement of PAP and improvement in AHI. So that my take-home message is the nocturnal oxygenation and sleep quality improves significantly with both CPAP and NIV. The PCO2 improvement is actually even possible with CPAP, but it depends on the CPAP compliance. AHI more than 30, the initial sleep study itself is an indication to go in forward with bi-level or BiPAP support, and AHI less than 30, that is a non-obstructive hypoventilation type of OHS patient will actually better do with BiPAP in the initial modality. CPAP non-responder of course has to go a repeat evaluation and can be switched to an IV. Considerable weight loss is a weight loss of more than 25% that has to be attained in patients with OHS to have a meaningful physiological benefit. Thank you.
Thanks, Dr. Mujeeb, for that elaborate discussion on the various aspects of obesity hypoventilation syndrome. He has gone through the diagnosis, pathophysiology and management of obesity hypoventilation syndrome, and he has also dealt with the different modalities of treatment like CPAP, BiPAP and AVAPs, and also he has touched upon the role of bariatric surgery in the management of obesity hypoventilation syndrome.
Thank you.
Now we will go to the next session, the last talk of this session, that is the newer advances in the diagnosis and management of OSA by Dr. Sryma PB, Assistant Professor Pulmonary and Sleep Medicine, PSG Institute of Medical Sciences, Coimbatore. She has done her MBBS and MD in Internal Medicine from AIIMS Delhi, and also done the DM Pulmonary and Critical Care Medicine from AIIMS Delhi. And she also holds the European Diploma in Adult Respiratory Medicine. So I am inviting Dr. Sryma PB for the talk. Thank you.
Sorry about that. Excuse me. A very good morning to all of you. At the outset, I would like to thank VPS Lakeshore and the organizers, especially Dr. Mujeeb, who has put in so much effort to conduct a really relevant topic for the day. So somebody in the introduction speech told that the sleep medicine is a very neglected part. Patients always neglect it. But I feel even physicians are neglecting it, because last week only we had a rigid interventional pulmonology conference at Coimbatore. Majority of delegates were from Kerala. So I think it's very important for people like Dr. Mujeeb to, increase interest in sleep medicine. So sleep is not a waste of time. Sleep medicine is also not a waste of time, right? So with that, I think I will go on to the topic. So the topic which is given to me is, what is new in OSA diagnosis and management? So how do I decide what is new? Like, is it 5 years, 10 years? Where is my starting point? So what I decided is that I'll start from 2017. That is where we have the last guidelines on the diagnosis of OSA. Right, so the guidelines have not changed. So what we have is 2017 data, and I will be discussing what has come after the guidelines. So I'm not going to read out the snapshot, but yeah, everybody knows this. This is the 2017 guidelines. So Dr. Hari Lakshmanan has already introduced the first one to you already, thanks to him. So what I'm going to discuss first is WatchPat. So what is WatchPat and how is it different from a polysomnography? So with the picture itself, it's quite clear. On the left, you have a patient who's just sleeping with a different watch on. On the right side, you have the conventional level 1 polysomnography in which the patient is just covered in all senses. So basically, this PAT has a PAT signal, that is a peripheral arterial tonometry, an oxygen saturation, which is again measured by the finger probe, an actigraphy, which is the wrist actigraphy, and sometimes they have a snoring sensor, a body position sensor, and chest movement, which are all optional ones. So they just have this watch on and this sensor attached on the chest, which will check the body position. All right, so that is WatchPat. So as you've already been introduced, it measures the PAT signal. So once a patient is sleeping, what happens is the muscle tone reduces. But once there is a respiratory cessation, which is an apnea or hypopnea, what happens is there is a fight or flight response, a sympathetic activation, which causes digital arterial constriction. So this increases the tone of the digital arteries, which is recorded as an attenuation in the peripheral arterial tonometry signal. So with the software, it can even calculate the amount of sleep, the light sleep, deep sleep, so it can also stage sleep. So there is a lot of data, and the easiest thing is that the physician doesn't have to do anything. It's all automated. It's like a plug and play device, right? So the next day you get a full report. You don't even have, you cannot even review it. Like even if you want to review, you cannot change anything. It's fully automated. So how does WatchPat, what has come new in this WatchPat area in the last 5 years? So this is a recent publication which is a large study. I think this is the largest study on WatchPat yet. So what they did is 500 studies which were consecutively WatchPat plus polysomnography, and then they took out the data. So what they saw was that this is the report of the PAT study, which showed no OSA in a significant percentage, but out of them, a significant percentage did have mild and moderate OSA. So this is a pictorial representation. Let me help you understand what this means. So the red portion is the severe OSA, moderate and severe OSA by polysomnography, which is our gold standard. On the x-axis, we have the PAT diagnosis, that is the arterial tonometry. So here what it showed was that PAT showed no OSA in 7.2% of moderate and severe. PAT showed mild OSA in again 20%. So combined, it's about 25% misdiagnosis of moderate OSA basically. Severe were less when you come to the numbers. So basically what it shows is that if there is a negative or inconclusive PAT, it should be followed by a polysomnography in sleep in the sleep laboratory. So this is a study which we did at AIIMS New Delhi. Dr. Saurabh will also be joining us, and me and Dr. Tejas. So this was a study which we compared using WatchPat versus polysomnography in about 30 patients. What we found was that the AHI correlation was quite good. WatchPat tended to overestimate AHI, like it will show always higher. And it was that, like, again we showed the same thing, like mild to moderate. The sensitivity, the specificity was quite less. So it was overdiagnosing OSA in significant percentage of patients. So what if the patient says that they don't even want to wear a watch to diagnose sleep problems? So do we have something simpler than this? So what we have is an under mattress monitoring device. That is, the patient just has to lie down on a bed, and there are piezoelectric sensors kept under the mattress which will detect everything, the movement, respiratory movement. The sensors are so sensitive that it can even detect the heart rate. So that is called as a sleep tracker. It's an AI thing. So it makes every bed a smart bed. That's how they're advertising it. So what is the data on it? It's a very small study, but I felt it was interesting. So because the sleep medicine is all becoming full of gadgets. So what it showed was it was quite good in sleep staging. Like the first picture shows a polysomnography staging on the top and the sleep tracker staging. So those who have seen hypnograms before, this is the top part where the sleep stages are shown. That's quite good, looking good. But what about AHI? So it's actually, when you look at the data, the correlation seems to be quite good when you look at the graph. But when you actually see the data, you're seeing that a lot of events are getting missed. So the accuracy sensitivity is not that good, especially when the OSA is less severe. Then what about these things? Patients always come and ask us nowadays. They all have an iPhone which is tracking their sleep. So are they good? So the conclusion is that they're not so smart. They're smartphones, but the sleep tracking is not as good. So this study evaluated iPhone-based 4 smartphone applications. Again, the sleep staging was not good. Then we have watches. This is a Huawei GT2, which is available, I think. But then what I wanted to show is that about 25% of the studies, the signal was not good. So you are looking at inadequate data, incomplete data. So most of the time as a screening, so this is not for diagnosis, they used it for screening in general population, but their general population had significant OSA, like it was all 83% were diagnosed as OSA out of the 117. So the sensitivity is quite low, the negative predictive value is quite low. So in conclusion, all of this are together called as consumer sleep technology devices. These are used by consumers. These are not medical devices. But in the end, the conclusion right now is that they are not validated. They are not FDA approved. And so you can use them to discuss about sleep with your patients. Like you can have a discussion about their phone data. But no, not a diagnosis, not a screening. It's just for improving your patient interaction. That's it. So that is about the diagnosis. So what has changed in management of obstructive sleep apnea? So we all know the stages of diagnosing a sleep disorder, starting a patient on CPAP therapy. So there are different stages to it. First of all, we tell this to the patient, then they react to it. They might say yes, they might say no, then there will be problems with using the CPAP. Then finally, by the time they become a master of CPAP, most of them, the data shows up to 50% stop using CPAP. So how can we improve that? So there again we have technology coming in. Patient engagement tools. So these are basically cloud technologies for patient engagement, which I feel this is the most relevant part of the talk, because this data is good. Even though these are all non-randomized studies, when you go to the quality of studies, they're not good. But this is basically an app which is very creatively named Apnea. So it will measure 4 things. It will ask the patient to enter CPAP use, physical activity, diet, their weight every weekly. And I mean, this basically is what is called as Hawthorne effect. Like we all perform better when the boss is watching, right? So here the boss is yourself, the patient only self-evaluates, and that self-evaluation was found to improve the compliance. And it's actually a very good data. Like once you see the general data about CPAP compliance, it's about 4 hours. But here they actually got 1 hour more. Again, this is something by ResMed. This is the AirView machines with the MyAir app. So again, this app gives you a score, like you are scored every night. The machine is connected to the mobile is uploading everything into the cloud. The doctor can see the report, how much the patient is using. And so finally what they found was that this was again a non-randomized study, but it showed that with the patient engagement group, that is when you involve patient in their care by giving them a mark every day about their mask leakage, the CPAP duration, everything. So what it showed was that the device usage is significantly high, more than 6 hours. This is, everyone who's practicing know that this is very difficult to achieve. More than 6 hours of CPAP usage is almost impossible. What most of our patients do is they put on CPAP, when they wake up in the morning, they just keep it away. Okay, enough, doctor has told 4 hours, I've used 4 hours. So that's not, so what they found was that this app actually helped patients use the machine more. So another thing is a hybrid nasal mask. I'm not sure how many of you are using this machine, but this mask, but I mean, I have no conflicts of interest here, but I use it very frequently. I mean, even the data here, again, a non-randomized study, sorry about that, but this is all what we have. But so this is a hybrid mask. Like we all have used the nasal mask, which sits on top of the nose. Then we have the nasal pillows, which go inside the nose. So this is like a cradle in front of the nose. It will just have 2 holes on top. So this is called as Dreamwear by Philips. So what they did is they chose patients who are already on CPAP and asked them to use the Dreamwear mask for a week. What they found out was that the appearance of the mask is quite good. Like I think I'm sure everybody can appreciate that. I mean, it looks very comfortable. The patient is comfortably sitting and reading, and then he can go to sleep just like that. The most important thing of this mask, I'm not advertising this, but still, you can lie on either side. So if you compress on this side, the air will flow through the other side. So patient can lie on any position. So comfort-wise, it is pretty good, very well accepted. And what they found out was that in the study, even though it's a small study, the appearance was appreciated by the patient's comfort level was better, patient acceptance. They do not get scars on top of the nose. Cosmetics are also important these days. Like we all have the N95 scars already from the COVID pandemic. We don't want one more scar, right? So another thing is, again, a very good data on compliance. The compliance improved by 1 hour. So mind you, these are patients who have already been using CPAP for a significant amount of time. They were already compliant to their CPAP, but once they were switched to this hybrid mask, they used the machine for 1 hour more, which is also a significant result. Again, not a randomized study, but still significant. So is PAP the only answer? So once you evaluate all patients, are all our patients like the elephant? Or are all of them just obese OSA patients? In our practice, we see a lot of different types of OSA patients. Not all of them are obese. Not all of them have the same EDS, high ESS. So is PAP the only answer? So here, what we have to understand is no longer is OSA just an obesity related issue. There are different endotypic traits which are associated with OSA, like collapsibility of the upper airway, muscle responsiveness, which is the pharyngeal dilator muscle responsiveness, arousal threshold, loop gain. So like collapsibility is only, this is determined by obesity basically. So 46% of patients have collapsibility as a major cause. Muscle responsiveness, that is the pharyngeal dilator muscle issue, is there in 36%. And very important is arousal threshold. That is, some people just tend to wake up quite fast from their sleep. So that is also quite important, and that is even seen in up to 88%, and this is more in mild OSA. So there are different parameters involved. While a CPAP will treat both the upper ones, the collapsibility as well as the muscle responsiveness, the lower ones are not taken care of by CPAP. So that's why we do see a fair share of patients who do not improve on CPAP alone. So what can we do with that? So here comes the upper airway stimulation, that is the hypoglossal nerve stimulation. I don't think anyone is practicing HGNS in India yet, but the data is quite good. It's an FDA approved system. So what basically this is, it's used in adult patients, not approved in pediatrics, but it is used in patients who cannot tolerate CPAP or who are failing CPAP, and they do not have complete blockage of the upper airway. So what it basically is sorry. So this is basically a pacemaker sort of thing which is implanted on the chest wall. There will be a sensor lead which goes to the intercostal muscle, and the another lead which goes to the hypoglossal nerves. So what happens is, once the sensor is activated, once the sensor detects that you're breathing, it will give an impulse to the hypoglossal nerve that will cause contraction of genioglossus, and the tongue moves anteriorly. So what happens is, in OSA, when there is upper airway collapse, the air gets stuck here. Once the hypoglossal nerve is stimulated, so there is a pacemaker, a sensor, and a stimulator. So the pacemaker is implanted. It's like an outpatient surgery. 3 small incisions on the same side, and this thing is implanted. It senses breathing, and it gives an impulse to the genioglossus through the hypoglossal nerve. So the inclusions, it's indicated in adult patients who are not very obese, BMI less than 32, and who do not have positional OSA, And also we should be doing a sleep endoscopy to see that there is no full collapse of the upper airway. So what this does, so we all know that there's a STAR trial which is published in NEJM long back, like about in 2013-14. So what is published recently is a 5-year data of this hypoglossal nerve stimulation. So what it showed was that there is, the improvement is quite sustained. So once this thing is implanted, the patient switches on the machine when he's going to sleep. Then there is a delay time allowing the patient to sleep. Once, like that you can set using a polysomnography. And then once the patient goes to sleep, the machine senses the respiration and opens the airway. It's a very innovative idea, and what is published right now is the 5-year data, which showed that the improvement is quite sustained. Even till 5 years, they do not have any recurrence of OSA. The AHI is well under control. Excessive daytime sleepiness are controlled. Quality of sleep is still good. So that is about hypoglossal nerve stimulation. So coming to the drugs, that is, we all have faced patients who are still sleepy after a proper CPAP use. They're using the machine is working well, their AHI is controlled, but still they are sleepy. So for them we have the drugs, that is modafinil and armodafinil are available in India, and these will improve the excessive daytime sleepiness. These are given in the morning. So what is recently published is a meta-analysis of these. So this is a forest plot which shows that compared to placebo, these drugs do improve excessive daytime sleepiness. Now coming to a little gray area, which is the emerging pharmacotherapy. Most of this is theoretical. These are all phase 2B clinical trials, so I'm not going into much details here. I will just introduce the topic to you. So emerging pharmacotherapy is the drugs which have just come up. These are in phase 2B trials. So these will be targeting our other areas which are endotypic traits, the other endotypic traits which are causing the OSA. So like the anatomy, which is basically weight loss medications. Then these are the really interesting studies. The cannabinoid study, that is dronabinol, was a recent publication in which cannabinoids can regulate the medulla, the respiratory centers, as well as the pharyngeal dilator muscles. Then very interesting study of atomoxetin, which is a drug which is used in attention deficit hyperactivity disorder, along with oxybutynine, which is a drug which you give in urinary urgency. So I mean, these are all manipulating the neurotransmitters. I'm sure we have neurology experts who can discuss more if you have doubts. I'm sorry, I cannot talk on that. But yeah, again, arousal threshold modifying drugs, ezopiclone has been shown to have very good results, but again phase 2B. So I'm not elaborating much because I don't want you all to think that drugs are upcoming much. No, but PAP is still the first line, but these are all in the pipeline, I would say. So a little bit of trivia when I'm discussing about management of OSA. So this is just a recent, I thought it's an interesting study because it was a meta-analysis. What happens, can you ask the patient to sing or play a wind instrument to reduce snoring? So what they found out was, this is actually pretty interesting. So this is, on the left is an Australian wind instrument. It's called didgeridoo. I don't know if anyone has heard of it, but it is seen that once you play that, you can even learn it in a few weeks is what the study told, and it's actually a randomized controlled trial which we don't have much. And compared to that, Indian Nadaswaram, that's again a study which was published from Madurai, which showed that there is some improvement in OSA. So maybe in the future for patients who are not ready to use anything. So newer diagnostic methods are like WatchPat are easier for patients, and we should be starting to use more. Consumer technologies are very far away from any clinical use. Patient engagement apps are quite useful. They will improve PAP adherence. And pharmacotherapy may be exciting in the future, but not right now. So this is our hospital. We have 2 sleep labs, and we do a lot of sleep studies. So thank you. Thank you for your patient listening.
Thank you, Dr. Sryma, for elaborating on the latest advances. I think it's time for questions, and I would like to invite the other speakers to the dais to take questions.
Just a brief announcement from the organizing side, since we are running late of time after this question and answer session. We shall move on to the next session without break. The tea is served outside, so those who want to have a cup of coffee can in between go and have that. Yeah. So after this question and answer session. So.
Just a comment regarding recent advances. There is two more things. One is a smart bed is now in the research. It's also a commercial one, not a scientifically advisable one. Smart bed also have detectors under the pillow, under the bed.
That was a sleep tracker one.
Yeah, correct. And which also can detect the sleep disturbances, snoring, and the patient body positioning, which may give a cloud directed inputs to the patient's phone. So the research is going on. It may come up with good data, but costly. Second thing is an intraoral nerve stimulation device, which we can keep just like a device like this. We can keep intraorally and stimulate during the daytime our genioglossus muscles, which will have sessions of there is a time like 10 seconds or 20 seconds you stimulate and relieve, like that multiple sessions you do in the daytime. So ultimately the muscle will get transition from their type 2A type, where there is a less response to movement, to type 2B, where there will be better response of nerve during the night. So there is also a nerve intraoral device, not a implantable one. That is also recently come up in the literature.
Is the watchpad device routinely used?
So watchpad we used to have at AIIMS. So problem is that though it is marketed as less expensive, that is compared to the Western standards. The individual sensor is 10,000 rupees and it's single use. So I think when you convert to our cost, it's going to be more expensive rather than less expensive, because I don't think sleep studies cost as much. In US it costs very, the cost is in $100,000 for a sleep study. So for them it's a less expensive device, but for us I think it's going to be more expensive.
Single use device?
It is no, the sensor. So there is a finger cap, no? So inside that comes a sensor which you have to replace for every study. So that is only a single use thing and costs around 10,000. So we have used it at AIIMS for the research study, but it's good for moderate to severe OSA when you don't have, like there the sleep study dates used to run for 6 months delay. So in that case it is useful, and when you're getting it free under government programs, but otherwise I think for corporate use it will be very expensive.
Can be combined with a level 3 study also, no?
Sir, it alone is enough. Like HSAT by ASM definition requires a respiratory sensor, an airflow and pulse ox, or a watchpad alone with actigraphy. So watchpad alone is an approved HSAT device, home sleep apnea testing device. So watchpad need not be combined with anything. It alone is enough. It is as good as a home sleep apnea testing device. So an HSAT should be used only when there is a moderate to severe risk of moderate to severe OSA, not in mild cases when you're suspecting. So in a case where you're planning a home sleep apnea testing, you can also do a watchpad if it is available to you and the cost is not prohibitive.
Srima, first of all, thanks for the wonderful talk.
Thank you.
And in your series, did it overestimate the HI or underestimate?
Overestimated.
Because in one of the studies you said it missed mild OSA, is that right?
Yes, sir. So ours was a smaller study. It was only 30 patients.
No, in the other study which you
other
quoted,
one was 500. So in our study, we cannot make it like a conclusion, because it was all very severe OSA patients, because those who get sleep study dates there will be very severe.
So in your study
so there is a lot of bias. So in our study it's generally was overestimating AHI. Like we were finding about 5 higher. AHI will be 5 events higher in the watch pattern.
You have recruited across the severity, like mild?
No, it was just a consecutive recruitment. So it was, most of them were severe. So actually in clinical use it does not matter, because whether it is 40 or 45 AHI, you are going to start.
It does matter when it is towards the milder category.
Yes, right.
Yeah, or
so
if it
ours,
is borderline.
yes. So ours was mostly in the severe category.
Yeah, that's
so
what I
so that is the reason for the difference. The other study which did was also only on moderate to severe, which they were suspecting, but they were recruiting all patients across the spectrum.
No, in that it missed mild OSA.
It missed mild OSA
so
and moderate OSA. And so that data is only on AHI alone. So you cannot make
Yeah,
a direct comparison with the two
yeah.
studies. But what I want to emphasize is that it can err on both sides. So it
Yeah,
is
that's
any
what-
other home sleep apnea testing device. So
Thanks.
Yeah, one more question I would like to ask. While doing a level 3 study, how often do we miss central sleep apnea in presumed OSA cases?
sir, at the outset, we are not supposed to do a central, home sleep apnea testing in a patient whom we are suspecting central sleep apnea. Now, in a very practical scenario, which I'm talking
For
about.
a suspected OSA patients, do we really miss a central sleep event?
So that does not actually matter, sir. So because what we are doing home sleep apnea testing, those are moderate to severe patients, what we are suspecting. So the major component will be obstructive events. So till the number of events 50%, more than 50% is obstructive, you are going to treat them as obstructive sleep apnea itself. Now the problem comes once you have done a home sleep study, it had shown obstructive sleep apnea of severe AHI, and you have started on PAP therapy and a patient is not tolerating PAP therapy. At that point, I think you should consider whether you missed something. But otherwise, in a scenario in which you have gone according to the guidelines, like you are not taking a patient for like coronary artery disease with an LV dysfunction or something like that, or stroke, where you do have an initial suspicion, if you're taking a usual patient like the guidelines recommend, which is a patient who has moderate to severe risk of OSA, which is defined by a patient who has, the ASM has given the definition on whom to do a home sleep apnea testing. That is a patient who's snoring with excessive daytime sleepiness, and 2 out of 3, which is witnessed apneas, hypertension, and loud snoring. So 2 out of 3. So if in that patient you do a home sleep apnea testing, it's good enough. You might miss few central apneas, but it doesn't matter. Till they are not crossing that 50%, your treatment is not going to change. So it is pretty safe in that way. But yes, I would like to, practically speaking, Dr. Hari Lakshmanan did correct way of putting out examples. But in that bariatric surgery patient, I have a little disagreement. Like, I would not do an HSAT in that scenario, because ideally speaking, it's an academic scenario here, so I think we should speak academically. But practically speaking, what he said might be correct. But academically speaking, bariatric surgery patients are at high risk of OHS, and they need to be optimized at least a week before the surgery. But it's true, what he said is quite true. We get a reference on the day before saying that yes. If it's but surgeons, if they're doing it, then it's fine. Yes, sure, sir.
Regarding the dreamwear, so
Yes.
you have a lot of experience using dreamwear.
Yes.
So I would like to ask you, do you prefer? Is there any preference for using dreamwear in a case of mild, say, rather than severe OSA?
So there are 2-3 components to that question. Very good question, actually. So what I say is that, I am biased towards it because most of my patients prefer it. Like, they do not want to get a mark on their nose. That is the major thing, because you're going to wear something throughout, like, almost 1/3 of your life. So that is one thing. So what you asked, the answer is, there is comparison between, dreamwear is basically a nasal mask. Okay. So nasal mask versus oronasal mask is, I guess, in essence, your question. So initially, people are thinking that if you're using higher pressure, nasal mask may not be well tolerated. But that depends. Like, even up to 14 or 15 pressures, they are quite well tolerated. What is actually found, what the research shows, that nasal mask actually will work with a lesser pressure than oronasal mask. So once you're titrating, if you're doing a manual titration, if you're titrating with an oronasal mask, you should be prescribing an oronasal mask, because the pressures are different. So what happens is, in an oronasal mask, the mouth is also pushed back. So actually the area there is reduced. So they will need a higher pressure if you're using an oronasal mask. So a nasal mask will always work with a lower pressure for the same patient. There is no pressure difference cutoff as such, but generally up to 15, even 15 CPAP is the maximum is tolerated even in oronasal mask. That's my experience, but people can go up to 20, but most of the patients, they have that pressure discomfort after 16, and you generally switch them over to BiPAP. So there is no specific cutoff like mild, moderate or severe. Nasal masks work well across the spectrum. You can prescribe in any patient. And regarding that comfort wise, I mean, this is just a nasal mask which is better designed, that's all. Have I answered your question?
But or mouth breathing or not mouth breathing is one criteria we always use before selecting.
Yeah, but that is also a controversial thing.
There is a chin strap available now even with mouth breathing patients. You can use nasal mask with the chin strap to close so that the air pressure will not leak through the mouth, so that you will reach at least optimal AHI clearance. So that is also possible. Even with even though now the problem is most of the patients will have the claustrophobia, they will have difficulty in holding the mask. Most of the people intentionally or unintentionally they remove during the sleep, and it's always difficult to close the mouth during the sleep, and some feel very discomfort. They will not compliance issue is the main thing, and where we have to change many times oronasal to nasal. Even though the price wise this one is costly, oronasal is cheap, but compliance wise even patients say, okay, even it is costly, I feel it is better than the other one. That is why the patient changes the mask. It's always we should give a trial before actually purchasing that. Nowadays the trial options are limited because of the COVID scenario. We have to choose either one mask. If you purchase or use one mask, we have to pay for that. Such scenario is there. So better option we can explain, better we try before, or if the trial version is available, then give a purchase option. That will be better always.
My go-to mask is always nasal.
Correct.
Nasal is always better accepted. And this mouth breathing thing also, there is data that people who are mouth breathing otherwise, once you put them on CPAP, they close their mouth and breathe. So that is also there. So I mean, I had a patient recently whose husband was telling her nasal CPAP is not working. I'm sure she's mouth breathing because she has been mouth breathing for a long time. So I said, but the patient was comfortable. Like, she was very happy with the machine. So we looked at the data, the leak was minimal. So what actually must have happened is she might have been mouth breathing when she was not using CPAP, but once I put her on a CPAP, she's no longer mouth breathing. So you should always look at the data. That is the most important, the usage data. I think the difference between sleep physicians, people trained in sleep and not trained in sleep, is the way the CPAP is monitored. Like, prescribing a CPAP, everybody does. I even saw a prescription by somebody who was, they had just written CPAP and the vendor has come and attached it. So there is nothing, there is not even a sleep study. So people know that there is something called sleep-related breathing disorders. They know that there is something called CPAP, but what to do after that? So that is most important. So I think that is where such conferences are really important. So.
And after this COVID pandemic, the data is coming up. It is around one study where 80% of the practitioners have changed their modality of sleep study as means home after the COVID pandemic, and also use of auto-PAP devices has come more relevant than the usual conventional titration, then applying that. And after the COVID pandemic, there is a more increased use of auto-PAP device and upfront, and get the data from that after 3 to 5 days and analyze how is AHI saturation or the PC20 values, whether it is okay, optimal, then we can continue that. And now after this last 2 years, there is a lot of trend in change towards more home study, towards more auto-PAP devices applying rather than the conventional way. But always, as with theoretical discussion, we should strictly recruit patient based on their criteria, whether they satisfy home or whether they satisfy auto-PAP device or not.
Yeah, one last question regarding the PAP therapy in obesity hypoventilation. So you told you can HA index more than 30, you can use CPAP directly, but there also usually will be a component of obstructive airway disease also in these patients now. So how confidently we can directly prescribe upfront CPAP?
Sir, first of all, the diagnostic criteria itself exclude the patients who are having other causes of hypoventilation, like patient who is COPD diagnosed with PFT confirmed is actually not an OHS patient. It's actually an obstructive airway disease with hypoventilation like COPD, where the modality of choice will, of course, it will be a BiPAP therapy. But if there is a COPD OSA overlap, where the OSA component is the predominant component rather than the OH or the hypoventilation component, of course, CPAP has better advantage in that scenario. But considering your question, if the patient is an OHS patient and if you want to buy a PAP device, my recommendation now also I am practicing is buy a device with CPAP and BiPAP.
Which will be a bypass.
Yeah. So he can, if like more than 30 AHI, if you start with CPAP or if they are not comfortable or in the later stage, you have to switch back to BiPAP. So rather than buying two machines after not using the CPAP initially, it's not working, then you have to spend again another 50-60,000. Buy a device with having both modes where we can an option to switch. That will be most economical way.
That's a very practical way of doing
yeah.
it. What I do is like we have rental options also available, no? So I ask them to take CPAP on rent for a week, then see how the patient is doing.
Correct.
But yeah, it's a great financial burden.
And the insurance will also make a lot of complication. Many of them have exclusion criteria. The OSA patients OSA may be in exclusion criteria. Many companies deny. Some may not. Some may promise that you will get reimbursement after, but some may not get.
What is the experience of panelists? Have you ever got a CPAP reimbursed from insurance?
No, we are getting. We are
getting. Okay.
But if the patient will have other comorbid condition like cardiac disease, renal disease, and for which they are already intimated the insurance company that they are having this complication, and once they admit for other reasons like breathlessness or other disease, on the evaluation, if you do all this evaluation of sleep apnea and prescription, then naturally it get accepted. But primary patient who is coming directly to the for OSA evaluation, very unlikely that they will get an insurance reimbursed unless until it's a very comprehensive insurance plan.
Any other questions from the floor?
Dr. Sourin, this question is for you.
Dr. Sourin, you spoke about leg movement and the arousal index. So can you comment about the bruxism or teeth grinding, which now is considered also a sleep movement disorder?
Yes, absolutely. That's the importance of level 1 study. Means the sleep technologist observes, there's recording of all the abnormal movements which occurs. They are recorded and they have to be documented actually. So then only we can interpret the sleep study in the right perspective. Means what exactly is causing the disruption of sleep, that we have to look into. So until unless we don't go into the detail, we don't record such things, those are usually missed. So yes, bruxism is definitely one of the hidden causes for obstructive sleep apnea. Sleep disorder breathing. We come across.
Thank you. Thank you, Dr. Sourin, and it's been an extremely fruitful discussion. And I'd like to wind up the session right now. Already we are running late on time. Thank you, all the panelists.
That was the end of session 1. We will now begin with session 2. Session 2 will be chaired by Dr. Murali Krishna Menon, HOD Neurology in VPS Lakeshore Hospital, Kochi, and Dr. John Alexander, HOD Internal Medicine, VPS Lakeshore Hospital, Kochi. Due to some medical reasons, Dr. Bindu Varghese was not able to join the session. I invite the chairpersons onto the dais.
Good morning. Let's go to the second session. I think we are running late on time, so I leave out the niceties. Dr. Ashalatha, who is a professor of neurology in the division and division head in sleep and epileptology. She's basically an epileptologist. She is not a novice in this field, a very familiar face in neurology conferences. I think we'll go straight to the topic. Dr. Asha.
Thanks, Chairpersons and Dr. Murali. I'm sorry for the goof up, but due to some reason I had to be the first presenter. And at the outset, I thank the organizers, especially my dear friend Dr. Vidya, Dr. Mujeeb, and Dr. Hari. So basically, the next few minutes, just a second. Yeah. So I think it's 11:05 and I have 20 minutes. In the interest of time, in the next few minutes, what I'm going to give out as a message is that there is a significant overlap between the various subspecialties when it comes to sleep medicine, as was rightly said by Dr. From Coimbatore. Neurologists were not much into the fray till late, in India at least, but we think that we have a major role to play because the EEG is the purview of a neurologist, and there are lot of neurological conditions which have an interface with pulmonology, which again Dr. Sapna and Dr. Vidya is going to speak about. But the most important thing is that it should be a comprehensive care center where there should be a pulmonologist, a neurologist, an ENT surgeon, an anesthetist, and a psychologist, psychiatrist, and all the other people. So with that brief introduction, I'll go into parasomnias and Sree. Some may be wondering what is a Sree, because in the topic it is nocturnal frontal lobe epilepsy, and what is Sree I'll just briefly touch upon later. So this is the interface of the topic. That is, this is called a Venn diagram, when something overlaps between three specialities or whatever it is. The sleep phenomena, the seizures, and the psychiatric medicine, they have an overlap. And the most important is one which has to be borne in mind, because this is not a very uncommon thing for a person with parasomnia to come and sit in front of you in the sleep clinic and ask what is my problem. And this is the list of parasomnias according to the latest classification, which is not of much relevance today, but 3 from non-REM sleep and 3 of them from REM sleep do have something which is common, or which is commonly mistaken by history, or even from a home video or whatever they're carrying, or from the onlooker's history, which can confuse a person who is working in sleep medicine. So all of you know what is parasomnia, and even this the abnormal movements or behaviors is same as what you see in a seizure disorder. And most of the seizures, at least 60%, not only frontal lobe epilepsy, the other seizures also occur in sleep, and of course the patient get aroused from sleep, and they are intermittent or episodic. They are paroxysmal disorder. So the 3 are completely common to both the disorders. And this is something which I want to emphasize. The sleep architecture, which is thought to be disturbed whenever a parasomnia occurs, is not so. For example, when a child is sleepwalking, you may see that the sleep architecture, if there is a portable so-called polysomnogram which is going on, the sleep architecture may be maintained as such. So this is something which is often not seldom thought of in the common scenario. So coming to the non-REM mimickers, or the parasomnias, which are very close masqueraders of epilepsy, are 3 in number. They are the confusional arousals, sleep terrors, and sleepwalking. And they have some features in common and very few features which are not common to all of them. So typically they occur in the non-REM sleep, and that to the N3 sleep, that is a slow wave sleep. And this occurs in the slow wave sleep, so that means suppose a person hits the bed by 11 p.m., it occurs within the next 2 to 3 hours. So that is something which is common to all the non-REM parasomnia. So this is something which you have to ask the person sitting in front of you. And the underlying pathophysiology and cause is also similar, which I'm not going to touch upon. And mind it, all 3 of them have a genetic predisposition. So you have to ask the family history. At least 3 generations history should be asked for. and an increased arousal, as was told by the previous speakers. All these disorders has to be rolled out, and Dr. Sapna will be speaking about RLS, BLMS, etc. So coming to each one of them, I don't have much to speak about sleepwalking, which is known to all of you. Only points to be borne in mind: it is common in the childhood age group, and it usually starts by around 4 or 5 years of age, but it can persist into adulthood as well. And the important point is that it usually lasts for at least around 10 minutes if somebody is not going to obstruct your path, and they can negotiate the surroundings and keep on moving. And they have autonomic dysfunction. If you see them closely, they have sweating, palpitation, tachycardia, etc. So if you come to witness such a person, this has to be observed as well. And the conditions that deepen the slow wave sleep, for example, the previous night the child could not sleep well, or there is a concurrent febrile illness or fatigue or whatever it is, that is one predisposing factor, in fact, for all the other 3 disorders as well. But at least few in the audience may be interested. Alcohol is not considered to be a trigger for sleepwalking. And these 3 can come together as well: night terrors, nightmares, and sleepwalking. So it is better to ask in the history if somebody has sleepwalking, whether they have nightmares or night terrors. Again, this we may have to resort to the help of the onlooker as well. Then comes the sleep terrors. This is nothing but a very an extended version of the dreams. Dreams means not the pleasant dreams, which is the nightmares I'm talking about. And again, it's a disease of childhood, but it can go on into adulthood. But here the most important thing is that the patient can scream out loud because it's a non-REM sleep. There is no muscle atonia. And in movies, this is often depicted in a different manner, which I'll come to later. In nightmares, you have seen that the hero or heroine is suddenly getting up from the bed and even shouting out. That never occurs in nightmares, because night terrors, because this is occurring in the non-REM sleep, and the muscle atonia is not there. The other features are all similar, but one association which has been proved is migraine. So if they have this sleep terrors, that is, they come and complain to you about nightmares, or somebody, the parents may say that the child is screaming out loud and there is some form of autonomic dysfunction, which also they can see. And when these people are followed up in the long term or even in childhood, they are migrainous. This association is there, but the cause has not been well proved. And the last one is the confusional arousal. This is nothing, especially in childhood. The other features are all the same. Only a difference is that it can happen in the N2 stage as well. So you see the sleep spindles, the B waves, that is the vertex waves, and the K complexes, and then you can get it as well. And this same feature is a feature of something called a nocturnal frontal lobe epilepsy, which I'll come to. And again, it occurs in the early part of sleep, and they just look up, they appear confused. Again, they don't come out of the bed, they only, the extraocular muscles do not lose their tone, so they open their eyes and they sometimes look here and there, and they often go back to sleep. Usually they are benign, but sometimes violent episodes are also described. This is one such patient. You can see was sleeping, then looking towards right, looking towards left, and then goes back again to sleep. And there is nothing much about it, but one important thing is that it can progress in 1/3 of cases into adulthood, that is confusional arousals. And in such patients, an abnormal sexual behavior is also seen associated with that, which is called sexomnia or sleep sex. So different manifestations of that can come up. And again, the rest of the EEGs, the rest of the features are the same. But in EEG, there is an important thing, because there is an arousal whenever people who are neurologists and otherwise also, when there is an arousal in the EEG, you have an hypersynchrony. That is the delta and the theta coming up. So that change in EEG can be noted in confusional arousals. And coming to REM behavior disorder, we are moving into the REM sleep. So in non-REM, you have the confusional arousals, you have the sleepwalking or somnambulism, and you have the nightmares. And moving on to the REM, you all know about REM behavior disorder. It is unlike the previous 3, this is more commonly seen in older patients. Sorry. here the characteristic muscle atonia is there, and the patient enacts out of the dream, which again I think Dr. Sapna is going to elaborate in detail. And this is something which is very important for a neurologist. So as is depicted here, this can be a forerunner of many of the neurodegenerative diseases, including Alzheimer's disease, and it can be drug induced also, especially anticholinergics and the so-called sedative hypnotics and antipsychotics also. And this is one which can be seen in chronic alcoholism as well. So again, that history is very important. So these are like, it's an era of gadgets, as Dr. rightly said. These are some of the straining devices which are used, because this is really, really difficult for the bed partner, because they'll kick them out of the bed, and that is how. And so these can be used to restrain the patient, although it is rather very cumbersome and not really advocated. The second one is nightmares, which we all have, and again, it's the same as night terrors. Only thing, they don't scream out loud, as I said earlier. This can be seen both in children as well as in adults, and this is accompanied by another phenomenon which is called sleep talking. That's called somniloquy. They tend to have some not very meaningful talk, but they can talk as well. And this can also be the side effects of various drugs, and these are the drugs which can cause that. So this history is very important as well. And in psychiatry practice, this is where a role of a psychiatrist and psychologist is important in sleep medicine in many facets, but this is one such thing. This can be one of the earliest manifestation of a form of schizophrenia, which is mostly the paranoid type of schizophrenia. So this can be one of the initial manifestation. And the third one, or the last one, is the expiratory groaning. We have heard so much about OSA, and this mimics OSA, but this occurs only in the expiratory phase, and this is like a high-pitched roaring sound that you hear. And it occurs mostly in 80% during REM sleep, but it can happen during non-REM sleep as well. So if you see it in the non-REM sleep, don't think that the diagnosis is missed out. So PST always resembles central apnea. So at least in certain cases of central apnea, especially when the person is a young adult where he is not obese and he doesn't have any other problems that usually seen in central apnea, you have to think of this condition as well. And this occurs in the expiratory phase where you get a hypopnea, and mind it, there is no oxygen desaturation here. So audio recordings people bring, and this is one thing which has to be rolled out. This is called expiratory groaning or cataphrenia. And these are two other disorders which has to be rolled out. One is GERD, especially from infancy to adulthood. You have this gastroesophageal reflux disease where you get the reflux, and people can have moaning, groaning, arousal, everything. So this also has to be rolled out. And last but not the least is the panic attacks, which is very common, especially during the COVID pandemic. We did see some few cases where the anxiety and depression causes the attacks during the night. In those attacks, which the person gets up and they find difficulty in breathing, and you can see various manifestations, autonomic manifestations as well, especially sweating. And I always complain of a tightness in the chest. If you see 10 patients, you will understand that the tightness in chest is a very common part and parcel of the syndrome. And coming to the last part, that is the nocturnal frontal lobe epilepsy, and how this is called SHE now. There was a consensus conference in 2014, and after that, nocturnal frontal lobe epilepsy was renamed as sleep-related hypermotor epilepsy. This was based on 3 issues, which is, it's not always nocturnal. During the daytime also, that is diurnal also, if you have a nap, it can happen. So that is one reason. And not only the frontal lobe, any other lobe, the other 3 lobes can also cause the same pattern type of epilepsy. And last one, there are some telltale markers of frontal lobe epilepsy, that is they have this posturing and clonic jerks and all, which is not always seen. So because of these 3 reasons, it is now known as SHE, that is sleep-related hypermotor epilepsy. But having said that, this entity is still existing. There is a nocturnal frontal lobe epilepsy which runs in families, and at least 1 or 2 members of each generation will be having it. It occurs only at night, or majority of the events occur at night, and it is due to this particular genetic defect. So this is the diagnostic criteria. Again, I'll come to that later. That is the criteria how to distinguish between parasomnias and the so-called hypermotor frontal lobe, frontal lobe or other types of epilepsy. So the most important thing is, one, the duration. Duration is always less than 1 minute if it's a seizure, whereas in the so-called 6 or 7 parasomnias, which I mentioned earlier, unless somebody restrains them, it is never less than 1 minute. That is one important thing. Then second one is that clustering. Clustering means on a particular night, parasomnias occur only once. But in seizures, at least in a good number of them, they occur multiple times. And third, or the most important one, is stereotypy. If you take seizures, 2 of them would be almost similar. But in parasomnia, whichever one you take, it will not be the same. So that is what is written here. And there are 3 levels in which you can divide them. A witnessed one, where it could be possible, and a video EEG combined with the polysomnography one, which I'll come to later, is the most ideal one. So you have all the EEG electrodes attached, plus all the polysomnography gadgets also put together, is the best to diagnose or differentiate between the 2 conditions. So this is what I wanted to tell you in brief. There is a non-REM parasomnias, which again, the 3 of them are there. I've oversimplified it, but this is enough to sit in the clinic and diagnose that. One is nocturnal arousal, second is sleep terror, and the third one is sleepwalking, which occurs in the non-REM sleep. And REM parasomnias, RBD, the nightmares, and of course the expiratory groaning. And the other one is Sree. Again, it's not during the night, it can occur during any stage of sleep. So this is the same which I've already told. So many features have been put forth, but duration, clustering, stereotypy, these are the 3 most important ones which occur. And pharmacotherapy, one word about it, you can try a benzodiazepine if you think that it's a parasomnia, and most of the cases use a clonazepam. And there is a remarkable improvement with that, at least in most of the cases, but that doesn't happen in seizures, and you always have to go for other gadgets as well. So before I conclude, this is one of the scales which was suggested way back in 2006, distinguishing sleep disorders from seizures. It is called the FLEP scale, that is frontal lobe epilepsy parasomnia scale. And there is a scoring which they have done, but the most of the important factors I have already mentioned, and it is treated as a diagnostic test for nocturnal frontal lobe epilepsy, but it can be used for he or she, or for she also. A total score of 1 or greater indicates a diagnosis of epilepsy, especially in our epileptology unit we often use this one. And a score of 0 or less includes parasomnias. So this is called the FLEP scale, and it's an Australian scale which is quite often used in many centers. But when people went and researched again into the FLEP scale, whether it can distinguish all this, and they found that the positive and the negative predictive value is very good. So this is one of the things which, if you are not using, I really advocate you to use that. So the conclusions is, somebody I think in the morning session was asking how much time one should sleep. So I think there is no definite answer for that. One should sleep so that the next day you are fresh. So Prime Minister Modi was commented, as well as probably the CEO of the Lakeshore Hospital, who sleeps for 3 hours, was also commented. So if they are fresh the following day, that is the amount of sleep that you need. They are called constitutional short sleepers, and the other group is called constitutional long sleepers. Even if you take the codes which I put here, early to bed and early to rise makes a man healthy, wealthy and wise, which was told by Benjamin Franklin. And this is an often quoted one: the woods are lovely, dark and deep, and you have miles to go, so better not sleep. And yeah, so, and this is because these are all misconceptions people have. So morning, again sir quoted, I think it is Longfellow and not William Wordsworth. The height that great men reached and kept were not attained by sudden flight. They, while their fellows slept, were toiling upwards in the night. So it's up to you to decide whether you have to sleep early or get up early, but you have to be a very productive individual. So with that, I think I had few videos, but I can leave it to Sapna if she can show that, because the time is up. So this is a challenging situation, but if you keep these 6 sort of non-REM and REM parasomnias in mind, and you apply the FLEP scale in which that 4 parameters which I told, I think most of the parasomnias can be distinguished from seizures. But let me say, this is the final answer. Polysomnography, video polysomnography is better, and video EEG polysomnography is much, much better. Thank you. Thank you for your patient listening.
Thank you, Dr. Asha, for keeping on the time. I'll open this session for discussion because I think Dr. Asha has to leave early. Are there any questions from the audience? Okay, I have a small question.
Yes,
just for the sake of it.
Yeah.
Would you consider benign epilepsy with centrotemporal spikes, the old BREs, to be considered a sleep-related disorder, or is it only an epilepsy alone?
It's sleep-related means I think most of the episodes, at least the majority, occurs during sleep. Again, to be very foolproof, it is not mandatory that it should occur during night sleep. It can happen during daytime naps as well. Having said that, the prolonged episodes usually occur when the child is awake, especially when the previous night's sleep was not adequate. So in a very distressed state, they can have that. It's not a sleep-related epilepsy. It's not classified like that.
I've had a couple of patients, basically Parkinson's with history like RBD, but sleep studies which were done, I mean, they were already evaluated outside when they came to me, had OSA as well. But yeah, it was very difficult to even convince them to use a CPAP. Like, how do you deal with such situations? Like, do you treat RBD first and then go for OSA treatment? Or, I mean, have you found such scenarios?
See, RPD and OSA, the combination is what you say.
Parkinson patients who basically are like long duration Parkinsonism patients.
But they do have OSA also.
Yes, obese as well.
Yeah. So OSA has to be treated. This is my knowledge, because I don't think I ever
OSA
had
has
a patient.
To be treated,
yeah,
but then
OSA
they have the sleep issues and dystonias of Parkinsonism.
Yeah. And Parkinsonism also has to be treated. I think the neurologists are all here. And for the RBD as such, what we tend to give is again clonazepam only. So if there is no contraindication for giving, I stress on clonazepam because it is a time-tested drug which is used in almost all parasomnias, including RBD. But if RBD is part and parcel of Parkinsonism, it is important to treat Parkinsonism. And although I said polysomnography has to be done and all, in RBD it is very, very difficult. They'll just jump out and then you're not going to get.
I tried and failed.
Yeah. It's only the video that is going to help out.
Right. Okay, thank you.
RBDs do work well. I mean, clonazepam do work well with RBDs. Then I think pramipexole is another possible drug of choice, probably in the, I don't know about RBDs, but in sleep-related RLS. Levodopa itself is one of the drug of choices. There are no other questions.
Next topic of the day is narcolepsy. It's a long-term neurological condition that causes fragmented sleep in the night and excessive daytime sleepiness. The clinical presentation may be mild to severe forms such as cataplexy. It may be due to deficiency of hypocryptin, or it's a neurological transmitter. And other causes such as head injury or autoimmune disease are also attributed. To talk on this, we have our own senior consultant neurologist, Dr. Vidya. She did her MBBS and MD from Government Medical College Trivandrum and did her DM from SCT Trivandrum. Over to Vidya.
Good morning. Let me thank at first Dr. Asha and Dr. Sapna for accepting the invitation and in spite of their busy schedule coming and enriching the CME. Thank you for the kind words. to the topic. So narcolepsy is a disorder we all know. It's a central disorder of hypersomnolence with symptoms. There's a tetrad or even pentad if you include fragmented sleep into it. So the core features are excessive daytime sleepiness, cataplexy, hypnagogic hallucinations, and sleep paralysis. So, but only less than one third of patients will have all the features like tetrad. They also have, though they have excessive daytime somnolence, they have a fragmented sleep at night. Occurs in 25 to 50 per 100,000 population. The onset is usually in the teens. It's sporadic and it has got a strong HLA association. So genetic susceptibility and immune regulation is found to be the basis for narcolepsy. And it is found that it's an autoimmune disorder where T-cell mediated attack happens on the orexin neurons, which are seen in the lateral hypothalamus. So orexins, otherwise called hypocretins, help to generate a high arousal state. So animal is motivated, attentive, and primed for action. At the same time, it suppresses the REM sleep. So moderate loss of orexin neurons causes sleepiness, but more than 80% orexin neuron loss is needed for cataplexy. Another evidence for molecular mimicry or autoimmunity for narcolepsy is there was a surge in the cases of narcolepsy with H1N1 infection or even vaccination with a particular brand of vaccine used in Northern Europe. So again, reinforcing the basis as autoimmunity. You can get secondary narcolepsy in lesions of the hypothalamus or even hypothalamic encephalitis due to anti-MA2 antibody mediated encephalitis. So the whole thing in narcolepsy is there's a disorder of transition from wakefulness to REM and REM to wakefulness. So everything, REM sleep is very important. So detecting REM sleep in the sleep study is also important in diagnosing narcolepsy. So REM sleep, as we all know, it's a sleep state with highest physiological arousal. BP and heart rate will be high, but at the same time, skeletal muscle activity is inhibited. A lot of dreaming happens in REM sleep, but at the same time, there is muscle atonia, and you cannot act out dreams because of that. So healthy people, REM happens after initial NREM stages, after about 90 minutes, and it never happens during daytime sleep. And EEG, it shows almost similar to, it will be almost similar to wakefulness. Mixed frequency waves are seen. And chin EMG will be less active in REM sleep. And EOG, you can see the eye movements. So this is the REM recording. Maybe you can see the background activity is almost like that of wakefulness. In the EOG, you can see the extraocular movements very well. And the chin EMG is less active. This is chin EMG. Chin EMG is less active compared to what you see in wakefulness. The chin EMG is very active. That is how you detect REM in a sleep study. This is the N2 stage of NREM. So I told you it's a disorder of transition from wake to REM sleep. So cataplexy and sleep paralysis, where the patient is awake but cannot move, it happens because REM sleep atonia intrudes into wakefulness. And REM sleep behavioral disorder is due to impaired maintenance of REM sleep atonia. And hypnagogic and hypnopompic hallucinations occur due to REM sleep-related dream imagery intruding into wakefulness. So coming to the core symptoms of narcolepsy, one is excessive daytime somnolence. There's tendency to doze off when sedentary in school, at work, also when active like driving, socializing, and they feel rested when they wake up in the morning or even after taking a short nap. Short nap is sufficient, 10 to 20-minute nap is sufficient for them to get refreshed. And usually the sleep comes in an irresistible urge to sleep, and you can call it a sleep attack. And cataplexy is a sudden muscle paralysis triggered by strong, generally positive emotions when laughing or unexpectedly meeting a friend. The muscle weakness starts in the face and neck, and then sometimes it can spread to the trunk and limbs. In severe episodes, the individual may slump to the ground conscious but not able to speak. It lasts for 1 or 2 minutes. Hypnagogic hallucinations and hypnagogic is at the onset of sleep, and hypnopompic when the patient gets up from sleep. There are vivid hallucinations at the onset of sleep, and it can be frightening. There is a visual, tactile, or auditory element in it. Sleep paralysis is a difficulty to move for 1 or 2 minutes once you are awake. You get a feeling of suffocation because there may be the hallucinations may be superadded along with it, and there will be mild reduction in tidal volume. Around 20% of general population can have a sleep paralysis, but in narcolepsy the frequency will be more. And fragmented sleep you get in narcolepsy, and also other sleep disorders like OSA, PLMS, RBD, RLS, all may be associated with narcolepsy. So these are the few cataplectic facies pictures. You can see there will be head drop, chin drop, the facial hypotonia, ptosis in different combinations. So it's not a deadly disease, but it is a disease with significant socio-economic impacts. So it can be divided into narcolepsy type 1, where you get chronic sleepiness with cataplexy, and CSF orexin levels will be very low. But narcolepsy type 2, it will be less severe symptoms, no cataplexy, and 90% of patients will have normal CSF orexin levels. I'll share with you a recent case we had who is a 64-year-old lady. It is atypical because it usually starts in the younger age group. She had rheumatoid arthritis and was on medications. She had excessive daytime somnolence for 4 years. She had underwent sleep study earlier, which was, I think it was inconclusive somewhere else. And she had vivid dreams at sleep onset. She used to see a lot of animals in the room, small children playing in the room, but it was always not very pleasant. She used to see people coming to attack her, and she used to howl and talk loud and act like throwing stones at them. And it was an eventful sleep for her. So apart from that, she used to slump to the ground, unable to move on laughing or meeting people, to the extent that she chose to live alone so that she did not have to meet other people, which made her more comfortable. So this is the video. Sorry for the... actually, I'll skip that video. I'll show it later if it can be played. So basically, she had severe cataplexy. I'm first time seeing this long cataplexy. Actually, she came to the OPD. She just slumped to the chair. There was a head drop. There was a chin drop, as well as the hands were whole body was hypotonic. And then I thought initially it will be a somatization disorder, just like she came in and slumped to the chair. And after 2 minutes, she got up and then realized she had multiple episodes per day. I could have shown that video, which was very interesting, but unfortunately. So diagnostic evaluation, clinical assessment is very important. Any patient with excessive daytime somnolence has to be evaluated for narcolepsy, like history, sleep history, physical exam, and neuro exam is important. This is a questionnaire which can be used to detect almost all the symptoms of narcolepsy. I think I have elaborated all. So the gold standard of diagnosis is polysomnogram followed by MSLT. Polysomnogram is done to exclude other causes, especially to exclude other causes like OSA and all. And the next day after PSG, you do a median sleep latency test to detect sleep latency as well as SOREMS. SOREMS is sleep onset REM periods. Usually, normally, REM happens after 90 minutes of sleep onset, but here it will be seen within 15 minutes. So some prerequisites are there for undergoing this. You have to stop stimulants, psychoactive medications 1 week prior. Antidepressants have to be stopped 3 weeks prior, especially fluoxetine, which has to be stopped 4 weeks prior to avoid rebound REM effects. And you have to keep a complete sleep log for last 2 weeks. So in a nocturnal, like a polysomnogram, what to expect? It can even be normal in narcolepsy patients. You see a decrease in sleep latency, sleep efficiency will be less, and there will be increase in wake time after sleep onset, showing there's fragmented sleep. Arousal index will be more, and N1 percentage will be more compared to N2. N1 percentage will be more, and you can detect REMs within 15 minutes, SOREMs. MSLT, it is valid only if you get adequate sleep of 6 hours in the PSG of the previous night. It is to be done after 3 hours after the PSG is over, and you record around 4 to 5 nap sessions separated by every 2 hours. Has to be in a sleep conducive environment. If no sleep is detected within 20 minutes, you terminate it. And nap session has to be continued for 15 minutes after sleep onset to detect SOREMs. Normal sleep latency will be 10 to 15 minutes, and narcolepsy, it will be less than 8 minutes. Even our patient I discussed, it was less than 2 minutes. And SOREMs will be seen in 2 or more nap sessions. This video. So other tests are orexin A levels in CSF. If it is done, if MSLT is inconclusive, it is done in young children where MSLT is not validated, and sometimes it will be difficult to discontinue antidepressants. In that case also, we can go for orexin A levels. HLA, I told you, it is 90% of narcolepsy type 1 is associated with HLA type DQ B10602. But it is not specific, so it is not done as a routine. But in suspected cases, if for additional information, you can do the HLA testing. So what is the diagnostic criteria for narcolepsy type 1? Criteria A and B has to be there. Daily irresistible sleep for 3 months, and B, one or both, cataplexy, MSLT less than 8 minutes, SOREMs 2 or more naps, and CSF hypocretin levels low. Criteria for narcolepsy type 2, criteria A through E has to be there. Daily irresistible sleep for 3 months, and MSLT less than 8 minutes, more than 2 or more SOREMs, cataplexy absent, and CSF hypocretin levels will be normal, and other hypersomnolence disorders to be ruled out. Other hypersomnolence disorders, almost the most common mimicker will be idiopathic hypersomnia, which also starts in the same age group, younger age group. And there it will be long sleep time will be there, 24 hours sleep time will be more than 12 to 14 hours. Here also cataplexy will be absent, and the daytime naps will be long and it will be non-refreshing, and there will be sleep drunkenness. After even enough sleep, they will not feel refreshed. And the SOREMs will be, MSLT will be less than 8, but SOREMs will be seen in only less than 2. So coming to management, we know a normal person can keep awake for 12 hours at a stretch. But in narcolepsy patients, they cannot keep awake for more than 4 to 4 hours at a stretch. So you have to give a scheduled nap. That is the mainstay of treatment. You have to give a scheduled nap of around 20 minutes. You ask them to keep an alarm and wake up after at this time, like that. So maybe 1 or 2 scheduled naps will be sufficient. Sometimes it may be the only thing that is needed for a narcolepsy patient, especially if the symptoms are very mild. So sleep deprivation can worsen narcolepsy. So regular and adequate sleep schedule is needed. To treat associated OSAs, RBD, PLMS, and some medications are to be avoided in narcolepsy patients because like benzodiazepines, opiates, they increase the excessive daytime somnolence. Theophylline will increase the insomnia at night, and Parasomnia can worsen cataplexy. They need a lot of psychosocial support, especially children. and screening for depression, psychiatric comorbidities. They are prone for hypertension, diabetes, and also obesity, because orexin deficiency as well as physical inactivity contributes to it. And another important area is driving safety. So they are prone for a crash, maybe 3 to 4-fold risk of crash, and especially long highway drives, very monotonous drives are very difficult for them. And sometimes you can, with behavioral and lifestyle modifications like scheduled naps, driving only short distances, avoiding driving after meals, sedating medications or alcohol intake can improve the driving safety, as well as modafinil can improve the driving performance. But they should not be allowed to work as commercial drivers. So coming to pharmacotherapy, you can divide it into wake-promoting medications as well as medications to improve cataplexy. Wake-promoting medications, first line is modafinil, R-modafinil, we are all know about it. And then other drugs are like H3 antagonists, histamine 3 receptor antagonists, pitolisant, which can improve cataplexy also. Another dopamine norepinephrine reuptake inhibitor, solriamfetol, that can also improve cataplexy. So you have to start with one medication, add the second one, and taper the first one. So second line medications are stimulant medications like methylphenidate and amphetamines. Another group of drug is oxybates, otherwise called sodium oxybate or gamma hydroxybutyrate. It acts in a different way. It actually consolidates the night sleep. It is used in severe sleepiness refractory to other drugs. It improves cataplexy also. The cost and safety requirement is a concern, and it cannot be used in patients with concurrent OSA and also depression. It takes weeks for benefit. It is used as date rape drug, so it has potential for abuse, so has to be very careful in using. So coming to cataplexy, cataplexy improves with antidepressants, usually venlafaxine, fluoxetine, and tricyclic antidepressants. For the last patient I discussed, it was like she was given scheduled naps, she was given modafinil and fluoxetine, and with almost near total improvement in her symptoms. Then pitolisant can be used in cataplexy. Oxybates improves cataplexy. So for disturbed sleep at night, you can use short-acting benzodiazepines like zolpidem. Then the newer drug lemborexant, Dayvigo, it is a dual orexin receptor antagonist, which is just contraindicated in patients with narcolepsy. So it is an autoimmune disorder. So some people have used role of immunomodulators, but for immunomodulators to work, it has to be diagnosed early, because by the time cataplexy and all develop, it is almost 80% orexin neurons are lost. So it has to be early diagnosis, like you can use as morning session, it was discussed, mobile apps or artificial intelligence can be used to detect early symptoms, which may be useful for these patients. Thank you for your patient listening.
Thank you, Dr. Vidya, for your excellent and highly informative and practical approach to a difficult problem. The topic is open for discussion. 1 or 2 questions are entertained. If no more questions, we'll move on to the next topic.
The next topic is sleep in neurological diseases. It is said that if sleep is not a part of evolution, then evolution would have been a disaster. So we have Sapna Erat Sreedharan, who is an additional professor of neurology at Sree Chitra, has done her MBBS and MD from Calicut University and DM from Chitra itself. Over to Dr. Sapna.
Thank you, respected chairpersons and all my colleagues and friends. First of all, thank you Dr. Mujeeb, Dr. Vidya for giving me an opportunity for presenting this topic. So in the next 15 to 20 minutes, I will, my time is, okay. Vidya could have shown the video, no? She had more time. Okay. So, in the next 15-20 minutes, I will briefly go through how sleep is important for brain health and what happens to sleep in neurological disorders, which is what most of us neurologists see, mainly in focusing on neurodegenerative disorders like dementia and Parkinsonism. Some few points about sleep in cerebrovascular disease, epilepsy, migraine and headache, and immune-mediated disorders, and whether sleep can serve as a biomarker for predicting some of the neurological disorders, and briefly 1 or 2 slides about the management. So, as elaborated previously also, we know that sleep is a universal and crucial aspect for overall health. We all spend 1/3 of our life sleeping. The specific actions of sleep are still being researched, but the known functions include memory consolidation, especially happening during the N3 stage or the slow wave sleep, management of cellular and metabolic processes, that is clearing of misfolded proteins and toxic metabolites, and energy conservation. And we all know that sleep quality decreases with age. So this is a graph which I am sure all of you are aware of, the hypnogram, which depicts the sleep stages with time. The lower panel shows what happens as we grow older. The duration of N3 sleep or the slow wave sleep comes down markedly from childhood to older age, whereas the sleep becomes more and more fragmented. The duration of REM, total duration, 20-25% of total sleep remains almost constant, but it becomes highly fragmented. So sleep is regulated by 2 processes which work independently. One is the external influence, the circadian rhythm, and the internal influence, the homeostatic process. So the external influence, the circadian rhythm or the process C, which is controlled by the sleep-wake the sun. The master clock is the suprachiasmatic nucleus in the hypothalamus, and the main stimuli is from the retina, the retino-hypophyseal-hypothalamic pathway, which we all as students of physiology have learned. The process S is a sleep pressure theory. As from the time we wake up till we go to sleep, our internal depth, that is for the urge to go to sleep, gradually builds up. Many metabolites are responsible, one of the most important being adenosine, and once it crosses a critical threshold, you have a urge to go to sleep. So at a cellular level, during sleep, what happens? There is clearance of misfolded neurotoxic proteins like alpha-synuclein, amyloid beta, and tau. Just like lymphatic system outside the nervous system for clearing metabolites, inside the CNS there is a glymphatic system, which is a glial-dependent metabolic waste clearance pathway. The amyloid clearance increased by 25-30% during sleep in comparison to wake state. So thereby the importance of sleep is very clear, that most of the clearance mechanism happens during slow wave sleep, and sleep helps in maintaining a normal metabolic environment in the brain. So the first I will deal with how sleep and cognition are interrelated. So when you read about articles about sleep and cognition, always this doubt comes to your mind: who came first? Whether it was a cognitive abnormality which led to sleep problem, or whether it's a sleep dysfunction leading to cognitive abnormality. So this table I've taken from an article from Biomed Research Center. So at one half we find that when there is a sleep deprivation, there is a lot of changes happening at a cellular level within the brain. There is increased neuronal firing, increased amyloid secretion and defective clearance of these things, increased excitotoxic stress. So all these can result in accumulation of neurodegenerative proteins like beta amyloid, tau, etc., which downstream can lead to degenerative disorders. But when you flip the table, the reverse also, there is some truth. In all the neurodegenerative processes, there are a lot of sleep abnormalities happening as well. So with aging, there is increased sleep problems, especially insomnia and excessive daytime sleepiness. There is increased use of hypnotics with aging. And there are community-based studies which shows that hypnotic use has increased risk of all-cause dementia, especially Alzheimer's disease. Both short sleepers as well as long sleepers show deficits in multiple cognitive domains and neuropsych testing. And this is a French study where it was found that excessive daytime sleepiness has a high correlation with dementia in general and vascular cognitive impairment in particular. So this is a study which was done from our center, whether the sleep architecture abnormalities can predict the future conversion to Alzheimer's in patients with amnestic cognitive impairment. So here the patients with amnestic MCI, that is minimal cognitive impairment, were selected, and they were subjected to overnight polysomnogram, and it was compared with an age matched controls, and they were longitudinally followed up. So it was found that moderate to severe sleep apnea was more prevalent in amnestic MCI group as compared to control groups. And those subgroup of MCI who had a better sleep efficiency and longer duration of REM had a better learning and memory performance. And higher AHI, as we expect, had a negative correlation with visual memory testing. However, when the patients were followed up for the next 3 years, we found that the amnestic MCI group conversion rate to AD over annual conversion rate to AD did not significantly increase in those who were poor sleepers. But there are some studies which show contrary results as well. So what are the sleep problems which are common in neurodegenerative dementias? Like Dr. Sryma was previously mentioning, a PD patient who had a significant OSA. So they, just like the normal population, neurological disorders, patients with neurological disorders are also prone for many sleep disorders. Some which are particular for the neurodegenerative condition and some in general, relating to aging and other comorbid conditions. So insomnia is one of the most common complaint which patients come to us, range from 29 to 84%, can be sleep onset, maintenance or early awakening. A quarter of subjects have snoring and significant sleep apneas. Nocturnal leg cramps, RLS-like symptoms in another quarter of subjects. RBD, which is more often described but is less common when compared to the other disorders, seen about 5 to 18%, which is more common in synucleinopathies like Parkinson's disease and multiple system atrophy. Excessive daytime sleepiness is another common complaint with which patients with neurodegenerative dementias report to us. So the prototype degenerative dementia Alzheimer's disease. In Alzheimer's, there is increased sleep fragmentation and decrease in slow wave sleep. Also in subjects who are high risk of developing AD, even before developing memory problems like ApoE4 allele mutation carriers, they are also showing high degree of sleep impairment. The tau and amyloid beta protein levels in CSF predict the degree of reduced slow wave sleep and decrease in sleep efficiency. And studies have shown that both subjective and objective measures of poor sleep correlate with the severity of amyloid burden and CSF measures of amyloid beta and tau. So this is a vicious cycle. So at one end you can find that there is a defective amyloid clearance, increase in phosphorylated tau and misfolded proteins. There is which can lead to amnestic MCI, Alzheimer's, and there is a two-way, it has a bidirectional relationship with the sleep problems as well. In Parkinsonism, the sleep disorders are found to be an independent risk factor for incident Parkinsonism, chronic insomnia being at a highest risk in community-based studies. Prodromal REM behavioral disorders associated with more severe motor and non-motor PD subtypes. And CSF synuclein levels show a diurnal variation which can be increased following sleep deprivation. So this is a case, a 70-year-old lady, no comorbidities, symptom onset in 2008. She started having sleep talking, screaming and occasionally falling out of bed. Usually it occurred between 2 to 4 a.m. once a month or so. It was not a high frequency event. She had no difficulty in initiating or maintaining sleep. There was a history of nightmares, can recall bad dreams or being chased when she wakes up. At that point of time, she had no cognitive or behavioral or gait complaints, and neurological examination was normal except for anosmia. So at that point, the clinical history is more suggestive of idiopathic REM behavioral disorder, except that there is an anosmia, which may be a clue that it may be a prodrome of a neurodegenerative disorder. This is a polysomnograph recording. So this during the REM sleep, you can find that there are some rapid eye movements happening in sleep. So in REM, in the initial part, you can see that the chin tone is almost silent, but after that there is an increase in chin tone which is happening during the sleep. So this is something called REM sleep without atonia, which is a diagnostic of REM behavioral disorder in polysomnogram. Because the event may be infrequent, and in a routine polysomnogram you may not be able to record the actual motor event, but this, if it is present, it is diagnostic of RBD. So initially patient was advised environmental modification. She was tried in clonazepam 0.5 milligram, but she had significant morning sedation and giddiness, and dose was reduced. There was hardly any benefit. Tried in melatonin, gone up to 6 milligram, mild benefit for 3 months, then the event started recurring. So after more than 7 years, she started developing other symptoms of Parkinsonism, bradykinesia, memory problems like visual and verbal memory impairment, and falls. So at that point of time, the diagnosis was leaning towards a neurodegenerative disorder, like more like a diffuse Lewy, a typical Parkinsonism, like a diffuse Lewy body disease. She was started on levodopa with mild benefit. So this clinical pathological series of 172 cases of RBD presenting with or without neurological disorder. The most common diagnosis, this is a Mayo Clinic series where they found that the most common diagnosis of these patients was diffuse Lewy body disease, followed by Parkinson's with dementia and multiple system atrophy. And other conditions, it can be a combination of DLB with AD pathology, then rarely other conditions like narcolepsy plus or antibody-mediated disease also were there in their entity. So at one end of the spectrum, there is a synuclein. It starts as a deposition of the synuclein in brainstem structures controlling the sleep. So patients start experiencing RBD symptoms. Then after, once the synuclein pathology extends further, the more neurological manifestations develop. In atypical Parkinsonism, other than RBD, many other sleep dysfunction is reported, like nocturnal stridor in multiple system atrophy, then abnormal sleep architecture, excessive daytime sleepiness, etc. Stroke is another area where a lot of sleep problems are reported. Over half of stroke survivors have sleep problems of different nature. The most common reported ones are sleep disordered breathing and insomnia. Community-based studies have shown that sleep disordered breathing have a high risk, those with a STB have a higher risk for developing stroke, that is over twofold risk for developing stroke when compared to those without. And also, once you have a stroke, if you have a coexisting sleep disorder, they are at a higher risk for recurrent stroke as well as poor functional outcome. However, whether CPAP therapy helps in improving their outcome, still it is debated. The SAVE study, which was the largest trial, which recruited patients after stroke or vascular event, was a negative trial, but there were a lot of problems with methodology and compliance issues. So, but many studies have shown that there is an improvement in the neurological outcome if you start them on CPAP therapy. So sleep and epilepsy, madam has, Ashalatha madam had previously shown some of the associations. So this, we know that sleep disruption of any kind, including sleep disorders, can worsen epilepsy also. Some epilepsies predominantly occur during NREM stage. Then when you see EEG, you can find that interictal epileptiform discharges are markedly activated and become more synchronized during slow wave sleep. And epileptiform discharges can also disrupt their sleep quality. And there is another entity called sudden unexpected death, unexplained death in epilepsy, which can occur in sleep. So some of the sleep-related epilepsies already has been described. So this is just a small video. So this child was brought to the epilepsy unit with a history of nocturnal arousals. So you can watch the video. This happened in the multiple times in the night, which was a clue that it may be epilepsy. But when you see the motor activity, often for an onlooker it is very difficult to say that it is a seizure phenomenon, because child is suddenly waking up from the sleep and child has got a frightened look, and after that there are some motor manifestations as well. So unlike an epilepsy where you find some tonic posturing or clonic jerks, none of these events are present in this current event recording. And after that the child became responsive and then child went to sleep. So often parents bring children with such events. So this could be easily mistaken for a NREM parasomnia, like confused arousal. So here patient was subjected to video EEG, and the video EEG showed that the child had a right insulo-opercular onset of seizures. The child underwent actually epilepsy surgery with the complete improvement of the symptoms. So another area where a lot of sleep disorders are described is migraine. And we all know that people who treat migraine, we all know that people with insomnia are at higher risk of migraine and the vice versa. And sleep and neuroimmunology is another area. There are some disorders like narcolepsy which have an immune association. Then there are some other immune disorders like Eglon-5 antibody disease. Then some of the brainstem encephalitis where patients can have very prominent sleep symptoms as well. Can sleep serve as a biomarker? RBD is now recognized as a prodrome of synucleinopathies and can precede neurodegeneration by years. Idiopathic RBD or long-term follow-up studies of 10 or 15 years have shown that over 80% phenoconvert themselves to one of the synucleinopathy. And other entities, sleep fragmentation and reduction slow wave sleep, these can precede Alzheimer's and cognitive impairment, but the cause-effect relationship is still not proven. Coming to the management, insomnia, one of the most common complaints with which patients with neurodegenerative disorders come to us. Mainstay of treatment will be management of the primary disease. If somebody with a Parkinson's complaint of insomnia, it may be due to multiple reasons. It may be due to their severe stiffness or rigidity, which is producing motor impairment, comorbid anxiety, depression, pain. All these factors can increase the severity of insomnia. So all those things have to be addressed before considering specific management. Hypnotics, usually we prescribe benzodiazepines or non-benzodiazepine agents, but always be cautious regarding the side effects, because somebody who is severely demented or somebody with a significant postural instability, if you prescribe clonazepam, they are more prone to fall and fracture risk. So in this area, the dual orexin receptor antagonists or DORAs, there is safety proven in small studies on moderate Alzheimer's. Excessive daytime sleepiness often hard to treat, can be due to medication side effects, and screen them for OSA if you think that they have symptoms suggestive of OSA. Alerting agents like modafinil, armodafinil can be tried with modest benefit. In RBD, be cautious when you are giving sedatives like clonazepam, especially those with a fall risk. Melatonin may be a drug which is more having a better safety profile in such entities, especially it doesn't increase the postural instability much. So summarizing, sleep disorders are very common in neurological conditions. They can precede some of the neurodegenerative disorders like RBD. Example, RBD can be associated with comorbid anxiety, depression, so they also have to be screened. Careful evaluation of symptomatology and judicious use of investigations, especially polysomnography whenever indicated. And whenever you suspect a coexisting OSA, please consider polysomnogram and treating the condition. And also, while using medications, always weigh the risk versus benefit. Thank you.
Thank you, Dr. Sapna. There is a comprehensive overview of sleep disorders in neurological diseases. The floor is open for discussion. Are there any questions?
like in OSA, how, like, do you screen, or like what is your usual practice?
We don't routinely screen the patients for OSA in acute stroke.
Once they recover.
Yeah, because the studies show that if you screen them early, like at the end of many of the patients at the end of 3 months may have recovered. Over half of the patient must have recovered from the OSA. So if they have symptoms suggestive of OSA, we subject them to polysomnography at the end of 3 months. Very ultra early screening usually we are not doing nowadays. But there was a study from our center itself where we screened the patients within 3 months, and we found that those with a higher AHI index had a poorer neurological outcome and higher recurrence risk. Yeah. Yeah. That still it is difficult, because early stroke phase it is very difficult often to prescribe CPAP for such subjects, because patients have significant neurological disability. They may have hemodynamic issues also. So in such setting, prescribing CPAP is not very easy. So we find that if you prescribe them ultra early, often the complaints will become very poor. They will not be able to maintain the use of the machine. So most of the time we find that at the end of 3 months, if they have persistent symptoms, we screen them, and that is one point of time where intervention is more practical also.
Yes, like most of them have bulbar symptoms also in the beginning, and they end up having aspiration.
Yeah. And other thing, if you have a significant weakness, hemiparesis, it is very difficult to use the mask use. Everything is difficult. Somebody, caregiver has to use the help with the mask, which is very much difficult in a practical sense.
Right. Thank you.
Madam, excellent talk. Just one or two queries. During the pandemic of COVID, there was a lot of sleep disturbance we all encountered, both in mild patients, more than severe patients. It has a lot of pathophysiology, both viral mediated, psychological, anxiety, all the social media references, all these are there. And how is your approach in treating such scenarios?
We were not directly involved with COVID, so luckily we didn't see many of the subjects. But as far as post-COVID, insomnia was a very common problem with which many patients approached. Night terrors and nocturnal panic attacks was another problem with which patient came to us. So most of the time because by that time even literature was only emerging about the pandemic. Most of the time what we did was we reassured, and many of the time were given a short-term medication for like benzodiazepine relaxants also were given, anxiolytics were also given. As happening in insomnia, many of the patients will not come back for follow-up. So many of the time I don't have a long-term follow-up for such patients actually. But nocturnal panic attack was few patients who came with a nocturnal panic attack referred for PSG actually, because our center we get many patients from medical college also for polysomnogram. So whenever somebody complains that they have a nocturnal arousal, they are automatically referred for PSG. So we found that many of them were having nocturnal panic attack with the and after counseling and giving a short duration of clonazepam, many of them fared well.
Your center is a center where more referral for this parasomnia and behavioral disorder, not only in adult but also in pediatric age also. But considering our present scenario, there is a lot of use of mobile, soft screen time, social media. All these affect, as after the COVID has affected the pediatric age group into their online sessions. They are more in online or with the mobile and other social media. And what is your experience or your center's referrals due to the behavioral disorder of children or the young adults? And is there any evidence or your experience you have to share?
I haven't done a systematic study, so evidence but practical experience base, I can say that definitely the children's sleep have been severely affected by COVID, like pandemic and the online education system. And their overuse of mobile gadgets. So the most parents complain that the sleep time is getting delayed. They are hardly sleeping in the night, and the daytime attention span also. So in adults, in children, unlike adults, they usually present with hyperactivity rather than excessive daytime sleepiness. So that hyperactive behavior is one thing that worries parents as well. They are not sleeping well at night and they are overactive in the daytime also. So that was one complaint that we had experienced in patients. And in such situation, we also advise sleep hygiene, and some patients had to be put on small dose melatonin as well to initiate their sleep in pediatric population. But as you know, even adults are becoming more addicted to mobile. So it is not that children alone are affected. Their parents also were similarly using gadgets. So that is one thing that is very difficult to correct in such situation.
Thank you. Okay. Last question.
You spoke about hyperactivity in children.
Yeah.
So when you get a child who's referred for a hyperactivity, with the parent not complaining about a sleep trouble, would you recommend a sleep study than going into a medical management?
Hyperactivity, like sleep problems can increase the hyperactivity, that is, but another thing in pediatric age group, OSA can present as, like if they have mild moderate OSA, daytime, instead of daytime sleepiness, they can also present hyperactivity. So if you, we take a history, we ask for the sleep duration, sleep hygiene, and also we ask for symptoms. Like if snoring is there in children, it is almost always pathological. So if any of these symptoms are there, we definitely subject them to polysomnography. Otherwise, routine, all the hyperactive children need not undergo a sleep study.
Thank you.
Thank you, Dr. Sapna. Sleep is an active process, and I think the glia also plays a very important role in sleep. We'll move on to the next topic.
Next topic of the day is Central Sleep Apnea Approach to Management by Dr. Parvati Rajendran. Online. She is doing the online manner. She did her MBBS and MD from Tricur Medical College. At present, she is working as an assistant professor to Pulmonology Department in Government Medical College, Tricur. Over to Dr. Parvati.
A very warm good afternoon to one and all of you. Thank you, Dr. Mujeeb and team, for inviting me for this wonderful faculty field seminar. Sorry, I couldn't attend in person because I'm at present suffering from a viral URI. Sorry, sincerely sorry. Central sleep apnea is my topic, and as a pulmonologist, usually my preferred topic is an OSA, and I, like many other pulmonologists, had a tendency to refer this central sleep apnea to the concerned people who are treating the underlying medical condition. But now this central sleep apnea is also coming to our OPD, so we as pulmonologists also, we should know something about this topic. So on to the topic. This central sleep apnea, as definition, is the cessation of airflow without respiratory effort during the sleep. So it is characterized by the repeated episodes of airflow, either apnea or hypopnea, and there is a transitory decrease or pause in the central ventilatory.
Excuse me, Dr. Parvati, could you put the this thing in full screen? Yes, slide.
Oh, sorry, sorry, I didn't understand. I didn't just realize that it was not the. Thank you. So this ICSD-3 has classified the central apnea into different classes, which we will be dealing in detail in the following slides. So the prevalence of the central sleep apnea is very low, that is less than 0.4% in general population. But as the age advances, the prevalence also increases. And if you are an elderly with comorbidities, the prevalence is as high as 7.5% in the population. So how do you diagnose this central sleep apnea? There's polysomnography criteria. That is, just like any other sleep apnea, there should be an AH than 5 per hour of sleep. And more than 50% of these events should be a central event, either an apnea or a hypopnea. So the gold standard for diagnosing this central sleep apnea is a full polysomnography with an esophageal pressure measurement. We all know this esophageal pressure measurement is basically for the study. So practically, we usually use this thoraco-abdominal piezoelectric or RIP bands for as an alternative. It is preferable to include a capnography, either an EPCO2 or a transcutaneous carbon dioxide monitoring along with a polysomnography. So the definition of central apnea and hypopnea, I'm sure you all are aware. The central apnea is a big drop of the signal more than 90%, either in a diagnostic study or in a titration study or in an apnea sensor, and its duration should be more than 10 seconds. Central hypopnea means this drop is more than 30% and its duration the same, more than 10 seconds. In addition to the central apnea criteria, there is an oxygen desaturation criteria as well. That is, there should be more than 3% oxygen desaturation from the baseline, or the event should be associated with an arousal. Chain stroke breathing, which we all know how to diagnose from the graph, has a definition as per the AIIMS. That is, there are episodes of more than 3 consecutive central apneas or central hypopneas in a crescendo-decrescendo pattern, and the cycle length should be at least 40 seconds. Usually it is about 70 seconds. And there are 5 or more central apneas or central hypopneas in this crescendo-decrescendo pattern, and it should be recorded at least for 2 hours of monitoring. So how do you know if this event is a central or an obstructive type? Central means there is no ventilatory effort, as measured by an esophageal pressure measurement or a transabdominal piezoelectric measurement. Central hypopnea means there is no snoring, there is no increase in inspiratory flattening as in nasal pressure, and there is no associated thoraco-abdominal paradox, and there may be an crescendo-decrescendo inspiratory flow pattern. So this is your central sleep apnea, hypopnea. So earlier we used to classify the central sleep apnea based like primary and secondary. Primary, which is the idiopathic congenital varieties, and the secondary, which is basically based on your other medical conditions. But rather than that classification, it is better to classify this central sleep apnea based on the pathophysiology. That is, it can be either an hypercapnic CSA or a eukapnic or hypocapnic. Hypercapnic CSA means this CSA associated with the hypoventilation, and the eukapnic or the hypocapnic means the ventilation is normal, but it is the respiratory center is unstable or there is an instability. So hypercapnic CSA or the hypoventilation CSA, it is mainly due to a decreased ventilatory drive. It can be either a congenital or an idiopathic hypo or an obesity hypoventilation, or it can be due to any anatomical lesions like a Bucchiali syndrome or a tumor or an extensive stroke, as Madam had earlier told. Or it can even be due to some medications like an opioid. Or it may be due to an inability to translate this central drive into adequate ventilation. It can be either due to a neuromuscular or a neural disorder, or it can be a severe kyphoscoliosis. All these patterns diseases will have an erratic or an ataxic breathing pattern, and usually they have a hypoventilation. Now, what is this hypocapnic or eukapnic CSA? The main mechanism here is an unstable ventilatory control, which I will be telling in detail. This is there is basically a chronic hyperventilation. Due to this hyperventilation, there is a low PaCO2. Why hyperventilation is occurring is basically due to a high respiratory drive. So here you will get the classic waxing and waning type of respiratory pattern, or rather the chain stroke breathing, and it usually occurs in NREM because during this NREM there is no supracontinent control of sleep. It is basically the chemosensitive mechanisms that is coming during this NREM sleep. So what we mean by the ventilator control instability is 2 things: either a high loop gain or a narrow carbon dioxide reserve. Narrow carbon dioxide reserve means there is only a narrow gap between this apnea, hypopnea, etc. based on this carbon dioxide levels. High loop gain means there are 3 components. Either it can be a controller gain or a planned gain or a feedback gain. Controller gain means this respiratory center is overly stimulated by this carbon dioxide. That is, any minor increase in carbon dioxide, this respiratory center is going to overwork and there will be an hyperventilation. What happens with this hyperventilation is that due to its hyperventilation, this carbon dioxide is going down. So this carbon dioxide drive is not there. So apnea is occurring. Then what is this plant gain? Plant gain means what is the change of carbon dioxide that is occurring due to this respiratory drive. That is the reciprocal mechanism. And the feedback gain means it is basically dependent on your circulation. If the circulation is dampened either by an increased circulation time or a decreased cardiac output, as in a heart failure, you are getting this feedback gain. So that is occurring during this eukapnic or hypocapnic CSA. So the associated conditions with this hypocapnic CSA are the congestive heart failure, which is the well-studied, well-known, and the thing that contributes to majority of the CSA. And of course, you have other conditions like the hormonal, like acromegaly or capillary pulmonary hypertension or a CKD. It is also seen in idiopathic CSA, high altitude CSA, and in treatment emergent CSA. So let's move on quickly to the congestive heart failure case, which is the most common condition associated with CSA. Its prevalence is about 1/3 in the stable heart failure cases. You all know that heart failure we divide it into reduced ejection fraction patients and the patients with preserved ejection fraction. If it is less than 45, it is reduced, and if it is more than 45, it is preserved. So the prevalence is slightly higher in the reduced people, that is up to 37%, while it is 18 to 13% in the preserved group. And more your BMI, there is more chance of all these comorbidities and your CSA. The typical pattern we see is the chain stroke breathing. This is the classical problem of CSA in a heart failure patient. That is, this CSA is a marker of disease severity or a mediator of disease progression. Why AIIMS is telling like that is because this CSA can promote this malignant arrhythmia. It can increase the mortality as well as it can turn an asymptomatic patient to a symptomatic patient. So this is what is occurring in a central sleep apnea in a heart failure patient. So it's basically depending on your cardiac output, the chemosensitivity and the high sympathetic activation, which occurs due to pulmonary congestion and all, which triggers the hyperventilation. So it occurs in the later hours of sleep because all these mechanisms have to come into play. And you can see the classical CSB because of the negative hypertonic pattern, because your ERB is reaching up here below or up to your FRC. So the treatment, as in any medical condition, the basic treatment is treat the underlying cause. You have to improve your LV ejection fraction and you have to decrease your wedge pressure. This is well documented in studies done in post-transplant patients where there was about 50% reduction in CSA. And if you're after treating these patients, just see whether these patients are having nocturnal hypoxemia. What I mean by the nocturnal hypoxemia is during the sleep, this SpO2 is lowering less than 88% or PaO2 is less than 55. Or there is a fall of SpO2 by 5% from the baseline for at least 5 minutes in a recorded study. And it is associated with other sequels like a development of pulmonary hypertension, like a P-pulmonale or an erythrocytosis. In these cases, you are justified in giving nocturnal oxygen to these patients. And in these patients, respiratory stimulants can help, but these studies, these numbers of patients are very less, so we can't make a generalized comment. Still, you can try this acetazolamide, theophylline, etc. So I hope you all know the different types of positive airway pressure therapy, but I will just tell what this ASP means because it is the mainstay treatment of this central sleep apnea. Here you are providing a varying amount of inspiratory pressure that is superimposed on your low level expiratory PAP, and there is a backup respiratory mode such that this magnitude of inspiratory pressure is reciprocal to your respiratory efforts. So you will get a variable inspiratory pressure that helps in dealing with your central sleep apnea. Okay. And then you have the CPAP, APAP, and BiPAP, all these PAPs. So the 4 main trials that occur in this area is the first is the CAN-PAP trial. This CAN-PAP trial is for the CPAP for CSA patients. This was done in 250 patients with a high AHI of more than 40 for 2 years, and they found that this CPAP significantly reduces the AHI, that is about 21 versus 2, but there was no significant improvement in the LV ejection fraction or the cardiac disease, but the CSA is decreased, and there is no change in the mortality. Mind it, the mortality doesn't change. The next study was the SAVIOR-C study, which was done for ASP patients with reduced ejection fraction and maintained ejection fraction heart failure. They told that there was an improvement in the qualitative life status and there was no significant change in the cardiac mortality or morbidity. Then came the servo HF study, which was the landmark study which gave many recommendations. This was a multicentric study done in about 1,300 patients, done in very moderate to severe sleep apnea with NYHA class 3 or 4 or 2 with hospitalization. They told that this ASV significantly decreases your AHI. That is about, it decreases from 31 to 3. That is a significant decrease is there. But the problem was that there was an increased mortality in this group treated with ASV in reduced ejection fraction heart failure group. That is, there was an increase to up to 31%. Usually it was about 28 to 29%, which increases to 36% when they used to ASV. So they told that ASV is contraindicated in patients with reduced ejection fraction heart failure. That was a landmark study. But this study had many problems because it was a biased study. It was mainly in the old age males and a high class heart failure. So now we are waiting the results of an advent heart failure study. So the treatment of ventilatory strategies from the CANPAPS trial, we start the treatment with CPAP. And if the CPAP improves it, well and good, just aim at a reduction of AHI less than 30. If the CPAP doesn't improve, then you can move to ASV in the group who have preserved ejection fraction. But in the group who doesn't have a preserved ejection fraction, it is better to go with BiPAP. Mind it, BiPAP spontaneous mode won't help much. So it is better to go with BiPAP ST mode where you have a backup plate and it will help in improving the ventilation. Mind it, this is based on studies who had very small number of study subjects. So better to identify the case, talk with the case, and have a complete follow-up of the case. And if you see that it is not working, better stop the BiPAP. And you can also add nocturnal oxygen if it is supported by PAPs. Okay. And ASV only in the group with preserved ejection fraction, as we are now following the servo HF trial. Why this ASV is contraindicated in the reduced ejection fraction, guys, are because actually all these stain-stop breathing, all these mechanisms are actually protective mechanisms. So by abolishing it, mortality is going to increase. Next, we can quickly brush the other conditions. One is the acromegaly, where initially we thought that there was a high prevalence up to 32% in this acromegaly group, but now the studies are telling there is only about 8 to 10% incidence in the acromegaly group, basically due to this hormonal growth factors. So better control your acromegaly, and if it is not getting controlled, better you go with your ventilation devices. Next is the CKD CSA group, which is the big subgroup having CSA. Here the prevalence is 8 to 10%. Mind it, this increases when these guys are having atrial fibrillation or an associated cardiac dysfunction. The basic pathology is the pulmonary edema and the metabolic acidosis. Here, first control the underlying disease. If you can't control, then go with PAP or ASV. ASV is justified in these cases. And we can even try with nocturnal hemodialysis in the dialysis group and bicarbonate buffer instead of acetate buffer used in dialysis. Mind it, these studies are also from a small population. Next, the pulmonary hypertension CSA. Here the prevalence is highly variable, and the treatments they recommend is the nocturnal supplementation of oxygen if it is a hypocapnic or eucapnic CSA, and you can even try the acetylsalamide, and if nothing is working, you can go with the ASV. Next is a treatment emergent CSA. Treatment emergent CSA, we know there are 3 subgroups. One is the true treatment emergent CSA, where the patients who are treated with CPAP develop CSA. Next is a transient group, where you give CPAP and they develop CSA, but this CSA usually resolves in 2 weeks. So understand that to call it a treatment emergent CSA, it is better to wait for at least 4 weeks. Next is the treatment persistent CSA, that is CSA which was persistent even under a CPAP. So all these conditions will cause the discontinuation of the CPAP use. So better you can go with an ASV in these guys. after ruling out all the medical causes and after treating all the medical underlying conditions and optimizing their medications. Next is the sleep instability and the idiopathic CSA, which we always tell as the primary CSA, which is not that much studied. Here, the mechanism may be a increased chemosensitivity to carbon dioxide and increased arousals. And as a treatment, we can give the carbon dioxide inhalation by increasing your dead space marks on. You can even give the respiratory stimulants like acetazolamide, and even the sulfidam is going to help. And if these guys are very symptomatic or if they are developing the sequel of the CSA, better you go with this adaptive cerebral ventilation. Next, the high altitude CSA. Understand that high altitude CSA is almost same as the having the same problem as the high altitude mountain sickness and the pulmonary edema. It is more you isn't, more chance that you are going to develop these conditions. It starts from 1,600 and by 6 you reach about 7,000 meters. Almost all are having this central sleep apnea. So the treatment is you can give oxygen and you can add a dead space, just like this dead space device this guy is using. Or you can use a respiratory stimulant like acetazolamide as we use in a mountain sickness patient, or Dexona as we use in a pulmonary edema patient. You can try autopap and oxygen in patients who are listening with it OSA conditions, and you can and you are not supposed to use a hypnotic in a mountaineer patient because you don't want to form a casualty there. And ASV, the studies are lacking. Maybe they may help. So hypercapnic CSA, madam already told about the stroke condition. You know, there is a peculiar pattern with this stroke CSA that it is high in the initial month, but when you follow up these patients by about 6 months, majority of them don't have CSA. So the prevalence is high in the initial time and then it decreases. So better you start with a CPAP therapy if the patient is very symptomatic. Mind you, these people are not going to tolerate the CPAP as madam has told, because they have all other problems like this regurgitation, your drooping, everything is there. So they may not be that much worried about CSA in the initial stage while the CSA is high. So if the patient is really symptomatic, or if the patient wishes to have, or if the patient is developing it even after 6 months, then you can go with this ventilation assisted devices, CPAP first, then ASD. Then all these other neuron conditions also have neuronal conditions also have this CSA, but these things are not well studied. And if you have any structural deformities like a malignant tumor or a Berchiali syndrome, better do a surgical treatment and then the CSA markedly will improve. And if you're developing a CSA in a patient with infection, you may suspect Listeria also. Now you have to know something about the drug-induced CSA. It is most commonly seen and most commonly described and most commonly studied in opioids. This opioids we all know is given for chronic pain management as in a cancer patient, and people also have a tendency to use this opioids. So if you are using in a high dose, there is high chance of CSA like 42 to 85%. If it is low dose, there is a prevalence of 24%. Mind it, this prevalence is high. And this prevalence increases when it is combined with other drugs like benzodiazepine, which is a GABA drug. And it is also seen in baclofen and also in the blood thinning agents like ticagrelor. This treatment is, if you can change the drug or decrease the dosage, well and good, it will decrease your CSA. And you have to classify this whether it is a normocapnic CSA or a hypercapnic CSA. If hypercapnic, you can try with BiPAP if all other modalities of changing the drugs and all are not working. And if it is a normocapnic, you can try ASV because there is an 60% efficacy for ASV in these guys. And you can even try the respiratory stimulants like acetazolamide, triazolam, sulfidam, etc. Mind it, first and foremost treatment is reduce the dose and change the dose. Obesity, we all know, is well documented with OSA, but since it is associated with leptin and all, there is a chance of CSA as well. More you are obese, more chance of OSA plus CSA. So this daytime sleepiness and daytime hypercapnia will correlate with your severity of your sleep apnea. So the treatment is first you start with NIV, the ST mode. You have to at least use for 4 hours, and you are not supposed to give oxygen monotherapy to these patients unless it is supported by an NIV. And this bariatric surgeries may have if everything other fails. You can try ASV if it is a treatment emergent case or if it is a persisting CSA case. Otherwise, your NIV is going to work. So coexisting OSA plus CSA, as I told, you can try the CPAP, then if not working, then go with your ASV in a long-term fashion. Your nocturnal oxygen may help if it is backed up by a ventilatory pressure device. So I told normocapnic CSA, the treatment is basically the treatment of the underlying cause and withdrawal of the medication. And you can increase the PaCO2 by a dead space like a PaCO2, this PaCO2 dead space devices like mask, this statements, etc. And in the majority of cases, initially, though you resort to this CPAP, slowly you will have to go and use this ASV. So, summarizing what I told right now, CSA, you suspect a CSA in a patient who comes with the sleep apnea signs, like an increased somnolence or a decreased sleep or decreased quality of sleep or witness apnea, decreased cognition, just like any other sleep apnea symptoms these patients will be having. And usually these guys will be having any underlying medical condition, what I have described in detail, or any drug uses. Always take a history of all these things and then do a PST. And if there is a medical condition you can correlate to, always treat this condition. If you can't identify any medical condition, rule out all the medical conditions by either an echo and BNP, or you can do a brainstem MRI, or you can rule out any hormonal cause or any opioid use. Or after ruling out all these things, we can go and start the treatment. Treatment basically depends on the symptoms. If the patient is not that much symptomatic, and if the patient is not having that much sequel like a pulmonary hypertension or erythrocytosis, you first start the underlying condition. The AHI may improve. If it is not improving, then only go with your ventilation devices. If the patient is having severe symptoms or sequel, start both the ventilation treatment as well as the treatment of the underlying condition together. Hyperventilation CSA, as we told in heart failure cases, almost all these studies are coming from the heart failure cases. So start with treat the underlying condition, start with CPAP. You may add nocturnal oxygen if this criteria is satisfying, because nowadays insurance companies are very much particular about this criteria meeting. Then we have a loft HF trial whose studies as we are waiting, and classify them into a reduced ejection fraction as well as a preserved ejection fraction group. And you can try ASV in the preserved ejection fraction, and you can try BiPAP in the reduced ejection fraction group. Mind it, by BiPAP, you have to use very cautiously. And you can also try acetazolamide because it is a respiratory stimulant if no other treatment is going to work. Then you should know something about this phrenic nerve stimulator, which is a transvenous phrenic nerve stimulation. That is, you all have, this is just like a pacemaker. That is, you are having a device that is placed in the pacemaker device that is placed in the upper chest, and you are having two leads. One is a sensing lead, which will sense the respiration via a thoracic vein, and the other is a stimulation lead, which will stimulate your phrenic nerve and thus stimulate your diaphragm, and diaphragm will contract just like a normal respiration. This thing is approved by the FDA, basically based on a multicentric trial which was unblinded, who had 151 patients with high, moderate to severe CSA, and they were followed up for 6 months, and they found that after 6 months, more than 50% reduction in AHI was observed. But understand that, and all the other sleep parameters and daytime sleepiness, quality of life, everything was improved. But understand that that was a short-term study. So we should have multiple studies on long-term follow-up of these things and comparing these things with a ventilation device. All the studies are lacking, but maybe you guys can, we all can further research into these things. Then next is the central sleep apnea associated with the hypoventilation. Hypoventilation thing, rule out all this structural brain anomalies, stroke, etc. And then you can go with a BiPAP with a backup plate as a first mode of treatment, not the BiPAP S mode. This is the BiPAP ST mode I'm talking about. And then if it fails, you can go and try an ASV. So this is what I just told. in the treatment part about all the different conditions, hypocapnic, hypercapnic, and how we are going to treat these conditions. Basically, if it is a hypercapnic thing, we will try NIV before trying an ASV. If it is not an hypercapnic, if it is a hypocapnic, better try ASV before an NIV if the CPAP is failing. And if it is a reduced ejection fraction heart failure, never try ASV. That is the nutshell of what I was talking about in the treatment part. So that concludes my session on CSA. Thank you.
I think in a nutshell, CSA can be caused by any of the chronic medical problems. First of all, we have to treat the primary cause, then we have to go for a specific treatment for CSA. Thank you for your excellent and highly informative talk, Dr. Parvati.
Thank you, sir. Our head of the Department of ENT, then Dr. Sophia Philip from GMC Kalameshwari Medical College. How about you, sir?
Yeah, good afternoon. Welcome to the post-lunch session of SleepCon 2022. And with a great pleasure, let me thank Dr. Mujeeb and Dr. Hari for inviting us chairs. The post-lunch session includes 4 topics plus another 4 in session 4. We will be sharing the session 3, and the first topic is evidence-based practice of surgical correction in OSA. When to refer and how to approach. The topic will be delivered by our esteemed faculty, Ms. Anjana, who is Associate Consultant over here in VPS Lakeshore. I think Dr. Sean has taken leave. Am I right? Yeah, he's having another conference. So, okay. Dr. Anjana, please, you are here. Yeah, over to you. Mic, please.
Good afternoon. Good afternoon, sir. So, as you said, Dr. Sean was supposed to take this session, but he is not there today. So, I'll be dealing this topic. And post-lunch session talking about snoring and sleep is very challenging, I know, but I'll try to make it very brief and simple and interesting. So, I'll be talking mostly in an ENT perspective. So, OSA is a very common sleep disorder characterized by airway obstruction, causing frequent arousals and desaturations. So this is a very common disorder. It's that common that WHO has named it as a disease of the 21st century. Now the prevalence of OSA is very high in India, in both men and women compared to other countries. There is no doubt that CPAP is the gold standard treatment for OSA. And how does it work? The pharynx is a very compliant tube. It is a very soft tube composed of muscles compared to a bony nasal cavity and a rigid cartilaginous tube, trachea. So any condition that reduces the intraluminal pressure or increases the extraluminal pressure, can result in collapse of the pharynx. So in CPAP, we give a steady stream of air that goes into the airway and make the airway patent. So what is the problem with CPAP that we face? Acceptance, compliance, and adherence. These are the problems that we generally face. So this is a review article published in 2008. In that they found that 46 to 83% of the patients with OSA were non-adherent to the treatment. This is a randomized control trial done in 2012. In that around 42% patients achieved MCS adherence threshold at 6 months. So what about those patients in whom the gold standard treatment has failed? So we know that consequences of an untreated OSA is life-threatening, and we have to find out what are the possible factors for the dropout. So most of the patient complains of nasal congestion, dry mouth, hair leak, sore nose, etc. So what is important is to rule out anatomical structural problems. So these are some of the conditions that increase the nasal resistance, like external nasal valve problems, septal deviations, turbinate hypertrophy, adenoid hypertrophy, nasal polyps. In all these conditions, nasal resistance will be high, and even if you give a CPAP, patients may not be able to tolerate it properly. This is a skeletal condition which is congenital piriform aperture stenosis. Again, the nasal cavity space will be very narrow, and if you give CPAP, patient may not be able to tolerate the high pressures. This is a study published in 1999. In this, they found that nasal symptoms were present in 42% of patients who dropped out within 6 months after the introduction of CPAP therapy. This is another study published in 2007 showing nasal resistance determined, which was found before the CPAP treatment, was considered to have significant influence on acceptance of CPAP. And nasal resistance could be a predictive parameter for initial acceptance of CPAP. So this is a patient who has soft tissue mass lesion in the supraglottic region, and each time patient inspires, the mass obliterates the laryngeal inlet. So this patient is never going to tolerate a CPAP. Another skeletal issue is high arch palate or a retrognathia. In such case, the space inside the oral cavity will be narrow, and while sleeping, especially when the reflexes are down, the tongue falls back, and that can result in apnea. So is there a way to predict long-term use of CPAP? High usage rate in the initial introductory period is a key factor for continued adherence to CPAP therapy. So this is a retrospective study which showed long-term CPAP adherence in patients with OSA can be predicted from the status of use in the early stage of treatment. So coming to guidelines on when to refer, American Academy of Sleep Medicine, they commissioned a task force of experts, and they did a systematic review and meta-analysis and came up with the following guidelines. Any adults with OSA, BMI less than 40, who are intolerant or unaccepting of PAP, and they have to be referred to a sleep surgeon. This is a strong recommendation. Then any adult with OSA and obesity class 2-3, intolerant or unaccepting of PAP, even have to refer to a pediatric surgeon. Any adults with OSA with BMI less than 40, and if there is persistent inadequate PAP adherence due to pressure related side effects, then you have to discuss with the patient regarding alternative treatment option. This is a conditional recommendation. The next recommendation is if a patient has an upper airway abnormality, you can recommend PAP as an initial therapy for adults, but you have to again talk to them about the alternative options. Now, as an ENT surgeon, what do we do? We take relevant history and questionnaires to assess the severity of disease. I'm not going to do the details of history taking and all that, but we generally use this Epworth sleepiness scale. It gives us a clue about the severity of excessive daytime sleepiness. This is another questionnaire which helps us determine the risk of sleep apnea. And then these are the questions that we generally ask. Where is the obstruction? Is it global? It is local? Whether it is skeletal or is it soft tissue or both? Whether there is a static or dynamic obstruction, and whether it is at a single level or if there is multi-level obstruction, and if it is it likely to be treated surgically or non-surgically. Now comes the evaluation part. So we start with anatomical evaluation, which is usually done with the help of a flexible scopy. And we try to assess whether there is any obstruction in the nose, oral cavity, velum, oropharynx, tongue base, or epiglottis. So this is this classification is very helpful. This is nothing but a modification of Mallampati score. Here we use both tongue and tonsil position to assess the obstruction, severity of obstruction. So importance of this classification is that we can identify whether the patient will benefit from a UP3. So only stage 1 patient will have a benefit of around 70 to 80%. So rest of the patients, if you do UP3, patient won't benefit. So that is one importance of this classification. So next we look at the palatal phenotypes, whether there is any obstruction at the palatal level. Is it oblique, intermediate, or vertical? Then Mu classification, we try to assess if there is any obstruction at the tongue level. So whether there is any high level obstruction, whether a high and low obstruction, whether obstruction is at the level of an epiglottis. This classification is more important for the anesthetist to know whether to anticipate a difficult intubation. Next comes a physiological evaluation, which is of course a sleep study. I'm not going into the details of that. Then comes a dynamic evaluation, which can be done DISE, drug-induced sleep endoscopy. It's a very common procedure. So in this we try to mimic sleep for the patient by giving propofol or dexmedetomidine. And then when the patient starts snoring, when the procedure starts, we do endoscopy and try to see where exactly is the obstruction, whether there is a lateral collapse, whether there is a AP collapse, whether it is a circumferential collapse, and where exactly is the obstruction. But now dynamic MRI along with awake flexible scopy is becoming dominant because it is very easy, very physiological, and far more superior, and it is completely objective unlike DISE, and it is an OPD procedure. So key to success is doing the correct procedure for the correct patient. So there are multiple surgeries described for each levels of obstruction. I won't be going into the details of each surgeries as such, but in general, for nasal surgery, the main goal is to relieve the obstruction so that as an adjunctive measure to improve the outcome of the CPAP. So this is a study done in 2013. In this they found that compound nasal surgery, that is septoplasty, terminate reduction, submucosal resection together done in 53 patients with high nasal resistance and moderate to severe OSA, they found that 57 and 75% showed post-operative improvement in at least one PSG. Next is regarding upper pharyngeal procedures. Tonsillectomy with adenoidectomy is the first line treatment for pediatric OSA. Tonsillectomy alone has shown improvement in AHI severity, desaturations, and sleep quality in obese patients with OSA. And UP3 is a specifically designed surgeries, for first surgery specifically designed for OSA. It was described in 1981. It is very infamous for its low success rate. The problem is if you do this surgery for every single snoring patient, it will eventually fail. So as I said before, Friedman stage 1, that is actually the patient where you should do this procedure. Otherwise the success rate is very low. And even Friedman stage in hyoid position can actually predict the outcomes of UP3. If the hyoid is very low, that means lower the hyoid, worse the prognosis. Now for the pharyngeal procedure, there are lot of techniques And nowadays we are moving on to minimally invasive conservative procedures, and barb repositioning technique is something new that is coming. Next is lower pharyngeal laryngeal procedures. It has shown to improve the respiratory physiology during sleep, daytime somnolence, and quality of life. And reduction of AHI of 50% or more, and AHI of less than 20 was achieved in 35 to 62% of the patients. This is very new technology that have come. It is not yet practiced in India, but it will come soon. So I think Dr. Sryma had already mentioned about this. This is hypoglossal nerve stimulation. Here we keep a pacemaker-like kind of a device in the chest, and the electrode is tunneled into the neck, and it goes into the hypoglossal nerve. And each time the patient inspires, the hypoglossal nerve stimulates the geniohyoid muscle and causes protrusion of tongue. And it was found to, there was 68% decrease in the AHI score, 70% decrease in saturation index, and improvement of quality of life. Multi-level surgery, if there are obstruction at multiple levels, this could be done, and success rate is 66.4%, and reduction in AHI 50% or more, and AHI of less than 20 was found. That's all.
Thank you, Ms. Anjana. Any questions from the floor? May I ask you, Ms. Anjana, after how long after a corrective surgery we have to do the follow-up PSG? And also any consensus on usage of this CPAP during perioperative period? Have you gone across those areas?
Actually, I'm not a sleep surgeon as such, so I would like to get the help of a declarer, sir.
Yeah.
Yeah, that's a good question. The idea is pre-operatively to make sure that this patient will not have any problem post-operative. That means if you know what is the situation, you will know to anticipate any problems for the patient, and therefore take adequate care to see if we put him in the ICU or something like that. It depends on there are many factors. It depends on the neck circumference, it depends on the BMI and things like that. And then PSG, what the patient feels, like what they tell you, that is the gold standard. When they come and tell you, I am feeling much better, or the person who sleeps with them tell them that the situation is much better, the snoring and things like that. So PSG is just, otherwise it is just a theoretical exercise for study purposes and comparison purposes. Okay. Right.
Yeah, thank you, Ms. Anjana. It was a nice deliberation. Let me call upon Dr. Saurabh Mittal online. As you all know, he is an international figure, especially he is an international sleep specialist certified by the World Sleep Society. He had completed his MD and DM from All India Institute of Medical Science, and currently working as assistant professor in pulmonary and critical care sleep medicine at AIIMS, New Delhi. And I'm known to him because his area of special area of interest includes interventional pulmonology as well as the sleep disorders. I think he is the right person to talk on CPAP compliance and how to improve CPAP compliance. Dr. Saurabh, are you online?
Hello, sir. I have provided my talk by a recorded lecture.
Okay. Yeah, thank you.
We are going to talk about CPAP compliance and how can we improve it. So as we all understand as sleep physicians, that compliance to CPAP therapy is essential for good treatment outcomes in patients with sleep apnea. So we will see in this talk that how do we measure the compliance and what all measures we can take to improve compliance. So we see that CPAP remains the most effective treatment option for most of the patients with obstructive sleep apnea. The key to a successful therapy with CPAP include appropriate follow-up. The problem in the current scenario is that a lot of patients do not initiate CPAP therapy, or those who initiate therapy, they do not continue the therapy. So monitoring of the treatment and sorting out problems during the treatment will improve the success of therapy. If we look at the current scenario of sleep medicine, there are various problems which are there, such as that use of CPAP downloads is not done in a lot of clinics. Patient education regarding the disease or the treatment options is not there. And obviously, in our setting, cost factors remain a major hindrance to a successful CPAP therapy. So once we prescribe a patient with CPAP and patient starts the CPAP therapy, then comes the question of that how do we monitor therapy? So monitoring of CPAP therapy is usually done by use of CPAP downloads. CPAP downloads means that the machine which the patient is using has a recording and which tells us about the various aspects of therapy. So why do we need a CPAP download? I'm not sure how many of you have used or seen a CPAP download. So we will see in this presentation that how a CPAP download looks like and how do we interpret it. But the first question is, why do we need a CPAP download? So first is to monitor the adherence to the therapy by the patient. Secondly, to assess the effectiveness of CPAP therapy. And next, about the troubleshooting. That means if we find a problem during the CPAP download, we can do troubleshooting and change some settings or do something to improve the effectiveness of therapy. So how do we assess the adherence? The first question comes, supposedly you start a patient on CPAP, when do you assess the adherence to therapy? So ATS recommends that between 7 to 90 days of therapy, we should do first assessment to adherence. So if you have a CPAP download, the CPAP usage by the patient is displayed by two parameters. First is the total percentage of days used. Means if you are measuring for the last 3 months or 90 days and patient has used it for 60 days, then the compliance would be somewhere around 66% as per the percentage of days used. And the next thing comes the percentage of days when patient has used the therapy by more than 4 hours. So these are the two parameters which are given on a CPAP download. So this is a CPAP download for a 35-year-old male. If we look at the compliance report, the upper column shows the date range. That means how many days you are looking at in the report. So this is a 34 days chart. So if you look at the number of days patient has used the CPAP machine for more than 4 hours is 82%. That is percentage adherence based on more than 4 hours use. And second thing we have to look at what is the average duration when patient is using CPAP. That is average usage during the days used. For this patient, it is 7 hours and 39 minutes. So these are the two things which we have to see during a compliance report reading. If you look at the further details of the compliance report, the next thing comes about the mode. So first we look at the usage and duration and compliance. Then we look at what is the mode which is being used. So here we have an auto CPAP mode. Then next is the EPR. So a lot of you might be aware of the EPR feature or the flex feature in CPAP machine. EPR means expiratory pressure release. That means when patient is trying to exhale, the CPAP pressure goes down to allow the patient to exhale against a lesser pressure. So it kind of provides better environment for patient to exhale rather than a higher pressure against which patient faces a difficulty. So these are the things which are seen during a compliance report. Now the next point we have to look at the effectiveness of therapy. So we look at the compliance of therapy, then we look at the effectiveness of therapy. So effectiveness of CPAP therapy can be measured by the AHI, that means the Apnea Hypopnea Index, which is the classical measure which we all use during the polysomnography. To measure this, we require oximetry, arousals, as well as airflow. But the problem is, once you have a patient on CPAP machine, they do not have any oximetry or any arousal. So they have only airflow. So based on the airflow, a lot of machines do provide a residual apnea hypopnea index. That means once a patient who has been initiated on therapy, what is happening to his AHI? Supposedly his baseline AHI was 90. You start the patient on a CPAP, which may be auto or fixed CPAP, and he comes back to you with a download and which shows a AHI of 7. So that means by the therapy, his AHI has been reduced to 7. So this feature is given by a lot of machine, although it is a good parameter, but it is just a surrogate of what we measure during the polysomnography. So for effective assessment, a AHI of less than 10 is usually considered adequate, although for ideal measures, it should be less than 5 to consider that therapy is fully effective to reduce the AHI. So the next portion of the CPAP download gives us the therapy where we look at the AHI. So AHI has two components, apnea index and hypopnea index. And the combination comes as AHI. The machines also give us whether the events of apnea are central or obstructive. So a lot of machines do have this feature of central and obstructive. Not all machines do have this. So machines measure this central or obstructive by the open or a closed airway. Means if machine faces a resistance during the flow, they label it as an obstructive apnea. And if they do not face, they call it a central apnea. So this is what we need to read from a CPAP data download. So that's how we look at the compliance of the therapy and effectiveness of therapy. So a lot of you might have seen the therapy reports in your clinics. So these are the two examples. The first one is from the ResMed. The second one is from the Respironics. I'll just show you a little bit of difference what they have. So ResMed therapy do give us a 95th percentile. Whether it is the leak, whether it is the pressure, the ResMed therapy gives us a 95th percentile, while the Respironics gives us a 90th percentile. That means there is a little difference in measurement between the two machines. The ResMed machines will give us a leak in liters per minute, which is here, that is 18.7 liters per minute, while Respironics machines will give us a leak. They will say that average time is spent during the large leak. So these are the little differences between the therapy reports provided by different machines. But we have to understand that these are the key parameters which we have to look at during reading a compliance. Now we go to the how can we improve the CPAP compliance. So we'll go to a case and then we will see how do we troubleshoot and improve CPAP compliance for a patient who has been initiated on CPAP therapy. So a 54-year-old female who was started on an auto PAP device with a fixed pressure around a week ago now complains of intolerance to therapy. She is embarrassed to use it in front of her husband and feels that the pressure is suffocating her as soon as she turns the machine on. She is also having difficulty in exhaling while she has CPAP device on. She says that she has not used it more than 1 hour at most nights. So before she takes it off. So there are many problems in this patient, and we will see that how can we address all of these by various methods which can improve the compliance to therapy. So how common is non-adherence? If you look at the data, it is estimated that almost 25 to 83% of patients who are started on CPAP therapy are non-adherent. And on an average, it is like 50% of the patients do not continue the CPAP therapy with which they are started. So how do we define adherence? The traditional definition of adherence is that patients who are using CPAP for 4 or more hours per night for 70% of nights. So this is a definition which a lot of us know, read, have seen in books, presentations. But this definition actually applies to the Medicare beneficiaries in USA. This definition does not have anything to do with the clinical benefit. So although most of the machine who will give compliance will give on this parameter only, the patients who have used the machine for more than 4 hours, they will give the percentage of compliance based upon that. But this does not apply very well to clinical benefits. In clinical setting, what seems more appropriate is more CPAP is equal to more improvement. So this was a study which was published in 2007 and which looked at the duration of night CPAP use with the percentage of patients with normal values on Epworth Sleepiness Scale, Sleep Questionnaire Functional Outcomes, and MSLT. If we look at that, the functional outcomes improve between the 4 to 5 hours, ESS by 7, and the MSLT at around 6. So most of the outcomes tend to plateau after 7 hours of usage. So what seems more appropriate in clinical benefits is that around 6 to 7 hours of CPAP usage does lead to improvement in sleepiness as well as functional outcomes of patient. So this definition of 4 hours per night holds true for Medicare beneficiaries to continue the therapy, but for clinical outcomes, we need to tell the patient that they need to use the machine for at least 6 to 7 hours, or the best prescription is that they should use the machine whenever they sleep, which should be in most of the patients around 6 to 7 hours. So what are the factors which affect the adherence or compliance? So there are various categories of factors such as demographic or social variables such as socio-economic status. So those patients who are poor or have to pay from pocket, or those who cannot afford, obviously they will not be continuing the therapy. Smokers are less likely to continue CPAP therapy. The patients who do not have any social support, they do not tend to continue their CPAP therapy. Patients by partner involvement or marital status also affects their adherence. Means somebody who's unmarried sleeps alone, nobody is bothered by his snoring, so they will less likely to continue the therapy as compared to those whose bed partner is kind of bothered by their snoring and they tend to continue the therapy. Patients who have more severe disease, more severe OSA, or more severity of symptoms such as daytime sleepiness or letharginess, they are more likely to continue. Patients who develop dry eyes, dry nose or dry mouth or nasal congestion, or those who have problems with the mask are less likely to continue therapy. So these are the factors which we have to realize that they are truly associated with affecting their adherence, and we have to address all of these to improve the adherence of the patient. So what are the factors which have actually shown that adherence can be improved? So there are 3 things. First is the behavioral therapy and patient education. Then we have to do side effect management. And there are few drug trials which have also shown that they can improve adherence to CPAP. So patient education plays a key role. So it has been shown that patients who were satisfied with the information and communication by the sleep doctor are more likely to use and continue using their CPAP. And what is more important is that this education should continue to be provided at multiple contacts with the patient, including the initial physician consultation. Means you tell today, and at every contact with the patient, you continue to educate them about these OSA, use of CPAP, and importance of adherence. What all this patient education should highlight: the potential benefits of the therapy, how do the device works and how to take care of the device, and what are the ways they can eliminate side effects which are associated with device. We will discuss all this in further slides. So next is important thing is that what determines the long-term adherence is that what happens in the short term. You start a patient on CPAP and at 3-day or 4-day you realize the patient is not using. That means he is not going to use it in the long term. So those who have early compliance, they will have long-term compliance as well. It was shown in this study that the compliance was measured at day 3 and day 7, and the patients who were compliant at day 3 and day 7 were more likely to continue using therapy at day 30. That means you can identify the non-adherent patient by day 7, that if by day 7 they are not using their therapy, it is likely that they will discontinue their therapy in future. So what all can improve is the frequent follow-ups. Means it should not happen that you prescribe a patient CPAP and then you forget it. It should not happen. Patients should be asked to follow up, especially during the first 2 weeks, because that is the period where patient has to kind of acclimatize with the machine. They will have a lot of problems. So you may have additional sleep staff or lab staff who can help out the patient with the therapy. They can be contacted by telephone to assess their problems and the compliance to the therapy. Nowadays, a lot of devices actually have a patient user interface which gives them a daily motivational feedback. So this is from a ResMed machine. They will give that how long the patient has used the machine, what was the mask seal, what was the residual events, whether they removed the mask in between. And this score kind of motivates the patient that if they are doing bad, they have a chance to improve. And if they are doing good, they can monitor their therapy. So this is for the patients to use at their home to monitor their therapy. The next thing is the behavioral therapy. So cognitive behavioral therapy also improves CPAP compliance. What is CBT? It's a structural psychotherapeutic method which is used to alter the attitudes and behaviors. So this efficacy of CBT in education has been reported in several clinical trials. So examples of CBT for CPAP users include that we have to show the patients about the videos of the real CPAP users, information experience of other CPAP users, relaxation techniques, and education and mask fitting. So next comes the question of side effect management. Because if patient develops side effects, they are less likely to continue. So how do we manage? One is the dryness. Dryness of the nasal passage as well as throat is very common. So humidification can actually improve nasal congestion and may improve the adherence. There are patients who complain of leaks. So if you start a patient on a nasal mask, they may have some mouth leak. So you can have a chin strap which can allow the patient to close their mouth so that it reduces the air leak. And some patients may have aerophagia during the initiation of CPAP therapy. So this can be improved if you switch the patient to APAP, because auto PAP usually have a little lesser pressure, mean pressure as compared to fixed CPAP therapy. So there are some modifications which can be made in therapy which will improve the patient's compliance. Now we go up at the mask. So choosing a mask at the initiation of therapy is very useful. So you show the patient all masks, ask them to choose, use them in the clinic so that they can decide which mask is best for them. So if you have started a patient on an oronasal mask, the problem is that most patients who have oronasal mask will have some residual AHI or leaks as compared to nasal masks. Although it has not been shown that changing the mask will improve the compliance. However, in general, what we should do, that nasal masks are preferred over full face or oral masks for the treatment of OSA. Nasal pillows are preferred over nasal masks, but the problem is if patient is at very high pressure or on a BiPAP, then nasal pillows may cause leak as compared to the nasal mask. So in general, for patients who do not require very high pressure, nasal pillows seem a better option. Otherwise, a nasal mask is good. Those who do not tolerate nasal mask alone, they may be advised a nasal mask with a chin strap, or they may be switched to a oronasal mask to improve their therapy. Now, looking at the pharmacological options, whether there are any drugs which can actually improve the compliance. So this was a trial which came around 10 years back, which looked at the use of S-zopiclone as a therapy for patients with obstructive sleep apnea to improve their CPAP compliance. In this, patients were randomized to S-zopiclone versus placebo. And in patients who were given zopiclone, the therapy, their percentage night used for CPAP was 64% as compared to 45% nights in patients who were given placebo. And average duration of CPAP use was higher in patients who were given S-zopiclone. So this was one drug which was shown that it can improve the CPAP compliance, while no other drug has been shown to a sustained benefit in improving the CPAP. The another thing which is extremely important and most often missed by a lot of us is the PAP-NAP therapy. PAP-NAP means that you ask the patient to sit during the daytime with a CPAP on. So that's called a PAP nap therapy. It is most often used in patients who have insomnia or psychiatric disorders. So once you start a patient on a PAP nap therapy, they are more likely to complete their titration studies and more likely to use CPAP as compared to the controls. So what does PAP nap therapy mean? PAP nap therapy means that you ask the patient during daytime that they use a PAP therapy. What it does, it reduces the fear of the patient of the mask as well as the pressure. So it kind of desensitizes the patient against the use of mask as well as the pressure which he has. The second thing is that it overcomes the adverse emotional reaction. So once you start a patient on a PAP therapy during a CPAP titration studies or at home, what happens, patient kind of gets fear with what is going to happen to me. So this daytime nap period actually helps the patient overcome this emotional reaction. Also, what can be done, the patient applies CPAP and he watches TV or something so that it diverts his attention from mask or the pressure sensation. So patient kind of gets accommodated or acclimatized to the PAP therapy. So PAP nap therapy is extremely useful in patients who have non-compliance to therapy or the patients who are being initiated on CPAP therapy. So it is good that you ask them to use this therapy during daytime so that they get more comfortable with the use of PAP. So just to summarize, what we have to do before starting the treatment with CPAP, we have to give the individual education. So regarding the health effects of OSA and CPAP therapy, we should tell the patients about the realistic expectations to CPAP. And we should have a bed partner who can help the patient with the better therapy. And once we start the therapy, patient should be asked for an early follow-up. We should use the CPAP data downloads routinely so that we can monitor the compliance and effectiveness and change settings or make modifications depending upon the patient outcome. We should consider other factors which can affect adherence such as insomnia, claustrophobia, psychosocial problems. And more importantly, what should happen, that patients should be told what to do when this happens. So means patient should be empowered so that they can do this troubleshooting at home, or they may be given a helpline number of a technician or someone who can help them troubleshoot at home itself rather than they present it to clinic. So the troubleshooting for the non-adherent patient include like patients who have dry airway, they may be given humidification or heated tubings. Patients who have difficulty in falling asleep or they have awakening, they may use REM or they may be given a small course of hypnotics so that they can acclimatize to the therapy. Patients who have mask leak or discomfort, they will need some adjustment with the mask or a mask may need to be changed. Those who have very much intolerance to pressure, they may be given an option of auto CPAP or a expiratory pressure release option. Patients who have nasal obstruction, they may be given a decongestant like Otrivin nasal drops, or they may be allowed a full face mask. Patients who have mouth leaks, they can use a chin strap or they may use a full face mask. So these are some of the things which can be modified to improve the therapy. So we will go back to the patient which we started with. So this lady who was started on IPAP but now has problems. So she is embarrassed to use it. So what should we do? That we need to educate the patient and spouse that there is nothing wrong about using CPAP. There is nothing wrong in having OSA. So we need to educate the patient and spouse so that she should not be embarrassed to use the CPAP. The next is that she was feeling suffocation. So once you start the patient on a high pressure, they may feel suffocated. So a REM feature, that means slowly increasing the pressure in the initial therapy, may help her in improving her therapy. She is also facing difficulty in exhaling in. So in such situations, we can have an expiratory pressure release, that is the EPR or a flex mode, or we can switch to a auto PAP. And second, lastly, because she has not used it, we need to tell the patient about the expectations and short-term goals, and we may need to do cognitive behavioral therapy so that her compliance can be improved with the CPAP therapy. So in this case, we have seen that there are multiple problems which are there, but we do have solutions for a lot of them. So we need to use all these features so that we can improve the therapy for this patient. So just to conclude, what I would like all of you to take home from my talk is that we need to do a routine use of CPAP downloads. We need to see them, read them, understand them, and use them routinely in our clinical practice so that we can do a better service to our patients. We need to educate the patients before, during, and ongoing therapy. We need to check the compliance and adherence and re-emphasize the need for CPAP adherence on every patient visit. Sometimes we need to ask patient to get machines during follow-ups, and we can do troubleshooting in the clinic itself. And some features such as humidification and expiratory pressure release may be used for most patients to improve their comfort, which may in turn lead to improved compliance. That's all from my side. So this is my last version, that first impression is last impression, which I tell a lot of my residents as well. So once you start a patient on a PAP therapy, you should put your best foot forward in the beginning. Because if you start a patient on a wrong mask, on a wrong machine with wrong settings, and patient does not feel good about it, he will never use CPAP. So that means you choose the correct machine, correct mask, correct settings at the beginning, which will improve your compliance and which will lead to improvement in your patient outcome, rather than giving a wrong machine, wrong settings, and trying to change them later on may not help. So try to do it in the initial few days of therapy rather than delaying it for 2 weeks, 3 weeks, so that we can improve our patient outcome. Thank you.
Any questions from the floor? Is he available online? Dr. Mujeeb?
So Dr. Saurabh is there. And we have 2-3 questions in the online delegates. I will read it, sir. The first question is from Dr. Sharada Vinod. She wants to ask, beyond which pressure can nasal pillow is not to be used effectively?
So nasal pillows actually can be used for all pressures. It is not that they cannot be used for BiPAP or high CPAP pressures. The problem is that they may leak. So you need to monitor the therapy if you start a patient on a nasal pillow therapy beyond a pressure of somewhere around 15 centimeter of water. It is not that it is a contraindication or they cannot be used, but you need to look at the leaks once you look at the download of the CPAP, so that if there is a high leak or if there is a problem, then you can switch the interface.
One more question from the same Dr. Sharada. She wants to ask, will azopiclone is safe in patient with on BiPAP with underlying lung disease or not?
So in general, for patients who have underlying lung diseases, most of the sedatives are not safe drugs. So patients who have underlying lung disease, maybe COPD or ILD, so sedatives are not good drugs.
I think there is some technical issues, right, Dr. Mujeeb?
Yes, sir. I think Dr. Saurabh got loss of connection at their level. And now he's out of session now.
Okay. Yeah, we can go to the next talk.
So till now we have heard excellent talks on obstructive sleep apnea, central sleep apnea, the management, complications, as well as the compliance to the treatment modalities. So the next topic is complex sleep apnea and treatment approach. Complex sleep apnea is a combination of both obstructive sleep apnea as well as the central sleep apnea. In many of the cases, we can diagnose it during the polysomnography itself. But in some patients, after they become non-compliant to the CPAP or when the trouble arises, then only this this modality can be diagnosed. So to talk elaborately on this topic, we have Dr. Praveen Valsan K, who is a lead consultant interventional pulmonologist in Aster Medicity. He has got his MBBS and MD degree from JIPMER, and he had worked as assistant professor in various medical colleges, and currently he is HOD and consultant pulmonologist, and also has worked in as consultant pulmonologist in DC Hospital. Over to Dr. Valsuran.
Thank you, ma'am, for those kind introduction. And let me express my sincere gratitude to Dr. Hari and Dr. Mujeeb for giving me the opportunity for me to be here. So, a very warm good afternoon to one and all. So, I'll be talking on something that is pretty complex. That's a complex sleep apnea, as the name indicates. So, in the next few minutes, I'll be touching on few snippets of the same, and also along with that, we'll see what is it, and the definition of it, the prevalence of it, how it is happening, what are the phenotypes of it, how do we diagnose and manage it, and what the guidelines say about it. And after which we'll have a conversation if the time permits. So what's complex sleep apnea? As Dr. Sophie has already mentioned, those patients who has obstructive sleep apnea who started on CPAP or underwent a CPAP titration, they develop central events. So that which was in fact many a time it was not there, or sometimes it was there and it is continued. So that is called as a complex sleep apnea. So initially it was called as the treatment emergent sleep apnea, then later the term changed to complex sleep disordered breathing, and now it's called as a complex sleep apnea syndrome, which is the common term that is used. So the ICD-3 definition says that, of course, the first criteria is that there should be an obstructive sleep event, followed which we do an titration study, and in the titration study there is a significant resolution of the obstructive events, and either a new or those central events which was there is being persisted. So that's called as that is a central sleep apnea. So it should have at least more than central events of more than 4 events per hour, and it should also be there for at least 50% of the total events. So and this phenomenon of course cannot be explained by any other central sleep disordered breathing. What's the prevalence? Just like in OSA, of course, the males far outweigh the number as opposed to that of the females. In OSA, if it is 60%, when it comes to CS, central sleep apnea, it's almost 80% in males. And probably because of the increased hypercapnic ventilatory response that is seen in the males, we'll see it's primarily to do with the carbon dioxide and its chemical changes that happens in the internal milieu. The prevalence is between somewhere around 0.56 to 18. It's a vast prevalence primarily because it depends on the type of the population that we take and the type of the comorbidities that is included in that. If you remove all the comorbidities, in fact, the prevalence might fall down. Of course, the highest prevalence is reported in those patients who has a congestive heart failure. And if we take the BNP into consideration, then to remove the fluid overload or the congestive failure, then of course the percentage will dramatically fall. So this was the study looking at around 1,700 odd patients who underwent the CPAP titration, of which 1.57 had a central sleep apnea. In fact, 10 patients, that is 0.56% of the patient had what we call as the new onset central sleep apnea emergence, and 18% had, that is 1%, 18 patients, that is 1% had a continuation of the persistent sleep apnea. And when ASV, adaptive servo ventilation, was tried, in fact, all the patients did respond. So which means that in fact the prevalence of the central sleep apnea, and these are the patients in whom there is no evidence of heart failure or fluid overload, by which they have taken into consideration the BNP in these patients. So if we see that those patients who does not have any of these comorbidities, in fact the sleep apnea, the central component is not very high. A study looked into the clinical heterogeneity of the patients with the complex sleep apnea syndrome. And as you can see, they looked into 150 odd patients, and what was found is almost 2/3 of the patient had some of the other comorbidities. And in fact, the major comorbidities were all cardiovascular, that is coronary artery disease, congestive heart failure, hypertension, stroke, AF, etc., etc. But what is most surprising is that there is almost 1/3 of the patients who did not have risk factors, in fact. We'll see the pathophysiology. So in fact, we know what happens in wakefulness. Wakefulness, we have a voluntary control over the breathing. So in fact, the breathing is in fact controlled by a combination of the voluntary or the behavioral control along with the various metabolic factors. And in fact, if we want to change our breathing pattern, we definitely are able to do it. But when the patient goes into sleep, this is not happening. So which means that there is a withdrawal of the voluntary control, there is a withdrawal of the behavioral modification, and there is of course a blunted chemosensitiveness of the that happens in the due to the changes in the chemical milieu that happens in this patient. So there is an interaction between the upper airway obstruction, there is an unstable central ventilatory control, and a host lot of other condition which is primarily pertaining to the host, and all these lead to a combination of the breathing difficulty, breathing instability, changes in the upper airway resistance, which we will be seeing, and changes in the carbon dioxide level, which is central critical to the development of these central apneas. All these lead to an oscillating variable sleep state. So if you look at why it is happening, there are four hypotheses that's been, or four reasons that has been cited primarily. One is the altered carbon dioxide response. So these patients, when they are the OSA patients, when they are started on a CPAP, their airway becomes normal, their airway is completely patent. And when there is a patent airway, the gas exchange improves, the carbon dioxide turnover improves, there's a removal of the carbon dioxide, and in a subset of the patient, in fact the carbon dioxide falls below the apneic threshold. That's the time when this the oscillation in this respiratory pattern happens, that is the central CSA happens. Then second is the over titration with CPAP, and that's very, very common. And in fact, so what happens when there is an over titration, there is an activation of the stretch receptors, the lung expands more. And when the lung expands, there is an activation of the what is called as a Herring-Buer reflex. So the stretch receptors will in turn tell the brain, okay, to stop breathing, to stop expansion. It is a way, in fact, to protect the lung. So that's the Herring-Buer reflex. So over titration will definitely lead into the significant oscillation, which can lead into the formation of the central sleep apnea. Then there is an instability in the ventilatory control, that is in some patients, in fact, CPAP can worsen their quality of the life, primarily because, as we have seen in the previous talk by Dr. Mittal, that there are a lot of factors which can lead to the non-compliance in the patient. The patient, they are not comfortable with the PAP therapy, the mask, the leaks, etc., etc. So all these leads to frequent awakening, and this awakening can lead to an imbalance in the ventilatory system control. Similarly, these imbalance can also lead to oscillation in the carbon dioxide, and that can again lead into the same pathology. And also the external and the internal triggers, especially the various comorbidities, the various problems of the patient, like for example the patient with multiple cardiovascular risk, etc., etc. All these leads into an intrusiveness into the PAP therapy, and that again makes the patient wake up multiple times in their sleep. So, so the thing is, so all this ultimately leads to sleep fragmentation. So, is it the sleep fragmentation, whether the cause or the effect, or it's a both of central sleep apnea, is always a question. So this is what I just mentioned. So we have the central sleep apnea in these patients. Primarily, one reason being the relief of the upper airway that leads to the better gas exchange and the PCO2 dropping below the apneic threshold. Second being the over titration that leading to the activation of the Herring-Buer reflex, and then activation of the central apneustic response, which stops the patient from breathing. The third being the various extrinsic and intrinsic causes. There's a patient's inherent problems, which also again leads to awakening and the imbalance in the ventilatory drive. So there are a lot of risk factors that has been looked into, and probably the most important being the sleep insufficiency, that insufficient sleep arousals, very, very common, multiple arousals. The other being that excessive titration, which I just mentioned. And there are some subset of the patients, like for example, post hyperventilation, post arousal syndrome, like a patient who is being coming out of the and surgery and then coming out of various sedatives. They all can develop an post arousal apneas. Excessive mouth leakage, which is very, very common in many of these patients. And misclassification of the central hypopneas, split night errors, which I'll just be talking later on. And in fact, the other important thing is the masks and the air leaks that happens in these patients. So the studies have shown that especially when many of these patients are being titrated with a nasal PAP, the inherent leak of the nasal PAP or the leak through the mouth can act as an inherent reason why these patients develop a central apnea. So this is the study that looked into the air leak during CPAP titration as a risk factor for central apnea. 310 patients with OSA. They looked into the leaks that happen. So the average and the maximal total and unintentional leak, as you can see, is more in those patients who has an central events of more than 5. So they divided into 2 groups, that post titration central events less than 5 and more than 5. And similarly, even for those patients, they looked into the average and maximal total and unintentional leak in those patients who are on nasal PAP, and they found that both was quite significant. So air leak has an important association with the treatment of the in the emergence of the central sleep apnea, and the reason being that these leaking masks leads to an increased carbon dioxide washout, primarily because the machine itself tend to compensate the leak, and many a time this compensation leads to overcompensation, and that leads to the removal of the carbon dioxide, and that is basically an increase in the dead space, and all these leads into central apneas. So there are 3 phenotypes. It's not exactly phenotype, 3 types that we can actually look into. One is the treatment emergent central sleep apnea, by which I mean is that these patients did not, of course, had as the central apneas in the baseline, but once titrated, they did develop. And these patients are the subgroup of patients who can actually be treated by the continuation of the CPAP therapy. Primarily because these central events develop is mainly because either because of the air leak or because of the various inherent problems with the patient itself, or like say the improper use of the mask and the patient's not compliant with the device, etc., etc. So once we, as Dr. Mittal has already mentioned, that once we start, making the patient use it more and more, these patients will become compliant, and their central apneas might abrogate. The other is the treatment persistent sleep apnea, by which I mean is those patients who did not have a CSA, once they start titrating, they will develop a central sleep apnea, and that persists even after continuing for a long time. So these patients will not become better even if we continue the CPAP. The third group of patients is the treatment resistance, these are subgroup of patients who already had a central events, that is, they had a mixed events initially itself, and these patients, once we start them titrating, the obstructive events are removed and the central events are being continued. So preventing a misdiagnosis is important, because especially the TEXA, that is a treatment emergent central sleep apnea, disappears after continued use of the CPAP. Diagnosis, of course, I don't need to say that, the basis on the PSG, and we do a titration and we see that these patients develop a central event. So coming to the management, so can we predict this a priori? So that's a question by looking at the various factors that is available with us. So if the subject has a central events initially itself, the more the chance that these patients will have some amount of central apneas even after titration. Severe OSA on diagnostic study, they have a higher chance of developing central apneas. The degree of the architectural distortion and the hypopnea density in the NREM sleep is an important predictor, more than an REM sleep, more than the ones in the REM sleep. NREM sleep is an important predictor of having a central apneas. Those patients who has a higher events in the NREM sleep, and more often in the supine position also, these patients also has a higher chance of developing and complex sleep apnea, and also had more elevated arousal index in these patients. And those patients who has a more arousal index also has a higher chance to develop central apneas. And very common, when we see a patient who is non-compliant, of course, we need to see whether these patients has a central events or not. So prevention is better than cure. How can we prevent it? We need to look for all the the risk factors that I mentioned earlier. In fact, many of these can be corrected, and if we can correct it, of course, these patients will become much more compliant, and they will have and many of their central events will be abrogated. So that, like says, improvement in the sleep efficiency, the improvement in the use of the machines much more, the proper use of the mask, the plugging of the leaks, misclassification, like use of any other things like opioids, etc., etc. Split night errors is important, because that is one thing that has always been said against the split night study, that these patients, when we do a split night errors, we hardly do it for say 3 to 4 hours. So these patients can have their total sleep time which is shortened, and they don't go in for an deep sleep, what is that, REM sleep. So the REM sleep onset is latency is increased, and when they don't get a good REM sleep, these patients have a higher chance of being misclassified as an central sleep apnea. So if we treat them, if we do a proper full-fledged sleep study, then we can see that they may not, some of them may not even develop a central sleep apnea. So the more REM percentage, it's associated with a better CPAP titration. So this study looked into the efficacy of the split night study, which I just mentioned. 60 patients in the CPAP as well, the split night as well as the full night study. And as you can see, the unsuccessful titration was almost 50% in the split night group versus 16. That is almost 16 patients. That is 35% in the full night group. And in these patients, when they looked into the REM sleep, in fact, the REM sleep was much more in those patients who had a successful titration, that is a full night study group. So what are the interventions that can be done? Of course, as I mentioned earlier, we have two problems in this. That is, one is the obstructive events in this subgroup of patients and their ventilatory dysregulation. So obstructive events can easily be controlled by our CPAP, that is a continuous positive airway pressure. So how can we control the ventilator dysregulation? So for which, for the treatment emergent, it's primarily the continuation of the CPAP. The other group we can either try with the trials has been with an BiPAP with an ST mode, the adaptive servo ventilation, use of the medications and supplemental carbon dioxide or increase in dead space. So of which the major trials and the approval is primarily for the ones with the BiPAP or the ST mode, or the better with the ASV. So as I mentioned, CPAP, of course, it can be continued. So we need to look at those subset of patients who has this what is called as a TEXA. So if so many of those patients who has the classic and emergent ones, and if we titrate them properly, if we give them a good advice, if we educate them, they many of them will have an correction of their sleep efficiency. But there are subset of patients who will not improve, so that is called as a treatment persistent sleep apnea. So in those patients, we need to support their ventilation during their central apneas and avoidance of the carbon dioxide oscillation, which is the prime reason. So how can we do that? One is the BiPAP in the ST mode. So the EPAP in the BiPAP will eliminate the obstructive events. Sorry. And the IPAP can decrease the hypoventilation and the overcompensation that can happen because of their central event. So that's so IPAP. So the patients in the ST mode. So if the patient does not take a breath, the extra breath will be delivered by the machine, so that it can support the ventilation and even initiate breathing during apneas. So the problem is that when these machine itself decides, they can sometimes the pressures goes very high and that can go in for an hyperventilation state. Again, the same problem can be continued. That's the carbon dioxide washout, etc. And of course, optimizing the patient ventilator asynchrony is also very important in these patients, because if it is not, the patient will wake up multiple times and again the same problem happens. So that is to some significant extent controlled by the ASV, that is the adaptive servo ventilation. So what is adaptive servo ventilation is basically, as the name indicates, it tries to adapt to the patient's needs and the patient's ventilatory requirements. So it automatically determines the extent of the ventilatory support that needs to be provided to the patient on a breath by breath basis. So it analyzes each and every breath and decide how much pressure support that need to be given. So we have So the EPAP is, of course, provides obstructive support, and the other part which the machine will deliver by looking at the breath by breath support. So we have two models in the ASV. One is the ResMed's or the CS2 machine, and the Respironics BiPAP Auto SV. Of course, we have newer ASV algorithms, which those are advanced algorithms, which are looking at the automatic expiratory pressure adjustments, etc., and other auto backup rate, in which even if the patient does not breathe and things, there are a lot more other variations that has come. So the important thing about the ASV is that if this analysis of the breath by breath is basically looking at the pressures that happens inside the mask, so it has to be a well-fit mask. That's extremely important when we are using an ASV. So this is the trial looking at the CPAP versus the adaptive servo ventilation. It's a multi-center randomized prospective trial. 66 participants, 33 in the CPAP group and 33 in the ASV. The baseline AHI was 37.5. And they looked into day 2 and day after 90 days, and there was improvement. But the improvement, as you, these are the demographic factors. It's almost comparable between both the group. So this is the graph which looks at the ASV group versus the CPAP group, and as you can see, the 2 days and the 90 days. So in which the central component is much more in the those patients in whom the CPAP is continued, whereas the ASV has a dramatic reduction in the central component. So so that, which means that the ASV does a significant good job than continuation of the CPAP. Then pharmacotherapies has been tried, but it's as a last resort. There are hardly much studies about it. Theophylline and acetazolamide has been tried. That's primarily, changing the chemical and the internal milieu of these patients. So that's not to be used as a single therapy. It has its own limited use and its side effects. There are other things that has been tried, is the stabilization of the NREM sleep by improving the sleep hygiene, by improving their regular sleep-wake times, use of the traditional sleeping pills, etc. Just a few more slides on the emerging therapies. So the emerging therapies, as I mentioned, it's primarily the core reason is primarily the carbon dioxide and the chemoreceptor changes that happens in the body. So this chemoreceptor reflex is modulated by the emerging therapies. So when the carbon dioxide falls, below the apneic threshold, that's the time when the central apnea falls. So our aim is to keep the carbon dioxide above this threshold level, thus making this disease primarily purely an obstructive in nature. So one is by giving a positive airway pressure gas modulator, a PAP-GAM. So it's basically an PAP-GAM device that is kept in line with the positive airway mask that delivers a precisely specific concentration of the carbon dioxide, thus trying to keep the carbon dioxide level just above the threshold. So, but then of course we need an experienced technologist to do all these. These are all primarily the research purpose, and there are of course few studies also with that. This is one such study. They looked into 6 adult men with poorly controlled mixed disorders. They gave a flow-independent addition of the incremental concentration of the carbon dioxide during sleep, and the result was immediate. In fact, there is an immediate response to the addition of 0.5 to 1% carbon dioxide, and the RDI reduced to less than 5 events per hour. This is other thing. So the carbon dioxide, one is that by the addition of the carbon dioxide, we can keep the carbon dioxide below above the apneic threshold. Second is by increasing the dead space area, by which we can again increasing the level of the carbon dioxide in that area, and thus keeping the carbon dioxide level above the apneic threshold. So that is the enhanced expiratory rebreathing space, EERS. So it tries to increase the dead space in a positive pressure, and thus leads to an increase in carbon dioxide. So a very simple thing. They, instead of using a vented mask, they used a non-vented mask, and they used an ETCO2 sensor to look at the level of the carbon dioxide. So it's a highly leak intolerant setup. And then in the normal patients, the normal sleep results in almost 2 to 8 millimeter increment in the ETCO2. So in the study in which they looked into 204 patients, and they kept the carbon dioxide around 1 to 2 millimeter above the apneic threshold level, and for which around 100 to 200 ml of and dead space was required extra. And they found that there was a significant improvement in their the central sleep apneas. So what does the ERS task force on the guidelines talk about? The members of the task force were very clear that we need to, the term is always a treatment persistent central sleep apnea. They do not, in fact, those patients who has comorbidities, the cardiovascular comorbidities who actually fall into, who has central sleep apnea, these patients should not be classified in this so-called the treatment resistant central sleep apnea. We need to look at all the risk factors that we mentioned earlier, and somehow we have to control that part to see whether these central sleep apneas may abrogate over the time with the continuation of the CPAP. And ASV has been shown to effectively improve the the treatment persistent sleep apnea compared to oxygen, carbon dioxide, BiPAP, ST, and other NIV modes. So the take-home message is that the patient with, so central sleep apnea is those patients with OSA started on CPAP, develop a new onset central apneas, and that is that, and we need to look at only primarily the treatment persistent sleep apnea. Of course, we need to, we should not misdiagnose those patients who has a treatment emergent sleep apnea and start them on an ASV, because primarily the ASV, primary reason is ASV is much costlier than a normal CPAP. The chemoreceptors and the changes in the carbon dioxide milieu plays an important role. And from practical standpoint, one needs to pay very close attention to the mask interface, its leakage, and the sleep efficiency and the amount of the time that the patient sleeps with the CPAP to see whether these patients will become better with the continuation of the CPAP. And for persistent complex sleep apnea, ASV is an ideal solution. Thank you for patient listening.
Thank you, Dr. Praveen, for that elaborate deliberation on this topic. I think we can take one or two questions.
You speak about full night sleep study and split studies. How do you justify a split study when, middle of the night you wake up this patient, then put them in a titration for the first time? That intolerance of the CPAP. Now, how reliable will that split study
yes,
be?
that's exactly one reason why these patients do develop central sleep apnea. So because I'm sure the guidelines also talk about split night study as and mode of way we titrate the thing. So that is why the study was conducted, in fact, looking at why these patients do develop. So split night study is one of the cause why these patients develop a central sleep apnea, and if it is there, we need to retitrate these patients for a full night study and see whether it abrogates or not.
So better than separate studies.
Yes, yes.
Thank you.
If the patient do have a sleep, central component.
Excellent talk, sir. Just a comment. Around literature is showing around 90% of the time, the treatment emergent central apnea will gradually settles with CPAP and other coexisting correction of comorbid like cardiac and other comorbidities. But very rarely we go into adaptive ventilation, but only when CPAP, as you some CPAP is resistant cases. As Dr. asked, the question is the split night and also aggressive titration, rising the pressures very quickly will also create CO2 washout and lead into complex treatment emergent one. But it's also one of the modality, considering the cost factor, the waiting period, and all other factor. We also used to do split night also.
So of course, the over titration is a very important problem, because especially because we tend to overlook that many a time. We just do it and see, okay, this is the pressure, we give it, and then they go off. And if you set that pressure in a manual CPAP, and otherwise of course these patients are on auto CPAP, then it's okay. But otherwise, if they are on a manual CPAP, it's going to create a lot of problem for them.
Dr. Praveen, one question. After initiating a patient on CPAP or BiPAP, so should we check again polysomnography? With polysomnography, should we check again for the development of any central sleep apnea after some time?
No. As we see, if we can download that report, we see that there are apneas, and then in fact even most of these if you look at their the thing is, if we download it, we can see a lot of central sleep apnea. In that case, if we look at their graphs, we can see that they will have this periodic breathing. So that is enough to diagnose an central sleep apnea.
Okay. So we can close this session and move on to the next topic.
Thank you.
This is the last one. All right, the next session will be delivered by Dr. Sunil Abraham. He is a consultant orthodontist at Lakeshore. He is BDS and MDS in orthodontics from Savita Dental College and Hospital, Chennai. Present position is consultant orthodontist and endofacial orthopedician, Sacred Heart General Hospital, Charthala, St. James Hospital, Chalakudi, and VPS Lakeshore. He was the civilian orthodontist at INHS Sanjeevani, Southern Navankapand for 9 years. He is also founder convener of Cochin Orthodontic Study Group. With this, I request Dr. Sunil to deliver his talk.
Very good afternoon to you all, and thank you for the kind words of introduction, sir. So the topic that I am talking today is, it's about the role of mandibular, the role of oral appliances and the mandibular advancement in the treatment of OSA. So thanks to the Lord Almighty for this moment, and thanks to the organizers for this opportunity. I will start off with the anomalies of the facial skeleton and the oral structures and dental malocclusion can contribute to OSA as a cause. In the first boy, you can see there's a severe vertical maxillary excess, there's an incompetence of the lips, a steep mandibular plane, and there's an excessive tooth show. Second boy, you can see there's a maxilla is small, you have the mandible that is longer. So here obviously the airway behind the maxilla is much narrower. This is another vertical maxillary excess. Look at the severe incompetence. So the patient is obviously a mouth breather. Again, look at the overjet. The horizontal distance between the lower teeth and the maxillary and the mandibular teeth. It's almost 12 millimeters. How do you expect a child to keep the lips closed? And you expect a nasal breathing to happen? No, it is practically not possible. Again, here is an anterior crossbite. The upper teeth are totally locked behind the lower anteriors. So the maxilla just cannot develop, and the problem starts right from if it is a milk tooth from 1 year, or if it's in the permanent dentition from around 6 years, you start seeing a problem. Again, here is a class 1 patient. Maxillomandibular relations are correct, but see the dental complication. It's so narrow an arch, the severe crowding and a crossbite there. So all such anomalies can cause can lead to OSA, or the problems leading to OSA. So most of the articles of pediatric OSA will talk about adenotonsillectomy as the gold standard in the management of pediatric OSA. But we saw a lot of facial anomalies. Such facial anomalies will prevent the child from restoring the nasal breathing after the surgery. So an orthodontic treatment will correct the facial and dental anomalies and restore the normal function utilizing the growth modification protocols. So to modify growth, you need to see the patient when the patient is still growing. So the key is to catch them young. You need to see them while the growth is still on. When we talk about the dental and facial deformities, anomalies, we speak in 3 planes. One is the anteroposterior, one is the vertical, and third is the transverse. So when you talk about the anteroposterior plane, we have class 1 where the maxillomandibular proportions are correct. Class 2, skeletal class 2, where you have the prognathic maxilla and the mandible is short. And the reverse is class 3, where you have the maxilla is short and the mandible is ahead. The second component is a vertical growth, vertical plane. You have a vertical growth pattern where you have the classical adenoid face, you see long face, the incompetence of lips, you see the gap, at least around 10 millimeters of space between the upper and lower lip. Imagine that child trying to keep the lips closed. The child will have to stretch the lower lip up with the hyperactive mendalis to get a lip competence. You have the short hypertonic upper lip. you have the everted lower. You can see the increased mucosal show of the lower lip, the excessive tooth show. And imagine this child smiling. He'll definitely going to show at least 2 to 3 millimeters of the gums, a gummy smile, which the children just don't like. Then you have the vertical maxillary excess, and you can see in the lateral cephalogram X-ray a very steep mandibular plane. Just 2 more points to note in this X-ray. This girl is trying to push the lower lip up to cover the upper incisors. This will explain that further. This is the lips at rest. You can see the increased tooth show. The child stretch, you can see the puckering of the chin is stretch the lower lip up to meet the upper lip. So it looks like there's lip competence, but look at this. When you lift up the upper lip, you can see it is the lower lip that covers the upper teeth. So that is a vertical maxillary excess trouble. The reverse is horizontal growth. You can see the mandibular plane is almost parallel to the floor, a reduced lower facial height. There's around 120% deep bite. When you see the facial proportion, you can see the lower facial height is definitely shorter. There's you see the lower teeth is totally covered by the upper incisors. That is the severe deep bite. In the transverse plane, you have problems. Then narrowness of the lower arch. See, when the lower arch is so narrow, you see the crossbite. Lower arch is totally collapsed behind the inside the upper arch. So the mandibular arch is very narrow. The reverse here, it's a posterior crossbite. You have a bilateral posterior crossbite. Imagine the maxillary arch is so narrow, it is so cramped, the tongue will be so cramped for space and obviously tends to fall back. So all these will lead to mouth breathing. The classical picture that you see, the amount of the interlabial space. So when there is a nasal obstruction, say by the adenoid or the tonsils, the reflex is to keep the mouth open for the mouth breathing. So when you can imagine when yourself we have the mouth kept open, the tongue is postured low. So the buccal muscles exert an excessive force on the buccal teeth. That is the hyperactive buccinator mechanism. The tongue is unable to mold the palate. So you have a narrow V-shaped arch. And because of the molars supraerupting, the posterior supraerupting, you will have increased facial height. So the adenotonsillectomy clears the obstruction, but the hypertonic incompetent lips, the vertical excess, will make sure the habit will persist. So priority is given to retrain the child to nasal breathing to eliminate the habitual factors of mouth breathing with an oral and vestibular screen appliance. So enlarged kissing tonsils, enlarged adenoids, all these can be a cause of the mouth breathing. So the Mallampati score has already been elaborated. Class 3 and class 4, very high possibility for OSA. So for identify, the reliable studies are direct nasal endoscopy or a drug-induced sleep endoscopy. That also has been mentioned here by the previous speakers. So the drug-induced sleep endoscopy is the examination that enables locating the site of airway obstruction under the best approximating natural sleep. So you're trying to mimic a natural sleep, a medically induced sleep, to identify whether the obstruction is at the nasopharynx, the oropharynx, or the hypopharynx. You're trying to rule out DNS, bulbous turbinates, adenoids, tonsils, or a larynx, wherever the level of obstruction is key. You can see this is a lateral cephalogram. You can see an enlarged adenoids obstructing the airway so narrow. This is the same patient after the adenoidectomy surgery. But you can appreciate the lip incompetence is still there. So oral screen is an acrylic appliance. It is started only after the ENT has cleared the airway. To prevent the mouth breathing by physically screening the oral cavity with an acrylic shield, to retrain nasal breathing, to do repeated lip exercises every hour to improve the tonicity of the perioral muscles, especially the orbicularis oris. This is one patient. You can see the characteristic incompetent lips and the proclined incisors, the increase of overjet. So this is an appliance like this. It has 2 handles to hold it, and 2 exercises are made to be done every hour. You can see the improvement in the axial inclination. There's definitely an improvement there. As the proclination reduces, the lip competence is much easier. So once the lip competence is better, we mentioned about a deep bite where the lower teeth are not visible at all. So we move on to an appliance called an anterior bite plate. You can see the lower teeth are totally covered. So when the plate is put, there is a disocclusion. The lower teeth, are out of the obstruction by the upper anteriors. So you can see this. It is locked like this. With an appliance, there is a bite opening. So the mandibular lock is corrected, and the mandibular jaw will also start correcting. With few days, you will see a bite opening where the lock is corrected and the posterior bite will settle. So that is how the bite from deep bite it gets corrected to a bite opening, which is followed up by a treatment called a maxillary splint hypal headgear, where the growth of the maxilla is in the downward and forward direction. You take support from the head, and the force is directed upwards and backwards, exactly the opposite in the direction of the growth of maxilla. So this is an appliance. It is to be worn 18 to 21 hours a day. But a lot of improvement. You can see the change, the improvement in the lip competence, the axial inclination, the overjet is reduced. You can see the improvement in the lateral cephalogram also. Second, we spoke about a narrow arch form because of the tongue is not molding the palate sufficiently. So arch expansion is done to overcome the reduced transverse growth of maxilla. In children with narrow maxillary arch and high arch palate, the mandible would follow a foot and shoe mechanism to catch up the restricted growth. With the improved arch form, the airway and tongue posture, the overall development of the dentofacial skeleton improves. There are two types of expansion. When you expand the maxilla as such is a skeletal expansion. Then you expand the arch form with only the teeth are moved buccally. So passive expansion, you have many the whole set of appliances called pharyngeal function regulators. You have pharyngeal 1, 2, 3 and 4. For active expansion, you have rapid maxillary expansion, slow dental expansion, quadrilex. We will see a few of them. So this is the pharyngeal function regulator, a bulky appliance, but well tolerated by the children. See, this is it's basically a shielding appliance. We spoke about the hyperactive buccinator mechanism. This buccal shield is kept 6 millimeters away from the buccal teeth. So the tongue is allowed to remold to expand the arch form, but it is done only when there is sufficient amount of growth remaining, because it's a passive expansion. One case of pharyngeal, you can see the retrocalined upper anteriors, 110% deep bite, which after the pharyngeal and the expansion has come to a well aligned arches. You can see all the teeth are aligned, and the deep bite has been corrected. You can here there is no lower anterior visibility is there. Here lower anteriors are normal. The X-ray, the lateral cephalogram will explain things better. You could see the severe deep bite here. The bite is opened. You have an overjet of around 7 millimeters, which has again been corrected at the end of pharyngeal. So this is a regular slow expansion. This is for the dental expansion we spoke about. Here we are not splitting the bone. It is just you pushing the teeth that is being pushed in by the buccinator mechanism. This is the rapid maxillary expansion where it's a fixed appliance. You exert a very high amount of force. For a removable dental expansion, we do a activation of only 1 turn in 5 days, whereas in rapid maxillary expansion, to cause a skeletal split, we do one activation twice daily. So it's around 0.5 millimeters every day. After the expansion, we take the intraoral occlusal view to confirm the palatal split. This is another versatile appliance called quadrilex. The advantage is it goes along with the fixed appliance. You can see how narrow an arch it was with the lateral incisors totally locked and the canines waiting to erupt. See, non-extraction, we've aligned all the teeth in there. So that's another method of expansion. That's again a dental expansion. So moving to adult OSA, we all many of the speakers said the gold standard is CPAP therapy. But for somebody who is not able to tolerate CPAP, one alternate that we can suggest is an oral appliance or a mandibular advancement device. So oral appliance can be attempted for a patient who is intolerant to CPAP for treatment of primary snoring without OSA. In adult OSA patients with the custom titrable appliance, titration is needed because not everybody the amount of mandibular advancement will be the same. For some person, 3 mm might be sufficient. Some person might need a 5 mm advancement. And for use when you are traveling, when you cannot carry the CPAP around. So that is another indication for oral appliance. When the patient is sitting upright, the tongue sits on the floor of the mouth. So the airway is better. But when the same person goes to supine position with the tongue seating onto it, especially when the muscle tone is lost during deep sleep, you can see the airway reducing. So the 3 appliances we spoke about, one is a mandibular advancement device, it's a tongue retaining device, and a soft palate lifter. This is a custom made mandibular advancement device. It's a single piece appliance where the maxilla and mandibular teeth are covered in a splint, and the amount of advancement, the rough calculation is from the maximum advancement you calculate 50%. So if the person can take around 10 millimeters advancement maximum, we set it at 5 mm to start off with. From there, then the titration you'll have to find out which is the optimum advancement for that person. So this is the appliance outside the mouth. So this is some reviews we did to comparing the efficiency. This is lateral view skull. You can see the normal, and with the appliance you can see the airways improved. With the same with the appliance and without the appliance in supine position, again here it is the airway is holding wide. The cone beam CT was done to analyze the airway in 3D. You will see the analysis. The volume of the airway in the normal was 16.63, while with the mandibular held advanced, you can see it is improved to 29.1. So that's a good improvement with the mandibular advancement device. The sleep study, home sleep study, was repeated without the appliance. It was 12.6, and the AHI with the mandibular advancement device dropped to 2.6. So the mandibular advancement device functionally 3D, radiographically with sleep study, it all showed it is working very well. These appliances I have not personally done. This is for the completion sake. I am just mentioning the tongue retaining devices. It will posture the tongue forward like a suction device, so that the tongue fallback is prevented. Then there is also a soft palate lifter. Again, I have not done personally. Then there are these commercially available mandibular advancement devices, custom made. This has a titrable jig, where the amount of advancement where the lower appliance will hook onto can be advanced as the home sleep study suggests. Another company's product, this is the Dencare anti-snoring device. This is the oronasal airway system, has a nasal dilator and a tongue repositioning component also to that appliance. So the advantages, it's easy to fabricate, easy to titrate the advancement, and convenient to carry it around. But the long-term use, I am an orthodontist, so my concern, the greater concern, is the long-term effect on the temporomandibular joint. Say you hold this your mandible forward for say 7 to 8 hours every day night. So 1 year later the patient comes back and says, I have a temporomandibular joint pain. It is going to be a little difficult to explain that. So to whomever I give a mandibular advancement device, I advise it not for a daily use. We still say CPAP is the best. This is probably for the days when you're traveling, or sometime when you're having a cold, or when you're not able to use CPAP for some reason. So for severe cases where there is a skeletal malocclusion, a craniofacial anomaly, high AHI values, we think of a surgical correction. The surgical plan depends on the level at which the obstruction occurs after carefully diagnosing the level of obstruction by the DISE or the CT or MRI. The success rate of the surgery depends on the accurate diagnosis of the level of obstruction. The commonest surgery was mentioned earlier. Another whole list of surgeries. One of the common one where the orthodontist tries the surgical assisted RME. Earlier I showed you a case of rapid maxillary expansion. That is done only before the growth completion point, where the intermaxillary suture is not fused. By the time 14-15, after the maturity, the intermaxillary suture fuses, you cannot get a rapid maxillary expansion. So that time, under general anesthesia, they do this necessary bone splits, and then the rapid expansion is done. So this is for a 18-year-old girl. We've got a reasonable amount of split to expand the narrow arch. The new, or rather the re-emerging surgery is the maxillomandibular advancement. Earlier this was done only when the other methods have failed, but now this is getting accepted as a first stage of treatment. The advantage of this particular surgery is, wherever be the level of obstruction, this surgery, there is definitely going to be an improvement at any level of obstruction. This is the 3D planning for the maxillomandibular advancement. This particular one is not my case. I have taken it from a friend for the completion's sake. You can see the narrow airway with the maxillomandibular advancement. You can see the airway is really widened. Another methodology is a distraction osteogenesis. You can see the airway widening as the distraction progresses here. This is one case, my first case as a sleep surgery. So this lady was in a high strung job and a severe skeletal class 2 prognathic maxilla with a retrognathic mandible, vertical maxillary excess, deficient chin, severe snoring, excessive daytime tiredness and disturbed sleep. And she had a home sleep study value, AHI value of 16. You can see the X-ray, the prognathic maxilla, the deficient mandible, the narrow airway. Those are the clinical pictures. You can really appreciate the deficiency of the mandible and the chin. You can see the increased overjet, the deep bed, the lower teeth are totally locked inside. You can see this is end of pre-surgical orthodontics. She's been prepared for the surgery. It took around 1.5 years. That's when the COVID pandemic struck and the airports are closed. She was from Dubai, so she was coming on for the preparation. Then we had to wait till the COVID got over. So then she underwent the surgery. This is the treatment planning in 3D. The Leaford one impaction maxilla was taken up by 7 millimeters. So that is the amount of auto rotation mandible got. Bilateral sagittal split surgery, 11 millimeters, and then a genioplasty. This is the pre-treatment, pre-surgical, and post-surgical. You can see the good improvement of the mandibular deficiency, which can be appreciated better on a profile picture. Well-formed chin, you can see a good improvement in the profile. This lady is not using a CPAP now. We have not done the post-surgical sleep study. This will explain things better. 0.52 centimeter was the airway before surgery, which is now improved to 1.61. You can see the improvement of the airway there. So overlap lenses have been shown to be very effective when used properly in appropriate cases. They are not panaceas, however, but in cases where PAP therapy or surgery remains, in many cases, PAP therapy and surgery remains the treatment of choice. From the simple anterior bite plate in pediatric cases to mandibular advancement devices and surgical orthodontics with orthognathic surgery, dentistry and orthodontics can be an active partner in the multidisciplinary team for management of OSA. Thank you.
Thank you, Dr. Sunil. Is there any questions from the audience?
Sir, one question. Till what age we can do this surgery, mandibular advancement?
Mandibular advancement, we wait till 18. After 18, it can be done anytime. We wait for the growth completion. So 18 is the earliest we plan.
Which one will be the preferred investigation of choice, whether it's DICE or MRI or CBCT?
I think DICE is more easily done. Then functional MRI is not very popular here. So I think DICE would be the choice.
Before any maxillomandibular advancements.
Exactly.
Dr. Sunil, I just want to ask, the initial presentations where there was a lot of orthodontic corrections were done, was really for the obstetric sleep apnea or for the dental malocclusion or the cosmetic purposes?
These are contributing to the OSA.
Okay.
It improves the, see, we talk about nasal breathing, but when there's so much of a 12 millimeter overjet, the patient just cannot, even if the airway has been cleared, the patient just cannot go back to nasal breathing.
Correct.
So you do such procedures, you get the lip competence, the patient recovers better.
Okay. Do you think any of the patients were absolutely contraindication for oral appliance? Any such prediction that this is not a case for oral appliance, should not be given?
Oral appliances just cannot be given for a child who's to a person whose growth is not complete. It is given only for adults. Mandibular advancement can be done for a child when there is a definite mandibular protrusion, where the diagnosis is very key. A normal class 1 patient, you cannot plan a mandibular advancement. If the mandible is protrusive, yes, a twin block appliance can be tried.
Fine. One more thing is, many of the patient will have a TM joint pain, as you mentioned. Many of the patient will also have this one bruxism. All this patient will not be an ideal candidate for oral appliance, right?
Correct. Bruxism again is going to disturb the mandibular advance, is going to disturb the occlusion.
Correct, correct.
Thank you.
I think that concludes our session. We, all three of us, thank the organizer for having given us this opportunity.
Good evening all. First of all, I would like to thank VPS Lakeshore, Dr. Lakshmanan and Dr. Mujeeb Rahman and Dr. Rahul for giving me the opportunity to share the session, and also to associate with the Cochin Thoracic Society for this wonderful a theme specific event. And we know COPD OSA overlap syndrome, so almost 10 to 15% prevalence is there in the general population, and it carries significant comorbidities, complications. So it's very much important topic, and we are having Dr. Thomas Wadkan sir, Senior Consultant and Associate Professor, Department of Pulmonary Medicine, Amala Institute of Medical Science, Kochi. Amala Institute of Medical Science, Thrissur, and he is the current president of Association of Pulmonologists, Thrissur, and he is MBBS MD Pulmonology from JIPMER, DRCP UK, and Diploma Boston. And I would like to invite Thomas Wadkan sir for the topic on COPD OSA overlap syndrome. Over to sir.
Good afternoon, everyone. Thank you, Dr. Akhilesh, for the nice words. Today we have been discussing about sleep apneas and sleep-related breathing disorders to a large extent. Now my duty is to deal with the double obstruction, not only in the upper airway, also in the lower airway. So, regards from Amala Institute of Medical Science. We have two departments over there, pulmonary medicine and respiratory medicine. So today's topic is obstructive sleep apnea and COPD. When it comes together, we call it as overlap syndrome. And I'm not associated with any of the CPAP, polysomnography or BiPAP industries. An overview of my presentation, I will be giving a brief introduction about overlap syndrome, and I will be dealing with what is happening in the respiratory physiology during sleep, and how does an OSA patient sleep when while sleeping, what is happening to his respiratory system, and sleep in COPD, the overlap syndrome,
and brief about treatment options in overlap syndrome and recent trends. So coming to introduction, I think the chairperson rightly mentioned about that. Both these diseases are so common in the community, and many times we treat it separately. Sometimes this patient can have both existing in the same person. So OSA is occurring about 10 to 30% in COPD, and its prevalence is same as in general population. Concurrence of OSA and COPD termed as overlap syndrome, and you can see that in adult population, general population, 1% are suffering from overlap syndrome. So now, when a healthy person sleep, you can see the minute ventilation decreases by 0.5 to 1.5 liter, and many times the airway resistance is increased. Our chemoreceptors are not sensitive like awake, and because of that PaO2 decreases by 3 to 10 millimeter, and saturation falls and carbon dioxide increases. So these are the normal physiological changes occurring in a healthy individual. So when in a sleep apnea patients, frequent apneas and hypopnea, this will lead to intermittent hypoxemia. Many times it is associated with obesity. So obesity related hypoventilation is so common. And of course, reduced respiratory drive and muscle activity contribute to more respiratory disturbances. And you can see obesity is associated with the leptin resistance that also make central hypoventilation and apneas, and obesity hypoventilation syndrome is quite known. So we are having so many impact in the respiratory physiology when somebody is having obstructive sleep apnea. Now in a COPD patient, when he sleep, they are profoundly hypoxemic at night than their awake state. And it is said that there is chance for death during night because of the apnea and hypoxia. And it is said that the nocturnal hypoxemia is worse than an exertional saturation fall or a awake hypoxia. And COPD contributes a lot of cough, wheezing, which will disturb the sleep. And so many are complaints of insomnia, unable to sleep, and need hypnotics, which will again contribute to obstructive sleep apnea. The fragmented sleep and reduced amount of deep NREM and REM sleep occurs in COPD patients, and severity of COPD very well correlates with the severity of the subjective sleep complaints, but not with objectively measured by sleep. So our sleep study may not pick up all the complaints which patient is having at night. And daytime sleepiness usually we assess by Epworth sleepiness scale, which sometimes will underestimate in COPD patients. So this is a study which is done 20 years ago by our team in JIPMER. We took stable COPD patients and we did polysomnography, and we could found that a significant number of COPD patients are having nocturnal oxygen desaturation without sleep apnea. So my topic is COPD OSA overlap, but I would like to say that sleep related breathing disorder is a large number of diseases associated with that. We also have to focus on that. Since my topic is only overlap, I am just talking about sleep apnea only. So overlap syndrome was coined in 1985 by David Flenley because he thought that it was a simple logic. OSA is common, COPD is common. Why the same patient can have both together? So that was a concept, because he was seeing more patients with some patients with severe pulmonary hypertension, which is out of proportion to the COPD involvement. So now when overlap occurs, they will have more profound nocturnal oxygen desaturation than patient with either OSA or COPD alone. And 15% of COPD patients have coexistent obstructive sleep apnea. And you can see the sleep apnea patient itself, COPD incidence is 7.6% compared to patient without sleep apnea, where prevalence is only 3.7. So it is twice the incidence of COPD in sleep apnea patients. And if you take a gold stage 4, this is previous classification COPD, the prevalence of sleep apnea is 43%. So it is very significant in severe COPD patients. Now, what is happening to the respiratory physiology when both these diseases together? So already their respiratory drive is decreased, that will be more profound. Respiratory muscle become more hypotonic, functional residual capacity comes down, airway resistance increases, upper airway narrowing increases, finally VQ mismatch, hypoxemia, hypercapnia happens. So in a nutshell, this diagram will tell you about what is happening and what is the underlying mechanism when COPD club with OSA. So cigarette smoking is predominant in COPD. Adipose tissue comes when patient is obese or risky for OSA. So remember that adipose tissue, cigarette smoking combination is a lethal combination, where oxidative stress is more, inflammatory mediators like tumor necrotic factor alpha, interleukin 6, 8, CRP. Finally, endothelial dysfunction is the key, where it is risky for cardiovascular, cerebrovascular, and atherosclerotic plaque formation, etc. So now, patient with overlap syndrome, why we are worried? Because these patients are known for severe complications in the form of respiratory failure, pulmonary hypertension, hypoventilation, severe hypoxemia at night, and they are prone for other comorbidities like diabetes, obesity, even silent death during night. So it is a very, very severe form of disease when OSA is combined with our COPD. So this slide show you how a COPD patient is becoming risky for sleep apnea. We are using steroids every time when patient is getting an exacerbation of COPD, which will increase the fat deposition, hypercortisolism, so risky for sleep apnea. And core pulmonale, there will be caudal fluid retention, airway edema, that also risky for obstructive sleep apnea. And patients will not exercise, so there will be sedentary lifestyle, again risky for obesity. Muscle weakness, upper airway collapsibility will be more in COPD patients. So COPD patients inherently more risky for developing sleep apnea. Similarly, OSA patient is risky for COPD. Few postulated mechanism is, it is a kind of systemic inflammation because of the adipose tissue. Along with there will be lower airway inflammation that will predispose to COPD as well. And hypoxia induced ischemia and reperfusion. Lot of oxidative stress into the lung parenchyma, and increased negative pleural pressure during COPD can cause GRD and lung disease as well. Nasal congestion of CPAP, which is a treatment of obstructive sleep apnea, will lead to breathing issues, and daytime sleepiness will stimulate them to smoke more and more. So that also increases the chance for COPD as well. So both are promote each other. Finally, they will have overlap syndrome. Now, what are the clinical features? I am not going to clinical features of COPD or OSA, which is very much known. But what is the characteristic of when overlap comes? The increased nocturnal oxygen desaturation. When patient is admitted in our ward or in ICU, we could see that this group of patients will have nocturnal profound hypoxemia when compared to other two groups. And their pulmonary arterial hypertension will be much more than the lung dysfunction. There will be a disproportion between the spirometry value and the pulmonary arterial hypertension. And they will be having other comorbidities like diabetes, cardiovascular disease, cerebrovascular disease, or even a congestive cardiac failure, and chances of death is also more. And their quality of sleep will be very poor when OSA is combined with COPD. So when to suspect overlap syndrome? Whenever COPD patient is having excess daytime fatigue, the best scoring would be stop bang, because excessive daytime sleepiness will be less. They will complain of mainly fatigue rather than sleepiness. And the high intensity smoking, higher pack years, more respiratory symptoms, higher nocturnal oxygen desaturation, all are associated with overlap syndrome. So whenever a COPD patient comes to us with these features, we should do a polysomnography to rule out associated sleep apnea. Now, overlap syndrome is like a double engine fighter plane. On one side, obstructive sleep apnea will cause lot of changes, and COPD will have its own effect. Finally, hypoxemia, systemic inflammation, oxidative stress, endothelial dysfunction, coagulopathy, all these contribute to development of pulmonary hypertension and coronary artery disease, peripheral arterial disease, stroke, etc. Now, how to diagnose it? Diagnosis need preliminary screening with the stop bank score. Look for pulmonary hypertension which is out of proportion to lung involvement. Nocturnal oxygen desaturation, transcutaneous PaCO2 should be combined in our polysomnogram because hypoventilation is usually associated in COPD without sleep apnea. So, if it is available, it is not available in our center, many of the centers in Kerala. But if you are looking into a COPD segment patient for sleep study, we should have a transcutaneous PaCO2 monitoring along with the sleep study. Home sleep apnea testing is not recommended in the current guideline by ATS because it will underestimate the sleep related breathing disorder in COPD. So, patient should have a full channel sleep study in the hospital itself. Now, this is a phenotype of overlap syndrome. You can see this triangle showing the COPD patient, out of which the gray area is the emphysema, and the red circle will be all OSA patient, and the green circle will be all obesity hypoventilation patients. So, you can see when it comes to the pure emphysema, only very small portion of patients are having overlap. In other words, emphysema is having a protective role to develop obstructive sleep apnea. Coming to the treatment, I think this chart will show you how we can proceed with overlap syndrome. Whenever we are seeing a COPD patient with daytime hypercapnia, if hypercapnia is there, use the stop bank score. If it is positive, directly subject the patient for sleep study. If stop bank score is less than 3, then if patient is having severe COPD, emphysema without obesity, overlap syndrome is unlikely, but if clinically warranted, we can do sleep study. If patient is obese, then definitely we have to consider sleep study. On the other hand, if patient is not having any daytime hypercapnia, again the scoring is done. If scoring is positive, do sleep study. Scoring is negative, if any risk factor is there, again do the sleep study. If no risk factor, we can safely rule out overlap syndrome in the COPD patient. Now, further management after the sleep study, non-severe OSA with a sleep-related hypoventilation, predominantly sleep-related hypoventilation, this we can assess with transcutaneous PaCO2 monitoring. This patient can have a high-intensity NIV treatment. Now, patient with a severe OSA, AHI more than 30, we have to do the CPAP trial. That is done, then it is diagnosed as overlap syndrome with the predominant obstructive sleep apnea where CPAP is the treatment of choice. On the other segment, if no OSA, then we can have sleep study. If OSA is unlikely, we need not do anything. For central sleep apnea, either go ahead with BiPAP with ST mode or the other group with CPAP therapy. If they are not improving, again BiPAP therapy is indicated. So, this flow chart will give you how to proceed with COPD. So, the first step will be look for awake hypercapnia. If it is there, stop bank score. If it is positive, go ahead with the sleep study. Now, NIV phenotypes for overlap syndrome. Many type machines are available, CPAP, BiPAP with ST mode. So, CPAP is usually given for pure OSA, high AHI with the COPD, CPAP will be better because CPAP is cheaper than the other. BiPAP is for obesity hypoventilation syndrome or emphysema patients. They won't be having obstructive sleep apnea much, they will have hypoventilation rather than obstructive sleep apnea. BiPAP with ST mode is COPD related hypoventilation can be used, and also for central sleep apnea. High intensity NIV is for high PaCO2 and sleep related hypoventilation. Remember that this is not for obstructive sleep apnea. Now, what are the other options we can add apart from the BiPAP and CPAP? Oxygen, if persisting hypoxia, target should be 88 to 92. More than that will abolish the hypoxic drive of the respiratory center. Inhaled drugs should be continued. It is said that LABA-LAMA combination will improve the nocturnal oxygenation. Regarding the inhaled corticosteroid, alone we are not giving in COPD. There are certain indications for that, but it is postulated that inhaled corticosteroid can have myopathy. So the use of isolated corticosteroid in COPD, especially in overlap syndrome, is controversial. Avoid sedatives, alcohol use and opioids in overlap syndrome because it will exacerbate central apnea and hypoxia. Cognitive behavioral therapy, there is a role if patient is not tolerating with the CPAP or NIV. Pulmonary rehabilitation should be coupled with the other forms of treatment in overlap syndrome because these patients will be more symptomatic than the other group. Now, future of the overlap syndrome, it will be phenotype based. Just an overlap syndrome is not enough. We should know which is the predominant, whether it is obstruction, whether it is central apneas, or whether it is obesity related hypoventilation, or just pure ventilation due to COPD with the nocturnal oxygen desaturation. Accordingly, the treatment options varies. And we need to study, a lot of studies needed in the COPD and central sleep apnea. That is lacking. In the future, probably more studies might come. And sleep related breathing disorder in COPD should be investigated rather than sleep apnea alone. Now the current trend is we do a sleep study, no AHI, no significant AHI. We leave the patient saying that your sleep is good. But that is not right. We have to assess the ventilation, hypoventilation during sleep by monitoring the carbon dioxide as well. So the oxygen trial, INOX trial failed because, probably because they didn't classify the sleep related breathing disorder. Volume assured pressure support with the fixed or auto EPAP is a good option for patients who are not tolerating the conventional BiPAP. And there is a new thing called auto tri-level positive air pressure where we use relatively lower EPAP at the beginning of the expiration. This is just to match the auto PEEP of the patient so that there won't be any hyperinflation of the lungs. If you use more PEEP, if you use more EPAP, there is chance that patient may go for more and more hyperinflation. So this tri-level PAP will deliver only lower EPAP than the conventional BiPAP, and it will deliver high EPAP at the end of expiration so that upper airway collapsibility can be prevented. So this model will be very good, but only pilot studies are available, need larger studies to get the final results. So in summary, OSA and COPD is very common, but we are not checking for OSA for all COPD patients. Similarly, all OSA patients, we are not checking for COPD. And remember that it is a lethal combination. Suspect it when appropriate as OSA is treatable, more treatable than COPD. And focus on sleep-related breathing disorders rather than just sleep apnea and forget about other areas. And CPAP, BiPAP, and now TriPAP, many machines are coming. So hope that treatment would be much better in the near future. More and more sleep labs will come up with carbon dioxide monitoring as well. Hypoventilation will be covered up, and that's all. Thank you all for patient listening.
Thank you, sir, for the excellent session on the COPD, OSA, or lab. What we are seeing in our day-to-day OPD that a lot of patients present with this daytime fatigueness that not only because of OSA component or it is not isolated OSA component or isolated COPD component, can be a overlap may need to be suspected. Sir, in which stage of gold means according to any class of gold this can be postulate like CPAP, BiPAP, TriPAP like that? Severity depends upon whether it is severity of OSA.
Yeah, very good question. In COPD overlap, if predominantly suppose AHI is more than 30, that is severe OSA, then CPAP would be to begin with, CPAP would be the better option because it is cheaper than BiPAP. If patient is not tolerating with the CPAP, still symptomatic, probably we need to do a BiPAP trial as well. So if it is OSA, AHI is more with the COPD, start with the CPAP. If AHI is low, hypoventilation is more, then better would be BiPAP.
Any questions from the audience?
Just mentioned about the TriPAP. Can you just elaborate a little bit more about that?
Yeah, it's a modified BiPAP only. BiPAP, we will give a fixed expiratory pressure, that is EPAP. So if I set EPAP 6 centimeter of water, the 6 centimeter of water will be given during the entire time of the exhalation. Now when we try level, it will start with a lower, say 3 centimeter of water of positive pressure during the start of the expiration, and end of the expiration 6 will be given. So the starting point is these patients will have pursed lip breathing because of the auto PEEP. They keep a auto PEEP in their tracheobronchial tree. So this auto PEEP we should cancel it by giving an external positive pressure. But if we give more than the auto PEEP, the remaining pressure will make it a lung hyperinflated. So hyperinflation is one of the pathophysiology under the COPD. So in other words, when we use more EPAP, we are causing more and more hyperinflation, and symptoms will be more. So tri-level positive airway pressure will be much better for patients with emphysema and patients with hyperinflation, especially when we are using high pressure for CPAP or BiPAP, EPAP. But that is only if few studies are available, not available in our place. I don't think it is available. It's a new concept, and pilot studies showing very good results for COPD patients.
Thank you, sir.
Now we'll move on to our next session. That is by Professor J C Suri, sir. He is the Director and HOD Pulmonology, Critical Care and Sleep Medicine in Fortis Hospital, New Delhi. He has done his graduation and post-graduation studies from Vallabhbhai Patel Institute, Delhi. And he was the Professor and HOD in Safarjung Hospital and Mahavir Medical College, New Delhi. And he is a recognized supervisor for many postgraduate thesis guide and in Delhi University and Marathwada University. The topic today, sir, is going to take is interrelationship between severe asthma and OSA from endophenotype to clinical aspect. Over to you, sir.
Good evening. Is my screen visible?
Yes, sir. Yes, sir.
You can see my slides, no?
Yeah, I think, yeah, we can see you, sir.
And I'm audible. My voice is clear?
Yes.
Okay. So, good evening to everyone. And thank you, Dr. Mujeeb Rahman and all the organizing committee members for inviting me and giving this opportunity. I'll be talking on a very important subject, that is the interrelationship between obstructive sleep apnea and difficult to treat asthma from endophenotype to clinical aspects. So what basically I'm going to discuss in my talk is the importance of having obstructive sleep apnea and asthma together beyond their usual common and frequent presentation. Previously, we used to think that since asthma is a very common condition, obstructive sleep apnea is a common condition, so we can find them together without having any relationship, having any interaction between the two. So what I will try to talk today is that when we have a combination of asthma and obstructive sleep apnea, it has a mutually exacerbating effect. And this I am going to show you through some prevalence studies which shows that obstructive sleep apnea is more commonly seen in asthmatic and general population. And I would like to talk about the reason being the shared risk factors. Then I will discuss about asthma as a risk factor for obstructive sleep apnea, the possible mechanisms, the pathophysiological mechanisms. And then I will talk about the prevalence of asthma in OSA patients and what is the impact of OSA on asthma pathophysiology and outcome. And then we'll discuss the reciprocal mechanisms and consequences of asthma and OSA overlap and their implication for clinical practice, and then some future directions. So first, I'd like to talk about some important epidemiological studies. They can be in the form of cross-sectional studies and longitudinal studies, and also the interventional studies. So in the cross-sectional studies, we clearly see here, it's a very busy slide, but what you can see here is that the obstructive sleep apnea is more commonly seen in patients with asthma. So you can see here, increased prevalence of snoring, the odd ratio 1.6, and of apnea, odd ratio of 2.3. There is an increase, again, this different cross-sectional studies showing increase in the RDI, that means the respiratory distress index, in continuous OCS versus intermittent OCS. So indicating that the asthma treatment also has an impact on OSA prevalence. So those who are on steroids, particularly continuous oral corticosteroids and also the inhaled corticosteroids, there is an increased asthma. And similarly, asthma is also increased. OSA risk in asthma, these studies, 39% versus 27%. So, and then increased OSA prevalence, severe asthma, 88%, moderate asthma, 58%, control 31%. What does this mean? This indicates that as the asthma becomes chronic, as the asthma becomes more severe, there is more prevalence of obstructive sleep apnea in this. Similarly, we have in the longitudinal studies, as we can see here, again, all this shows, not either asthma risk in the form of habitual snoring or actually the increase in the obstructive sleep apnea in patients with asthma. So there is also the increase in the sleep apnea related poor quality of life. So these are various important studies, both the cross-sectional and the longitudinal. These are the longitudinal studies which indicate increased incidence of new onset obstructive sleep apnea in patients with asthma. So if you follow patients of asthma over a period of time, there is new onset obstructive sleep apnea. So increased incidence of new onset asthma, obstructive sleep apnea in asthma patient as asthma becomes more and more chronic and severe. So these are, I think, the important studies which gives us some epidemiological evidence that asthma is linked with the prevalence and incidence of obstructive sleep apnea. These are the another studies. This is the one of the most important studies, the Wisconsin cohort studies. Again, which shows that the asthma duration increased the incidence of OSA risk in a dose-dependent manner. That means this is a in a 5-year increment in duration was associated with new onset OSA, that is 7% and 18% higher risk of incident OSA. So this is again a clear indication. Then in the retrospective longitudinal studies, the frequency of annual emergency room visits and use of inhaled corticosteroids were positively associated with obstructive sleep apnea. So more severe the asthma, more frequent the visits in the emergency department, and higher the use of inhaled corticosteroid was positively associated with obstructive sleep apnea prevalence in this population. Again, as you can see here, if you look into the asthma severity, and we know that difficult to control asthma and severe asthma are the most severe form of asthma. In this, if you do the polysomnographic study, you will see that about 88 to 95% of these asthmatics have clinically significant obstructive sleep apnea. So these are, I think these are the important studies which clearly show that asthma is associated with the increased risk of obstructive sleep apnea. And what are the possible reasons why asthmatics have more obstructive sleep apnea? And this is due to the common and the shared risk factors, that is rhinitis, gastroesophageal reflux disease, and obesity. We know that all the three comorbidities are commonly seen in patients with severe asthma, and we also see the same comorbidities in patients with obstructive sleep apnea. So here you can see this schematics of mechanism which is bidirectionally linking asthma and obstructive sleep apnea. As suggested by the current data, you can see that asthma is commonly associated with comorbidities like obesity, GERD, and rhinitis, and all the three are associated with increased prevalence of obstructive sleep apnea. Rhinitis through a number of mechanisms, like as we know that rhinitis causes inflammation of the nasal passages, which leads to nasal obstruction. And then this nasal obstruction will predispose the individual to develop obstructive sleep apnea. So rhinitis may also be associated with nasal polyposis. And all these can cause upper airway obstruction and reduction in the patencies. So the upper and lower airway inflammation in rhinitis and asthma may perpetuate each other and could promote the development of obstructive sleep apnea. So there is now a clear-cut epidemiological evidence, even in general population, that both allergic rhinitis and non-allergic rhinitis are risk factors for high AHI. So this has been seen in various studies for distinction. Then GERD is another important condition which we see in patients with asthma. And we know that acid reflux may actually result into the inflammation of the upper airway and may cause local edema. It may cause spasm of the upper airway wall. It may cause edema, and also the neurogenic mucosal inflammation. So all of these things can promote the development of obstructive sleep apnea, and which can also worsen asthma and perpetuate a vicious cycle. The obesity, we all know obesity is a risk factor, the most important risk factor for development of obstructive sleep apnea, and obesity is also a risk factor for asthma. So patients with asthma may also be at risk of developing obesity. So we have this bidirectional relationship between obesity and asthma. The asthma, because of causing poor physical activity, and then patients receiving oral corticosteroids, and due to the inflammation and the disease, the patients have sleep loss, because we know that one of the mechanisms for developing obstructive sleep apnea would be low arousal threshold. The other are the upper airway obstruction, and third is the respiratory instability. So these three factors, anatomical factors, respiratory instability, and the low arousal threshold. So all these three things are commonly seen in patients with asthma, and along with obesity, because the asthmatics are more prone to develop obesity because of the steroids, because of the inactivity, because of the sedentary lifestyle. They are more prone to develop obesity, and then that is an important risk factor for OSA. Why obese patients develop obstructive sleep apnea? Because obesity can reduce functional residual capacity, it can increase oxygen demand, and it can also change the respiratory drive. So, and decrease load compensation. So all these things can actually predispose to the development of obstructive sleep apnea. So besides having common risk factors in the form of rhinitis, GERD, and obesity, asthma is also associated with respiratory instability. And how does this occur? This is a unique pathophysiological mechanism which has been seen in the human and animal studies. So we all know that asthma is a chronic inflammatory condition which is usually intermittently exacerbated by exposure to allergens or to infections like viral and other triggers. And we also know, as we just discussed, the breathing control instability act in concert with the compromised upper airway anatomy to set the stage for upper airway closure. So how asthma can lead to this breathing control instability? And it is due to the inflammatory process. So the inflammatory processes originating in the lung can destabilize breathing control. This concept is gaining more and more attention, and asthma is no exception. So studies in the animal models provide some mechanistic insight into how inflammation in the lung can affect neural breathing control and chemoreceptions. So what we have found in these studies that there is an active transport of cytokines across the blood-brain barrier. There are the other mechanisms are there is increased cytokine production by the central nervous system macrophages, which are the resident macrophages in there. And there is also neural transport of inflammatory mediators from the periphery through the afferent fibers of the vagi. So that means the vagus nerve terminals, which are innervating the lung and the upper airway, the inflammation in the airway, which produce these cytokines can travel through these peripheral nerves into the central nerves and then result into this instability of the breathing control. Along with this, the peripheral chemoreceptors also appear to be sensitized in response to Th1 type of inflammation. That's another thing. And the next thing is that most of the patients with asthma may have a VQ mismatch. They may develop hypoxemia and hypercapnia. So this heightened hypoxic and hyperoxic ventilatory responses may also cause a breathing instability. So the enhanced hypoxic response may even persist after bilateral vagotomy. So this clearly shows that there can be other non-neurological mechanisms which may be responsible for breathing control instability, and this could be through the chemoreceptors rather than the mechanoreceptor feedback of the lungs. So the inflammation of the asthmatic inflammation of the lung can, through different mechanisms, directly and indirectly, can result into breathing control instabilities. So all those patients who have a compromised upper airway, who are asthmatics, maybe due to shared risk factors, and if the asthma is uncontrolled, this inflammation and these inflammatory cytokines can result into a significant breathing, respiratory control instability, and this breathing instability can result into upper airway closure in vulnerable patients. That means those patients who have anatomically compromised upper airways. The another important things which asthma patient can have is the use of inhaled corticosteroids, which can cause upper airway myopathy. So that's another important thing. So anatomical compromise may be there. The new onset anatomical compromise patients can develop due to the use of inhaled corticosteroid, and this can be either due to the deposition of fat in the pharyngeal submucous areas, and also due to the pharyngeal dilator muscle myopathy caused by inhaled corticosteroid. So these are all important mechanisms, which we have recently recognized, which makes asthmatic patient more prone to develop obstructive sleep apnea. So now we go to the other aspect, that is, what is the effect of obstructive sleep apnea on the expression of asthma? So far what we have learned is that asthma can result into new onset obstructive sleep apnea. Now, once the obstructive sleep apnea develops, it is no more an innocent bystander. The obstructive sleep apnea actually exacerbates asthma. And how does it exacerbate asthma? How does it change the natural history of asthma? Let us understand it through epidemiological studies, and also we'll see it through the effect of treatment of OSA on asthma outcome.
Actually, the video is actually we are facing some technical issue from there. The internet has some issues.
Hello.
Hello, sir, you're audible now.
Okay. I will resume. Sorry for this. There was a power failure here. Can you see my slides?
Yeah, we can see you, sir. Slide. Yeah, we can see you now.
Okay. So I was discussing about the effect of obstructive sleep apnea on the expression of asthma. And I would like to discuss this thing on the basis of the epidemiological evidence that if there is obstructive sleep apnea, then there are worst outcomes in asthmatic patient. And what is the impact of treatment of obstructive sleep apnea on the asthma outcomes? And finally, what would be the possible pathophysiological link of obstructive sleep apnea with asthma? So these are the some important epidemiological studies which indicate that in patients with when you have obstructive sleep apnea, it is associated with increased asthma exacerbation, increased prevalence of severe asthma, and decreased asthma-related quality of life. So, so there is an increased risk of poorly controlled asthma. So not only we have more severe asthma, but increased risk of poorly controlled asthma in obstructive sleep apnea. The odd ratio is about 1.4 to 1.5. The AHI is associated. So if you look into the correlation with the increasing severity of obstructive sleep apnea, there is increased risk of severe asthma exacerbation. So not only you have severe asthma, you have more exacerbation, which we see in this thing. So here, I would just like to draw your attention to the various inflammatory pathways which we see in patients of asthma. So we have the Th2 pathway here, which is the most common pathway which we see in patients with allergic asthma. And then we have non-Th2 pathways where we have non-allergic components. So in the allergic asthma, we have the patient is exposed to common allergens. And then we have these Th2 cells. And through that, we have two pathways, one through IgE and basophils. And then there is a recruitment of mast cells and other inflammatory cells. And then the second pathway is through IL-5, and there is a recruitment of eosinophils. So you get this eosinophilic inflammation. The other non-Th2 pathway you has the neutrophilic inflammation, and which is more due to exposure to cigarette smoke or exposure to pollutants or various viral infections for this thing. So we also know that this eosinophilic inflammation is more prone to response. You know, the eosinophilic inflammation is associated with good response to inhaled as well as oral corticosteroids, whereas neutrophilic inflammation, the response to inhaled as well as oral corticosteroid is poor. And moreover, the neutrophilic inflammation is also associated with remodeling and airway fibrosis for this thing. So these are the usual, you can see that in any patient with the chronic asthma, you will see a combination of Th2 as well as non-Th2 inflammation. So how does obstructive sleep apnea actually impacts a patient of the outcome in a patient of asthma? So what we have seen that the OSA is actually is associated with the shift in the inflammation from Th2 to Th1. And there are different studies. These are the animal studies which have shown that OSA risk, as you can see here, is associated with a neutrophilic airway inflammation in asthma, which suggests that OSA may be an important contributor to the neutrophilic asthma. So when a patient of asthma who initially has eosinophilic inflammation develops significant obstructive sleep apnea, there is a gradual shift from eosinophilic to neutrophilic inflammation. So even, you know, a mild OSA in patient with severe asthma is associated with increased proportion of neutrophils in the sputum and changes in the airway remodeling. So these are the important thing. And the another thing what we see in the pathophysiology of obstructive sleep apnea. In obstructive sleep apnea, you see that we have this intermittent hypoxemia, because when there is an apnea here, as you can see, there is a significant oxygen desaturation. So during an apneic episode, there is a desaturation, and once the apnea terminates, the patient goes into a hyperventilation phase, and there can be actually an increase in the oxygen saturation. So what you see in an asthmatic patient, not only intermittent hypoxia, but also intermittent hyperoxia. So during the hyperventilation phase, there is a reoxygenation. So the injury is the injury may be both due to hypoxia as well as hyperoxia. That is the oxidant injury, what we see. And also there is a recurrent arousals, and these arousals can also lead to breathing instability. And then third thing what we see is the increased intrathoracic negative pressure. So all these three components actually impact the respiratory airways. The intermittent hypoxemia is associated. So we have these three things: recurrent increase in the workup breathing, chronic sleep fragmentation, chronic intermittent hypoxemia, and large intrathoracic pressure swings. So these are the important things we see during an apneic episode. And what we see, the effect of chronic intermittent hypoxemia on the allergen-induced airway inflammation in the rats. And what has been seen in this animal model, that chronic intermittent hypoxia alters immune response to allergen towards a more Th1 predominant cellular phenotype with collagen deposition and matrix degradation, leading to airflow limitation, leading to, in fact, irreversible airflow limitations. So these findings highlight the potential of sleep apnea to aggravate airway dysfunction in patients with pre-existing asthmatic patients. So the effect of OSA on asthma inflammation is that this shifts from the traditional eosinophilic Th2 profile in this model to Th1 pattern of inflammation, which led to tissue remodeling consisting of proximal airway wall fibrosis, distal airway basement membrane thickening, and emphysema-like formation of the lung periphery. So these processes culminated in the physiological deficits of expiratory flow limitation. And in fact, this is irreversible, which is not responsive to bronchodilator. So OSA-related features have the potential to lead the structural airway and parenchymal changes with physiological deficit in a manner that casts doubt about their response to the current standard therapies for asthma. So what we mean by this is that if a patient of asthma who initially had predominant eosinophilic inflammation, who was responding to inhaled corticosteroids very well and during exacerbation to short courses of oral corticosteroids, with this shift in the inflammation and also the pathophysiology and the pathology of the airways, with the development of obstructive sleep apnea, these patients now no more responsive. They are no more responsive to inhaled steroid and oral steroid as well as they were before the obstructive sleep apnea was there. So these observations may explain sometimes the failure of CPAP to improve the airway physiology, because once this is long-standing, this airway inflammation and the irreversible changes have taken place. So even if you treat this patient with CPAP for obstructive sleep apnea, these changes may not reverse. So that shows the importance of early detection of obstructive sleep apnea in patients of chronic asthma. So the early detection of OSA and early treatment with CPAP may result or may prevent the development of these changes, these changes from Th2 to Th1 inflammation and also the remodeling of the airway. So to conclude, Asthma commences, we know, early in life. It is an eosinophilic airway disease. The inflammation, this inflammation through the local or systemic effects has been shown to destabilize peripheral and central breathing mechanism and also upper airway control mechanisms. So this way it predisposed to the development of obstructive sleep apnea. In conjunction with the anatomical effects of long-term inhaled corticosteroid therapy on pharyngeal airways, it sets the stage for upper airway collapse during sleep and OSA. So the asthma inflammation leads to development of obstructive sleep apnea. Once established, obstructive sleep apnea is not the innocent bystander. The chronic intermittent hypoxia associated with OSA shifts the airway inflammatory profile away from Th2 pathways, that is eosinophilic inflammation, to the Th1 pathway, which lead to the lung remodeling and airway dysfunction. So this change in the pattern of inflammation now is less responsive to inhaled corticosteroid therapy. So once the patient becomes less responsive to inhaled corticosteroid therapy, you call it as severe asthma. And you start increasing either inhaled corticosteroids or you add oral corticosteroids. So when you increase inhaled corticosteroid, when you increase oral corticosteroid, this further predispose these individuals to develop obstructive sleep apnea. So a vicious cycle set in. So without addressing OSA, therefore achieving asthma control would likely require a step up in ICS dose and repeated steroid burst. And this would further increase the risk for and the severity of OSA with its consequences for asthma, accelerating this vicious cycle and translating into irreversible airway dysfunction. So more the uncontrolled asthma, you are going to increase the inhaled corticosteroids and oral steroid. It will further predispose the person to develop OSA, or it will increase the severity of OSA. And as the severity of OSA increases, it further has its impact on the asthma inflammation, and which leads to further remodeling and irreversible changes. So this cartoon clearly shows that here you can see that this is the airway, that this is the here the patients with asthma have increased inflammation, and this increased inflammation through its impact on the central and the peripheral chemoreceptor, it causes heightened chemoreceptor sensitivity and breathing instability, and that breathing instability leads to development of obstructive sleep apnea. And once the obstructive sleep apnea develops, it causes intermittent hypoxemia, changes this Th2, Th1 imbalance, and leading to development of predominant Th1 inflammation to lung remodeling and irreversible airflow obstruction. So this is how this interaction works and perpetuates one another, each other here. So this interaction emphasizes the importance of thoroughly assessing asthma control around the clock as a part of multidisciplinary care program. So the clinician should periodically screen their patients with asthma for OSA, particularly those who have had asthma for a longer duration, those who have uncontrolled disease, and those who have higher doses of inhaled corticosteroids. So one thing here, the important thing is that the phenotype of obstructive sleep apnea, which we see in asthma, is more of hypopnea type. And we do not see frank apneas in this patient. So when you are evaluating this patient, so please don't do it with the home sleep testing, because in home sleep testing, we don't monitor sleep. And if the disease is predominantly of hypopnea type, and we know that one of the definition of hypopnea is decrease in the airflow with arousal, and if it is not associated with desaturation. So in the home sleep studies, the hypopneas associated with arousals will not be detected, and we will underscore the severity of sleep apnea with these type of tests. So if you have to evaluate your patients of asthma for sleep apnea, you have to do level 1 in-lab studies for this thing. And the CPAP treatment should be offered and adherence emphasized because it holds the potential to reduce asthma morbidity and improve quality of life in the long run. Thank you very much for your kind attention. And I'll be very happy to answer if there are any questions.
Thank you, Professor J C Suri sir. It was a wonderful talk regarding asthma, OSA overlap, and the shared risk factors, obesity, GRD, rhinitis, and the imbalance between TH2 and TH1 pathway. And the topic is open for discussion.
Good evening, sir. It was an excellent talk. Very recent innovative ideas are coming in terms of both OSA and asthma interrelationship. And my doubt is, his concern is whether it's like a chicken egg question, like whether the asthma triggering or OSA triggering. So you have shown the pathophysiology and the last picture where the starting point was the asthma triggering the neuropathway and the TH1 to TH1, TH2. So is it a era where we have to find or we have to treat asthma properly so that they will not develop OSA, or we have to screen every OSA patients thoroughly so that they will not land in severe asthma? So please have a little bit more on this. Thank you.
Thank you very much. I think it's a very important question. And I think it is both ways, you know. If you have a patient of asthma, as I said, asthma starts in early childhood, particularly the allergic asthma. So at that time, we don't expect these patients to have obstructive sleep apnea. So, and the obstructive sleep apnea most likely comes as a second comorbidity as the asthma becomes more and more chronic. So the most important thing is the proper control of asthma. So if you treat asthma properly with inhaled corticosteroids, then the inflammation will be under check. And as in the pathophysiology, we mentioned that the asthma inflammation through direct and indirect means either through chemoreceptors, central or peripheral, or through the cytokines going through the nerve endings, or the cytokines going through the blood. So ultimately, it causes the breathing control instabilities. So this breathing control instabilities in vulnerable people who have upper airway obstruction, either anatomical obstruction genetically there or due to, say, shared risk factors like rhinitis or inhaled corticosteroid-induced myopathy. All these things, you know, I think it's a continuous process and leads to the development of obstructive sleep apnea. And then as the child grows, as the person grows, they become more and more obese. So there is an increased risk of developing obstructive sleep apnea in vulnerable people. So once the obstructive sleep apnea develops, then actually the problem occurs. So as long as there is no OSA, asthma is controllable because it is eosinophilic inflammation. You can control it well with inhaled corticosteroids. But once OSA develops, the pathophysiological mechanisms associated with OSA, the consequences, not mechanism, pathophysiological mechanism, but consequences like intermittent hypoxemia, like increased intrathoracic negative pressures, they then start causing changes. You know, as we have seen in rat experiments, there is a shift of inflammation from TH2 to TH1, and then there is the kind of inflammation which is less responsive to inhaled steroid. So I think it is a continuous process. It's very difficult to say where it begins. It's a vicious cycle, and anywhere you can interrupt. You can take, you know, if you see an adult patient in which both the things are there, then you improve the asthma control, you optimize the asthma treatment, and you also treat the obstructive sleep apnea with CPAP. But there may be a situation where there is a long-standing asthma, long-standing OSA, and if you do the pulmonary function test, it may show irreversible airflow obstruction, and there is already signs of remodeling are there. In such patient, if you treat with CPAP, probably the response may be only limited, because the changes have already taken place. So I think the key here is the most important thing is early detection. So if you have asthmatic patients, you detect or you screen these patients very early for the presence of obstructive sleep apnea, and detecting them early and treating them early would be the key, and that is what it is there. It will be very difficult for me to say which one came earlier, but I think it is the asthma, because asthma starts from childhood, and obstructive sleep apnea comes later on, and that's how you have to approach these patients.
Thank you, sir.
Thank you, Professor J C Suri, sir, for that wonderful talk. And if there is no more questions, we'll go to the next topic. Thank you, sir.
Good evening. Next topic is about one of the important aspect, that is PAP titrations. As we know, once the OSA is diagnosed by polysomnography, the next step is usually a PAP titration. When and how to do this PAP titration, and when should be the follow-up PAP titration. These are all important aspects and questions which can be raised. And we are having Dr. Sourin Bhuniya as a speaker for this session. He is an additional professor, Pulmonary Medicine and Critical Care, All Indian Institute of Medical Science, Bhubaneswar. He completed MBBS and MD Pulmonary Medicine from Utkal University, Odisha, where I also completed my MD from the same university. Then he is an assistant editor at the Journal of Association of Chest Physician, and inviting Dr. Sourin Bhuniya sir for the talk on PAP titration.
Thank you very much. Sir, am I audible?
Yes, sir. Yes, sir. Slides.
Is my screen visible now?
Yes, sir.
So very good afternoon to all of you. Thank you so for the kind introduction. Well, it has been always a pleasure to listen to Suri sir, and I feel proud to be sharing the same platform with Suri sir today. So my job is to take you through this very important topic of positive airway pressure titration over the next 30 minutes. It will be just an overview covering mostly the practical points, how to go about the PAP titration. The outline would be first we will assess the need for titration with PAP devices, why we need to titrate with PAP devices in case of obstructive sleep apnea. Then we will have a look at the setup for the titration study, whether it is going to be an in-lab titration or it's going to be home-based titration, that we have to see the pros and cons. And then we will look at the titration protocol for the different kinds of devices which we commonly use as per the ASM criteria. And then we will look at some of the differences between the CPAP titration versus auto-PAP titration versus the bilevel PAP titration. So first things first, what is positive airway pressure titration? So it is a manual pressure adjustment by a sleep technologist during attended lab polysomnography to eliminate obstructive respiratory related events, whether it's an apnea or hypopnea or a RERA, and snoring during all the stages of sleep and in all the positions of sleep. So these underlined phrases are very important when we consider PAP titration. So whenever a patient is diagnosed with obstructive sleep apnea, so So then we have to decide upon the pressure which is going to take care of all the obstructive events. So if the pressure is less, then that is going to be not effective. The patient is going to have persistent symptoms. And even if the pressure is more, then also the patient will not be tolerant to the pressure and will not serve the purpose. So the ideal pressure has to be found out by the titration of the PAP devices. So the first thing when we break the news of obstructive sleep apnea, diagnosis of obstructive sleep apnea to the patient, so what reaction do we usually face? So it's mostly this kind of reactions we face, that are we going to sleep with a mask throughout the night? So they feel as if their life is doomed and their life becomes miserable. So lot of tension, lot of anxiety immediately goes through the mind of the patient, that what kind of disease is this? So it takes a lot of effort to counsel them, to make them understand what the disease is and how a PAP device is going to prevent all the complications of the dreaded complications of obstructive sleep apnea in such a patient. So what are the essentials of PAP titrations? First, the patient education is most important, as patient education and counseling about the positive airway pressure. So this, if the patient education and counseling is not proper, then there is always a deficiency in the acceptance of the in the therapy, and the patients have also to be counseled regarding the proper mask fitting, the importance of the proper size mask, that has to be told to the patient. And also there needs to be a CPAP adaptation at low pressure, maybe a couple of days earlier than the actual day on which the titration is aimed, because this if we sensitize the patient with a low pressure with a mask, that identifies some problems like claustrophobia very early, so that we can take necessary steps. So adequate titration to eliminate all abnormal breathing events in all stages and all body positions. This is very important, as we will see in subsequent slides. And of course, assessment of the efficacy and tolerance to the PAP device from follow-up of the patients. So let us see what are the initial PAP mode options. First, we have the fixed level CPAP device, which delivers PAP, positive airway pressure, at a level that remains relatively constant throughout the respiratory cycle. That means they deliver a constant pressure throughout inspiration and expiration. So titration by an attending sleep technologist in sleep lab using PSG-based monitoring, they were requiring an overnight stay. So whenever we are doing a titration by a fixed level CPAP, it has to be in the in-lab titration by monitoring with the sleep technologist. Then we have got the auto PAP devices, which utilize the proprietary algorithms to resolve OSA as detected by the device and are generally performed at home. So these auto PAP devices, they sense either the airflow or the airway resistance or the variability in the pressure in the airways, and then they deliver the required pressure as and when required. And so this can be used for titration at home. Then we have got the bi-level PAP device, which delivers positive airway pressure at different levels during inspirations and expiration, which is known as the IPAP and the EPAP. And the titration must be performed in the sleep lab under PSG monitoring. So what are the factors which influence whether the setup is going to be an in-lab titration or it is going to be home-based titration? So patients with uncomplicated OSA can undergo initial titration at home using auto PAP or in-lab CPAP titration. So these patients of uncomplicated OSA can undergo the titration in either of the setup. But in patients with complicated obstructive sleep apnea, for example, patients with comorbid, either they have got associated central sleep apnea or COPD or any neuromuscular disease or OHS, these patients are not suitable for auto PAP titration. So they have to be taken up for titration in the lab. So the type of device, again, which we plan to prescribe to the patient, which the patient is likely to use on a long-term basis, that will again decide the titration setup. Patients who need BiPAP can only be tested in the lab. So again, we have to consider the cost and the time of the titration. If the patient has got very severe symptoms, very severe desaturation, we cannot wait for the waiting period of months, which are usually found in the hospital. So again, these things have to be taken into consideration for deciding the setup of titration. And also we need to take care of the patients in areas that lack sleep laboratories. Patients suspected to have significant mask leaks due to facial deformity may not be suitable for auto-PAP titration. So such patients who, if you see any kind of facial deformity, they have to be planned for in-lab titration. Uncomplicated OSA patients who failed previous APAP titration may require in-lab titration. So patients who have already undergone APAP titration at home, but it is not effective, they have to be taken up for in-lab titration. If we feel that the technician might have to change the mask or adjust the mask in between, then also we have to, it has to be a supervised one in the lab. So while an attended in-lab approach is traditionally considered the gold standard, randomized trials and meta-analysis of patients with uncomplicated moderate to severe OSA have failed to demonstrate substantial difference in efficacy between in-lab and home PAP titration strategies. So there are many RCTs and meta-analysis which have shown that there is no difference in the efficacy between the in-lab and the home-based titration strategies. Sorry. So this is one of the biggest systematic review and meta-analysis which compared the auto-titrating versus the fixed continuous PAP pressure for the treatment of OSA. So here they had compiled the data from 24 RCTs and had around 1,000 patients who met the inclusion criteria. All cases of moderate to severe cases of obstructive sleep apnea without any significant comorbidities, they were taken. Auto-PAP improved compliance by just 11 minutes per night and reduced sleepiness by measured ESS by just 0.5 points as compared with fixed CPAP, whereas the fixed CPAP improved minimum oxygen saturation by just 1.3% more than the auto-PAP. So the no trial evaluated any objective clinical outcomes like death, cardiovascular events, or diabetes or depression. So more or less we see that the results from both auto-PAP and the fixed CPAP are more or less same. Sorry. So this systematic review, they concluded that because the treatment effects are similar between APAP and CPAP, the therapy of choice may depend upon factors like the patient preference, specific reason for non-compliance, and cost. That is, it mainly depends, it has to be individualized from patient to patient, depending upon their preference or the reason or any specific patient-based factors. So this was another big systematic review by the American Academy of Sleep Medicine. So in this review, they found that there were no differences in the residual AHI between CPAP and auto-PAP titration strategies in patients with uncomplicated and moderate to severe OSA. There were no differences in the night compliance of either CPAP or auto-PAP, or in daytime sleepiness, the quality of life, or the neurocognitive function. Also, there were no discernible difference in the side effect profile between the two modes. Patients who received APAP complained of less pressure-related discomfort compared with CPAP. And also there was limited data which suggested that there was a patient preference for auto-PAP. So now coming to the protocol, how we go about the titration based upon the ASM guidelines. So first, let's see the titration protocol of fixed CPAP. So it started at a low level of 4 centimeters of water. Pressure is then gradually increased by increments of 1 to 2 centimeters of water. And at each pressure, it's allowed for at least 5 minutes. Then we look for at least either two obstructive apneas or 3 hypopneas or 5 RERAs, or at least 3 minutes of loud or unambiguous snoring. So once we find that these events are not there present, then we can decide upon the pressure. If any of these events are present, then we have to again go on increasing the pressure by 1 or 2 centimeter, 1 centimeter. The minimal CPAP that consistently prevents upper area obstruction becomes the fixed CPAP setting. When we see that there is no more events, then that becomes the fixed CPAP setting. So once the pressure reaches 15 centimeter of water, we have to consider switching over to the BiPAP spontaneous mode because the pressure above this level is going to be intolerant for the patient. If the patient is still hypoxic after respiratory events are resolved, we should not increase the pressure. Rather, we should put supplemental oxygen. So the hypoxia during titration is not an indication for increasing the pressure. That is an important point which we should remember. So how to assess the adequacy of CPAP titration? There are three results. Either the titration has to be optimal, or it has to be good, or it is adequate. So the goal is always to go for optimal titration. That is the best for the patient. So what is optimal titration? Optimal titration reduces the RDI to less than 5 events per hour for at least 15 minutes. And in addition to that, supine REM sleep should not be interrupted by spontaneous arousals or awakenings. So if this is achieved, then we have achieved the goal of optimum titration for the patient. Then what is good titration? Here the RDI is reduced to less than 10 or by 50% if the baseline RDI is less than 15. And in addition to that, supine REM also should not be interrupted by spontaneous arousal or awakenings. And in adequate titration, it does not reduce the RDI to less than 10, but reduces the RDI by 75% from the baseline, especially in severe OSA patients. Or optimal and good criteria are met with the exception that supine REM did not occur at the selected pressure. So if we are not able to achieve that the REM supine position, then that becomes the adequate titration. Now, what are the indications for split night sleep study? So if we see that during the first 2 hours of recording, the AHI is more than 40, that is, then we should plan for the split night study. Or if the AHI is between 20 and 40 in the presence of repetitive, very lengthy obstruction and major significant desaturations, then also we have to consider the split night study. So in such cases, CPAP titration must be carried out for more than 3 hours. And the PSG document CPAP eliminates all events in sleep, including REM in supine position. So a second full night PSG with CPAP titration should be performed if the above 2 criteria are not met. So if we are not getting enough, say 3 hours to carry out the CPAP titration, or if we are not getting enough time, we are not allowing enough time for the patient to reach the REM stage in supine position, then again we have to plan the complete full night PSG with CPAP titration the next day. Now coming to the autopap titration module, how to go about the autopap titration. So it is advised that the patient use the autopap device at home for at least 7 to 14 days. Then the machine is usually normally set at a minimum and maximum pressure of 5 to 20 centimeter of water, and the data is then downloaded from the machine. So the optimal fixed level CPAP setting is typically the pressure at or below which the obstructive events measured by the APAP device are eliminated for more than 90 or 95% of time. It is typically designated as either the P90 or P95 pressure, or the 90th or the 95th percentile of pressure. So the pressure at which all the events are eliminated for more than 95% of time, that is the pressure we usually prescribe to the patient as the fixed pressure whenever we go for APAP titration. But for assessment of APAP titration, we don't have any criteria as optimal or good or adequate titration. There are no clear-cut published guidelines to assess the APAP titration adequacy. However, we can consider the titration successful if at least 6 hours of device use is there every night during the data analysis. If you see that the patient has used the 6 hours every night, or the device calculated respiratory event index is less than 10 events per hour, or the leak profile is acceptable, or there are no residual symptoms of sleepiness or snoring. So then we can accept that the titration has been successful. Now coming to the titration module for the BiPAP spontaneous mode. So the indications are uncomplicated OSA patients who fail CPAP or AutoPAP, OHS patients who fail to improve on CPAP, and central sleep apnea patients, including treatment emergent central sleep apnea. Here, a backup rate has to be given. The central sleep apnea and hypoventilation due to neuromuscular disorders. So all whenever we come across patients with all these conditions, then we have to plan for BiPAP titration. So again, during BiPAP titration in a patient not previously treated with PAP, the initial IPAP and EPAP are usually started at 8 and 4 centimeters respectively. Then they are serially increased by 1 centimeter of water, allowing at least 5 minutes at each pressure until frank obstructive apneas are eliminated. So the pressure at which the obstructive events are eliminated, that becomes the EPAP, and after that only IPAP is titrated. We go on increasing the IPAP until all other events like the hypopneas, RERAs, and snoring, they are eliminated. So the maximum recommended IPAP level is 30 centimeters of water for adults. In a patient previously titrated on CPAP who has failed the CPAP titration, the starting EPAP can be set to the CPAP value that eliminated frank obstructive apneas, and the IPAP is set to a level 4 centimeters higher. So the CPAP pressure, which we have to note down the CPAP pressure, which had eliminated all the obstructive apneas. So that becomes the EPAP, and the IPAP is started at 4 centimeters higher pressure. So the minimum recommended IPAP-EPAP difference is 4 centimeters of water, and the maximum is 10 centimeters of water in uncomplicated OSA. When OSA is complicated by hypoventilation, a higher separation between EPAP and IPAP may be necessary to provide the degree of pressure support necessary to augment ventilation. So how do we evaluate the patients with suboptimal titration? When we, after titration is done, we see that the titration is not optimum. So what are the indicators of suboptimal titration? So if there is intolerance to pressure required to resolve sleep disorder breathing, if there are residual symptoms such as excessive daytime sleepiness or snoring, if there are residual AHI observed at CPAP pressure more than 15 centimeters of water, then these are the indicators for suboptimal titration. So what are the common causes of suboptimal titration? Problems, there can be problems related to the masks, or there can be problems related to the nasal issues. So the most common problem related to the mask is claustrophobia. So if a patient complains of claustrophobia, cannot tolerate the mask, we have to gradually desensitize the patient with the mask, preferably with the nasal mask, and then gradually we have to increase the duration of usage of mask. If the mask is poorly fitting and leaks are there, we have to use the smallest possible mask to prevent the leaks. And if the patient is mouth breathing with nasal mask or nasal pillow, then we have to apply a chin strap or maybe shift to oronasal mask. If the patient complains of nasal dryness, then we can add heated humidification. If nasal congestion is there, then we can advise topical nasal steroid sprays. And if the patient complains of persistent nasal blockage, then of course we have to get an ENT evaluation done. So when there is intolerance to pressure, use of pressure relief or a pressure ramp. So a ramp is set for a time over a period of which there is a gradual increase in pressure. So there will be no sudden gush of air onto the face of the patient. Switching to home AutoPAP treatment from fixed pressure CPAP, if there is intolerance to pressure, or switching to BiPAP device or auto BiPAP may be considered as pressure relief. So there are some situations where there can be the pressure requirement can be variable. In such cases, also we need to switch over to AutoPAP device. Examples are use of alcohol. Suppose the person takes alcohol intermittently, maybe on weekly basis. So on the days on which the person has alcohol at night, the sleep is going to be worse. So the pressure requirement is going to be high on that night. The nasal congestion leading to nasal obstruction, patients with allergic rhinitis, wide variation in body weight. higher pressure requirements during REM sleep, if patient is having predominantly REM dominant OSA and or when sleeping in supine position. So if, under such scenarios, if we can switch over to auto PAP, which takes care of the SOS pressure requirement. So summarizing what we have discussed till now, patients in whom PAP therapy is indicated should undergo PAP titration to determine the optimal settings. Ideally, before the night of titration, patient should be educated about PAP device, mask fitting, and adapted to the sense of pressure. For patients with uncomplicated moderate to severe OSA, titration can be performed with either an attended in-lab titration with a fixed level device or an unattended in-home titration using an auto PAP device. For patients with complicated OSA, however, we suggest CPAP titration in an attended sleep lab with PSG-based monitoring. In most cases, CPAP may be the first modality tried in such cases. However, BiPAP is used only when specific comorbidities exist, as we discussed. AutoPAP may be preferred in cases where there is a wide variation in pressure requirement, and those who do not tolerate CPAP or have residual symptoms at CPAP pressure of 15 centimeters of water, BiPAP titration should be initiated. Thank you for your patient hearing.
Thank you, sir, for the excellent sessions. Any questions? Sir, sir, one question means, once the treatment with CPAP is started, is there an indication for a follow-up CPAP titration at any point of time, and when, sir?
Yes, definitely. That's a very important question that you have raised. Follow-up, usually we ask the patient to follow up on monthly basis, or if the patient is doing maybe on 3 monthly basis. So if we suddenly see a increase in the symptoms, or then we can think of, if suppose there is patient has stopped the lifestyle modification, there is sudden increase in weight, then there might be a change in the pressure requirement. In such scenarios, we can consider a repeat titration. We can call the patient and plan for a repeat titration.
In a complicated OSA, like an OSA with another hypoventilation disorder, probably it could be a COPD with type 2 respiratory failure or OHS. Once you decide on the EPAP pressure, how do you titrate the IPAP? Is it based on ABG carbon dioxide, or is there any criteria for fixing IPAP?
So whatever titration protocol that I discussed, that was only for sleep disorder breathing. So if in case of overlap, definitely we have to look at the ABG and the CO2 levels, and then we have to decide upon the IPAP settings over the EPAP settings.
So that ABG you take during the sleep study or subsequent day?
In the subsequent days.
And you see the long-term improvement over the blood gas value.
Pardon?
And you see the ABG improvement over a period of time. It's not during the night of titration, right?
No. That is not possible due to titration to titrate with the ABG. So if we suspect there is an overlap syndrome is there with COPD, then that has to be carefully handled, and maybe we need oxygen supplementation for such cases. And definitely we have to go for ABG, and we have to look for, after follow-up of the patient, we have to again do the repeat ABG and see the improvement in the blood gases.
And again, patients who are on oxygen, so how do you put the mask during titration? Is it nasal cannula and over which you put the mask, or you give through the port?
It is given to the port actually. The cannula is attached to the port. There is a port to which it is attached. It is convenient. Otherwise, if we use the nasal cannula, then there can be leak if the mask is not fitted properly.
Sir, regarding that hypoventilation and the titration, if the patient is in our clinical evaluation itself is looking like a patient with neuromuscular disease or COPD, where hypoventilation is actually anticipated, in that ideally we should add transcutaneous CO2 monitor also, so that we can have a good titration protocol. Second thing, sir, you were asking the second question is oxygen flow. Oxygen is connected to the external port, and usually most of the time the baseline oxygen requirement may not be the actual oxygen requirement during titration. Depends on the pressure required, or depends on the pressure support required, and the PAP flow. Oxygen requirement may increase during titration.
Many a times, why I asked that question was, many a times when we give oxygen through the port, we see that their saturation is not picking up, even if we give a good amount of oxygen, and their saturation will be maintaining only only with the cannula. Many a times we have seen that scenario where when we give oxygen through the port or through the either through the mask or through the port within the machine, their oxygen saturation doesn't pick up, and their saturation may actually drop down. So we have to give oxygen through the cannula itself. So that was the reason why I asked that question, because
sir, actually, usually I haven't come across such cases where oxygen saturation is going down during the titration. But usually, when the patient is on a BiPAP device and with a oxygen port, usually they maintain. Means if the desaturation is severe, then usually we do not take up the case for titration.
I'm talking about complicated cases. Then simple OSA they do good with auto-PAP mask, but in complicated cases like COPD, coexistent COPD, or obesity, hypoventilation, when you apply the BiPAP mask, and then if you give oxygen through the port, many a times their saturation doesn't come up to a reasonable level.
Then maybe we have to give through the nasal cannula, as you had said, as we have observed.
Yeah. And we had to resort to nasal cannula many a times. But again, the tolerance of the mask will be an issue if you.
Yes, that puts a lot of pressure over the face, so that has to be taken care of.
Okay. Transcutaneous CO2, is it available here?
Available, many centers are using. There are limitations and the plus point. The limitation is sometimes the values may not be always accurate. It need always titration, like it is a titrable one, and it measures the CO2 from heating, and the capillaries blood, the capillary blood CO2 will be detected, and many patients who are may lose the during the sleep, it may sleep, or many patients who are having diabetic neuropathy or peripheral vascular diseases. In all such scenario, an actual value may not come. So it's not ideal like it is CO2 and other measurement, but the literature is showing a reasonable value of CO2 can be picked up.
Okay.
Regarding that CO2 monitoring, ET CO2 would be more reliable, but problem is it will disturb the sleep of the patient. There won't be any continuity when we are monitoring that. But transcutaneous reasonably good. Recently I come across few studies done by the DNB residents in Mumbai. They have done a wonderful study of 100 patients with ET CO2 monitoring, and they found the hypoventilation is it was a positive study. Hypoventilation they could find out in their study population. So I think in dedicated lab we can add especially COPD overlap, transcutaneous CO2 will give some idea about hypoventilation and nocturnal hypercapnia, which will not be detected in the morning ABG.
What Dr. Hari was asking is a perfect practical point which we usually see when we convert from ICU NIV to BiPAP, the portable ones. The oxygen is not maintained by the flow. Probably what I feel is it's due to the mixing of the rebreathed air, more carbon dioxide within the mask, and so even if you keep it over the port, it may not be maintained with the same. For example, 24% FiO2 will not be maintained with 2-3 liters of oxygen flow via port. So what he was telling us, through the nasal, the mixing may be less. But as you have told, the leak will be more since it's causing the mustache. So you may have to individualize what I feel. And regarding the titration with IPAP, I feel you can look into the tidal volume delivered with the delta P which you have kept with the EPAP and IPAP. And depending on if the tidal volume is not much delivered, you can increase the IPAP little bit more and give the keep the delivery of adequate tidal volume, by which you can have more washout of carbon dioxide and all the stuff. So it depends on the different comorbidities, and you have to individualize with practical things. Thank you.
Thank you, Dr. Sourin Bhuniya, for the excellent session. Now we will move on to the next topic.
Thank you.
For the next topic, I invite Dr. Nitya Haridas, Associate Professor, Pulmonary Medicine, Namrata Institute of Medical Science, Kochi. She has completed her graduation from Government Medical College, Kottayam, and MD and DTCD from Government Medical College, Kozhikode. Madam will be talking about the topic EEG and event scoring. Over to you, madam.
Good evening, everyone. Welcome to the final session of the day. At the outset, let me thank the organizing committee members, mainly Dr. Hari and Dr. Mujeeb, for inviting me to talk on this topic. The topic I will be talking about is about EEG and event scoring. So, for a normal home sleep study or something, it's not that important. But when we go for the full channel polysomnography, and we have already elaborated on circumstances when we need a full channel polysomnography, an EEG and consequently the event scoring would be important for you. And my talk would be more focused on the pulmonologist rather than going to the elaborate aspects for the neurologist. So to make it easy for the residents and a basic pulmonologist to understand the EEG and how we go about doing the event scoring. So a quick recap of the stages of sleep. We have the 4 stages: the non-REM 1, the non-REM 2, the non-REM 3, and the REM sleep. And with the consequent changes in non-REM 1, it's a transition period which lasts about 5 to 10 minutes. And going on to the non-REM 2, where the body temperature drops, and this constitutes the majority of the sleep. And here the brain begins to produce sleep spindles, and it lasts for approximately 20 minutes. And in the stage 3, it is the deepest stage of sleep, where the muscles relax and the blood pressure and the breathing rate drops, and it lasts for about 20 to 25% of the total sleep. And the REM sleep, it is the stage where it's a paradoxical sleep, where the brain is becoming active while the body is becoming more relaxed and immobilized. Here dreams do occur. And in a normal sleep, in the earlier stage, it is the N2 and the N3 which is more predominant, but towards the later stages, the REM sleep predominates. And when we go for the polysomnogram, we have the various electrodes, that is the EOG, EEG, EMG, ECG, and the respiratory electrodes. And for the respiratory electrodes, we have the thermal sensors, the nasal pressure transducers, the pulse oximeter, and the transcutaneous monitors. And for staging of sleep, the minimal parameters needed are the EOG leads in the left and the right eye, the EEG leads at least one occipital, one central and one frontal lead, and EMG lead, one segmental ENG channel. These are the EEG derivations which have been recommended by the ASM. The recommended ones are the F4M1, C4, the F4M1, C4M1 and O2M1. The alternative ones are FZCZ, CZOZ and C4M1, and we have the various backups also. And the scoring rules I have based on the ASM manual version 2.6. I will be concentrating mainly on the adult scoring. I don't be going into the details of the pediatric and the infant scoring, and I will be just touching on the technical aspects and won't be going to the details of the technical aspects. So when we go about scoring, it is better to go for epoch scoring. And epoch is a 30-second. It's a 30-second epoch scoring, and we assign each stage to each epoch. And the general rule, if there are 2 or more sleep stages which are occurring in one epoch, we will assign the score to the stage which is comprising the majority of the epoch. But there are some exceptions to this rule which I will be saying about later. And this is the general nomenclature which we use for the stages of sleep. For wake, we use stage W, N1 for non-REM 1, N2 for non-REM 2, N3 for non-REM 3, and R for REM. And this is the general EEG which we see. There is the alpha activity which you can see here. The alpha activity is of the range of 8 to 12 Hz, and it's associated with the state of relaxation. It is seen in the parieto-occipital region. The beta activity, this is what you see, and it is irregular electrical activity of 13 to 30 Hz, and it's associated with the state of arousal, and it diminishes during the deeper sleep and re-emerge during REM sleep. And it's mainly seen in the frontal and the central leads. The theta activity is in the range of 3.5 to 7.5 Hz, which occurs intermittently in the early stage of sleep. The delta activity is more of a slow wave activity, and the amplitude is it has an amplitude criteria of more than 75 microwatt, and the frequency would be less than 4 Hz. So first, the stage wake. How will you score a stage wake? For scoring a stage wake, it is scored in according to the alpha rhythm or the posterior dominant rhythm, the presence of eye blinks, the presence of leading eye movements, or rapid eye movements. So what is this alpha rhythm? Alpha rhythm is it represents an alert wakefulness to the stage of drowsiness, and it's of the range of 8 to 13 Hz, maximal over the occipital region or during eye closure, and it is attenuated when the eyes are open and are replaced by a low amplitude mixed frequency EEG pattern. The eye blinks are conjugate vertical movements of 0.5 to 2 Hz, and it's seen in eye wakefulness when eyes are open, and there can be leading eye movements which are trains of conjugate eye movements which has a slow phase followed by a rapid phase in the opposite direction. Then there are the rapid eye movements. These are conjugate, irregular, sharply peak movements with an initial deflection which should be less than 500 milliseconds. These are the characteristics of stage R, but it can be seen in wake stage when the subject scans the environment. So how will you score the stage wake? It is scored when there are more than 50% of the epoch has either an alpha rhythm, and you should understand there are certain individuals who don't produce an alpha rhythm. For them, we look for the presence of eye blink or presence of rapid eye movement with a normal or a high muscle tone, or the presence of a leading eye movements. Here, this is the typical EEG which you see in a stage wake. Here you can see the blinking eye movements. Sorry, not the blinking eye movements. This is the rapid eye movements. But here, in contrast to the REM stage, the chin EMG is normal. Then going on to the stage N1. So for scoring stage N1, what are the things we look are slow eye movements, the presence of low amplitude mixed frequency EEG activity, the presence of vertex waves, and Usually the sleep onset is with stage N1, but there are certain individuals who shows as sleep onset directly into the N2. The slow eye movements are conjugate regular sinusoidal movements. Here, in contrast to the rapid eye movement, the initial deflection would be more than 500 milliseconds. And the vortex waves are high voltage, sharp, negative waves which are followed by a surface positive component, and its duration would be less than 0.5 seconds, and it is maximal over the central electrodes. Here you can see the slow eye movements and the vortex waves. In individuals who are alpha or posterior dominant rhythm wave generators, we will stage N1 when the alpha or posterior dominant rhythm is replaced and more than 50% of the epoch contains low amplitude mixed frequency activity, and we continue it as N1 when there is a background low amplitude mixed frequency activity. Even there is a K complex if it is associated with arousal, or if there are no spindles or other complex which are not associated with arousal. Here you can what is marked as the vortex waves. In non-alpha producers, we score stage N1 when any of the following activity. There is a 4 to 7 Hertz activity with slowing of the background of more than 1 Hertz from the stage wake, or there are the presence of vortex waves or slow eye movements. Here the chin EMG is usually variable, but it would be lower than stage wake. But we should understand that the vortex sharp waves and slow eye movements are not required for scoring stage N1. Here you can see the slow eye movements. These are conjugate sinusoidal movement with an initial deflection of more than 500 milliseconds. Now going on to stage N2. The stage N2 is scored in accordance to the presence of K complex and sleep spindles. So what are these K complex? These are sharp, slow waves with a biphasic morphological structure. Here these are central, mainly in the central vertex leads, and with a duration of at least 0.5 seconds, but they don't have a specific amplitude criteria. But to say that it's an arousal associated K complex, and arousal should commence less than 1 second after the termination of a K complex. So what you see is a K complex. Here you can see a sharp negative wave followed by a positive component. The sleep spindles are of the frequency of 11 to 16 Hertz. They originate in the midline thalamic nuclei in the central vertex region, and they also have a duration criteria of more than 0.5 seconds, and it is a sinusoidal EEG activity. And this diagram shows the sleep spindles. Here what you see is the sleep spindle. These are the K complex. K complex have a sharp negative wave followed by a positive component. And we can begin scoring in stage if one or both of the following occur in the first half of the epoch or last half of a previous epoch. There should be one or more K complex or one or more trains of sleep spindles. And we can continue scoring epochs with low amplitude mixed frequency EEG activity without K complex or sleep spindles as stage N2 if they are preceded by K complexes unassociated with arousals or sleep spindles. If an epoch following stage N3 does not meet the criteria of an N3, we can score it as stage N2 if there is no intervening arousal and the epoch does not meet the criteria of stage wake or REM. So when to end an N2 stage? When there's a transition to a wake, N3 or R, we can we can end the staging of N2, or when there's an EEG arousal resulting in a transition to N1 or wake, unless the criteria of N2 is met. And if there's a major body movement which is followed by slow eye movement and a low amplitude mixed frequency EEG without any arousal or K complexes, score the epoch following major body movement as N1 if there's slow eye movements. If there are no eye movements, score it as N2 itself. Here, in this epoch, there's an arousal which is happening. And after that, the following stage is N1. But when K complex comes, it is staged as N2 itself. But here, in the next diagram, this is a K complex which is associated with an arousal. So, that also, it comes to N1. And the next K complex is not associated with arousal. So, it is coming as N2 itself. And now about N3. N3 is scored on the basis of slow wave activity. The slow wave activity is of the frequency of 0.5 to 2 Hz seen in the frontal region, and it has an amplitude criteria of more than 0.75 Hz, 0.75 microwatts, but there is no specific duration criteria. But this is an exception to the general rule. Here we can score the stage as N3 when more than 20% of the epoch will consist of a slow wave activity. And here there can be slower, the sleep spindles may persist in N3 also, but there's no specific eye movement which is typically seen in N3. And the chin EMG can be way of variable amplitude, but it would be lower than in N2 stage. Here it is a typical N3 stage. You can see the high amplitude waves. And now to the last stage, that is REM. It is scored in accordance with the presence of rapid eye movements, the presence of a low chin EMG tone, the presence of sawtooth waves, and transient muscle activity. Rapid eye movements, as I said earlier, are conjugate movements with an initial deflection of less than 500 milliseconds. And while the sawtooth waves are sharply contoured triangular waves of 2 to 6 Hz, which precede the burst of REM waves, and it is maximal over the central region. So we can score it as a REM when all of the following criteria are met. That is, low amplitude mixed frequency activity without K complex, the chin EMG should be low, and rapid eye movement should be present. But the dictum is you can score as REM even in the absence of a rapid eye movement, provided the AEG remains low amplitude without K complex and spindles, and the chin EMG tone is low, and there is no intervening arousal, and there is absence of slow eye movements following an arousal or stage wake. This is the stage wake. Here you can see the rapid eye movements and the low amplitude mixed frequency waves, and here you can see the chin EMG. It's almost like a straight line. It's the lowest in that REM stage. And we can discontinue REM when there's a transition to wake or N3, or the chin EMG tone increases, it becomes stage N1. When there's a K complex without arousal or spindle, or the spindle occurs in the first half of epoch with no REM, then it is an N2. Now there's an arousal which is followed by low amplitude mixed frequency waves and slow eye movements occurring, then it is stage N1. Or a major body movement followed by slow eye movements occurring, then it is stage N1. So then there are some epochs which are associated with the major body movement. So when there is a major body movement is a movement or a muscle artifact which would be obscuring the EEG for more than half of the epoch. But here the sleep stage cannot be determined. So if there's an alpha rhythm for the part of the epoch, score as stage W. But when there's no discernible alpha rhythm, but the epoch preceding or following body movement can be scored as W, score it as stage W. Otherwise, score it as the same stage that follows it. Here in this one, there's no discernible rhythm, but the epoch following that was N2, so it was been staged as N2. Now coming to the respiratory rules. Here we need to know some technical aspect. For looking for apnea, we look the oronasal thermal flow. For hypopnea, it is the nasal pressure transducer which is seen. For respiratory effort, the gold standard is the esophageal manometry. For oxygen saturation, pulse oximetry should be used. For snoring, the acoustic sensor or piezoelectric sensor can be used. For hypoventilation, arterial PCO2 or transcutaneous PCO2 or ETCO2 is used. Here for the apnea, we look the thermal sensor, while for the hypopnea, we use the nasal pressure transducer. And how will you look the event duration? How will you check the event duration? It is measured from the nadir of the preceding first breath that is clearly reduced to beginning of the first breath that almost approximate the baseline breath. And for scoring an apnea, both the criteria should be met. There should be a drop in the peak signaling excursion by more than 90% from the pre-event baseline. And when it's a diagnostic study, it should be an oral-nasal thermal sensor. For the therapeutic study, it would be from the PAP device flow, and the duration should be more than 10 seconds. And we can score it as obstructive if there's continued or increased respiratory effort throughout the entire period. And we can score it as central apnea, where there's absent inspiratory effort throughout the entire period, and score it as mixed apnea if the inspiratory effort is absent in the beginning of the event, but it resumes in the later portion of the event. So, here you can see there is an absent flow, but there is continued respiratory effort. So, this is an obstructive apnea. For scoring hypopnea, there should be all the criteria should be met. There should be peak signal excursion drop by more than 30% of the baseline event, and the duration of this drop should be more than 10 seconds, and there is a 3% or a 4% oxygen desaturation from the pre-event baseline, or the event is associated with an arousal. So, this is a hypopnea. There is a decrease in the flow, and there is associated desaturation also. And for scoring it as obstructive hypopnea, any of the following must be met. That is, there should be snoring during the event. There is increased inspiratory flattening of the nasal pressure or the PAP device flow, or there should be an associated thoraco-abdominal paradox during the event. When none of this is met, it can be classified as a central hypopnea. Then there are events as respiratory event-related arousals. These are sequence of breath which lasts for more than 10 seconds, characterized by increasing respiratory effort or the flattening of the inspiratory portion of nasal pressure channel or PAP device flow, leading to an arousal from the sleep. Here you can see that there is a serial decrease in the inspiratory effort, and it will terminate in an arousal. For scoring an hypoventilation, we can score an event as hypoventilation if either of the following occurs. That is, there is an increase in the arterial PCO2 to a value of more than 55 millimeter for more than 10 minutes, and there is a more than 10 millimeter increase in the arterial PCO2 during sleep to a value exceeding more than 50 millimeter of mercury for more than 10 minutes. Then the other event is sky-stroke breathing, which are episodes of 3 consecutive central apnea or central hypopnea separated by a crescendo-decrescendo change in the breathing with amplitude of cycle length of more than 40 seconds. And there are 5 central apneas or central hypopneas per hour of sleep associated with crescendo-decrescendo breathing pattern recorded over 2 hours of monitoring. This is the pattern which you will see. And then there comes the arousal rules. So how can you mark it as an arousal? For scoring an arousal, there should be an abrupt shift in the EEG frequency, including alpha, theta or other frequency, which lasts for at least 3 seconds, with at least 10 seconds of stable sleep which would precede the change. And this would be for the non-REM, but for REM, there should be an associated increase in the submental EEG amplitude to say it as an arousal. So in this one, here there's an increase in there's a change in the EEG frequency, and there's a 10-second preceding sleep. So you can say it as an arousal. But when you come to REM, you should look for the associated chin EMG also. So when there's a change in the increase in the chin EMG amplitude, only you can say it as an arousal. And there are cardiac rules for which sinus bradycardia, tachycardia, the wide complex tachycardia, narrow complex tachycardia, and atrial fibrillation are defined. And there are movement rules in which you score the periodic limb movements. where you see it as a significant limb movement when there's a minimum duration of at least 0.5 seconds and a maximum duration of 10 seconds. And the minimum amplitude should be at least 8 microwatt above the baseline. And the time of ending the peer limb movement is at least 0.5 seconds, where the EMG does not exceed 2 microwatt above the baseline. For saying it as a periodic limb movement, there should be at least 4 consecutive limb movements in a period of 5 to 90 seconds. So this is a significant limb movement. This is what you can see. So with all these things, when you are seen with an EEG like with a polysomnogram like this, you would be confused on what to do. So you can go for a 2 or 3 pass method, in which in the first pass you stage the sleep as a 30-second epoch, and concurrently you stage the spontaneous arousals and look for any cardiac arrhythmia. In the second pass, scroll the respiratory events, and then third pass you can go for the periodic limb movements. To take home, there are rules and examples which are means for identifying the categories, and the definitions from the ASM manual are the rules for waveform identification. And we can develop examples within the subjects and across the subjects for waveform identification. And it's just easy for me to say this waveform within some time, but it takes practice to learn it. And it is practice which makes you perfect.
Thank you, Nitya ma'am, for the enlightening us with the EEG and scoring and the importance in OSA. And the session is open for discussion.
Nice talk, madam. Just want to what is your standardization protocol before you start reading or analyze the event? How will you standardize? What are the manuals you will do before going into the manual scoring?
I didn't get your question.
Madam, there are a few EEG standardization or respiratory plethysmograph standardization. We will ask the patient to
they will ask the patient
like
to
eye blink or eye maneuvers, apnea maneuvers,
apnea maneuvers will be the eye blinks will be the.
And the impedance of the EEG should be ideally less than 5.
Actually, I didn't go much into the technical aspects because this itself was taking some time.
Ideally, impedance is less than 5 kilo ohm, and all the eye blink maneuvers, eye open, right shift, left shift, their apnea maneuver. Manually, we have to say the patient before we start analyzing, and then all the parameters are standardized, their waveforms is perfect. Then only this EEG and other analysis will be very accurate. Otherwise, some values will be, the leads or will be different or not accurate.
That was a nice talk, Dr. Nitya. Is there any way to catch those people who adulterate the epochs with a real OSA patient onto your patient? They do it online or on the gadgets. If your patient doesn't have OSA, they can, the people doing the home-based studies, okay, the company people, or those going for screening, they change the epoch. If they don't have the AHI to their mark of selling the machine, what they do is they add on epochs of a real OSA patient onto your patient. So is there any way you can take up these adulterations?
So that would be difficult. So the only thing is the hypopnea is always a gray area. So marking of hypopnea is somewhere which where we can even for the home-based sleep study, if we get the we have the home-based the level 3 also in the department. Sometimes when I get a doubt on how whether all the events have been captured, I go through it. I go through it and look whether sufficient number of events are there, and we get a fair idea, but you can't be as sure as in a level 1.
Because it's a continuous epoch, So in the real-time recording, is it possible to incorporate additional epochs? I don't think so.
No, they can. Initially, when I started this home-based screening of OSAs, most of the patients are OSA patients, which are not severe OSA, which are really not. So when I take them for the in-lab studies, level 1, all OSA will disappear. So then only I could catch these people who want to sell off their machines with the only printouts of the epochs they incorporate into the normal individual, and they just want to do the business.
Sir, I think in medical college you can have some junior PG to overlook
that. Software, cloud-based titration. The events will be automatically detected, and the pressure will be ups and down based on the this is Bluetooth connectivity and the net connection. The cloud will actually, without in-person manual change, automatically titration can be done. But this kind of yes, sir. Okay. But the adulteration part, even also I was not imagined. Maybe it is your practical experience.
Not mine, company.
But the home-based test showing few patients we had, not now, long ago.
I think if no more questions, we can close down this session. And we thank Dr. Hari, Dr. Mujeeb Rahman, and the organizers and technical team for and VPS Lakeshore for the excellent support and the nice topic selection and the CME. And thank you, Nitya Madam, for the excellent presentation.